Thank you to everyone for joining us today for the Endo Explained webinar session. Dr. Kamal Najat is going to begin with some introductions.
Hello, everyone from around the world. Welcome to Explain. It is a pleasure and privilege to have all of you from around the world. The sessions today are going to be conducted by Dr. Far Najat, and here we are going to set some announcements from Mr. Zoe Pennington from the Worldwide EndoMarch with exciting announcements. It is again a pleasure and privilege to have all of you. Thank you. Ms. Pennington.
Thank you again for everyone joining us today. We have a wonderful panel. And to watch previous webinars, you can visit our website, endomarch.org, and go to the webinars session, to the webinar tab at the top. We also released an app called Najat Endometriosis Advisor, where you can assess your risk of endometriosis. You can download that app for free on Google Play or in the Apple App Store. Dr. Far Najat will be the host of the session today, and we have a wonderful panel. We have Dr. Michael Lewis, Dr. Stephen Paltzer, Maria and Mauricio, and also Dr. Shadi Siraji. So we are very excited for today's session.
Hello, this is Dr. Far Najat, one of the co-founder of the Worldwide EndoMarch. And I would like to welcome everybody from different parts of the world this morning, afternoon, at night. The topic of today's discussion is ovarian endometrioma or chocolate cyst. And briefly, we know endometriosis could involve different parts of the body. The most common area is in the pelvis, and endometriosis could be superficial, or we call it deep infiltrative, and on the ovaries could be superficial and commonly could cause cyst, and this called chocolate cyst because they contain old blood and the color is like chocolate. So that is the reason they call it chocolate cyst. The significance of this chocolate cyst, not only issue of the pain, also the issue of the infertility, and also a small chance of becoming cancers. So with this brief introduction, I would like to first start with one of our patients that she had infertility, and Ms. Maria Zarat, her husband Mauricio, that they share with you their journey of having endometriosis and going through the infertility, and tell us what was their experience. Maria and Mauricio, thank you very much for your time, and we have the podium for you to tell us about your story. Thank you.
Thank you, Doctor. Hello, everyone. We're Mauricio and Maria. We're really happy to tell you our story because it was quite a journey. Basically, what happened was that we were able to conceive, but after 5 miscarriages, it was 3 years of trying to get pregnant. Actually, they never knew that I had endometriosis because they ran a lot of biopsies and everything, and I could get pregnant, but the problem was that I miscarried like around week 6 to 9, so it was a little bit confusing. We went through a natural pregnancy, then IUI pregnancy, and 3 IVF pregnancies, which we were able to conceive and everything. And actually, around the 4th and 5th, they ran a lot of biopsies, a lot of tests and everything, but they didn't know that I had endometriosis. With each miscarriage, they found a lot of things. At the beginning, it was a thyroid problem. Then it was that I needed blood thinners. Then that I needed probably some prednisone, which it could help. The last 2 miscarriages, I needed a lot of IVIG transfusions and intralipid infusions. But once again, we kept miscarriage every time. So on our 5th miscarriage, Dr. Talibian from CCRM, who helped us through all this journey, told us that even though they ran a lot of tests and none of them showed that I had endometriosis, and I never had pain, I never had anything that they could tell that I had it, she told us, I want you to go with Dr. Neshat because there's something going on. He needs to have a look at, and he will tell you if he thinks that probably there's some of it. Probably she was super lost, right?
Yeah, there was a lot of confusion around because we had been testing every week for certain things. We had been, mostly Maria, obviously, but her blood was being drawn every week, and then 47 different samples of X, Y, and Z. So I guess from a dashboard perspective, everything looked like it was okay. So we were running out of options in terms of what the cause could be for the miscarriages. And every time we had a miscarriage, we would circle back and sort of reassess where we were, and maybe it's this. So we would tackle that problem, and then another miscarriage. Obviously, we don't want to get into the emotional, painful side of it because we would never end. But being objective, every time that we would come back, and by the time we had our last one, that's when Dr. Talibian sort of went back to square one and says, well, maybe there's something here that I'm not looking at.
Yeah, and it was weird because when they did the egg retrieval, I had a lot of eggs and great quality, and we had really good embryos out of it. So everything looked like we wouldn't have any problem.
Yeah,
right?
and the miscarriages were happening at a stage where it didn't make sense. So we were conceiving, we were there, and then after 6 weeks, 8 weeks, I think with the further we got was 9 weeks.
Yeah.
So after 9 weeks, that's when things started to go sour. So yeah, we went with Dr. Nisat, and then it was a little bit. I don't know, they found basically the source of one of these sources, because I think we needed to go through all of this because at every corner we discovered something new, and then the last corner we turned, that's when we decided to do the procedure, which was done flawless and fantastic. And for us it was very important to see the result because as we mentioned earlier, we were ready to basically give up in the whole process. So when we heard of a positive outcome in terms of endometriosis, by positive I mean when the doctor told us that some of it was removed from the uterus, from the ovaries, and pelvis and anus, we didn't really know the depthness of it or what this could mean, but at least now we knew that there was another variable in the whole ecosystem that was now tackled and taken care of.
Yeah.
So the procedure was done in October. I think
at the end of October.
The end of October. we went back to the doctor, to CCRM with Dr. Talibian early December. And we found out that, you know, in March that everything was walking in the right direction. And
yeah, basically, it was amazing because Dr. Neshat, as soon as he had a look and he figured a little bit of her story, he was like, I'm 95% sure that you do have endometriosis. But I was, no, I mean, they ran a lot of biopsies. And it was amazing because he was, I need to do a laparoscopy. I'm pretty sure, and I'm pretty sure that everything will change with this. Honestly, I didn't want to keep like my hopes up because after 5 miscarriages, it was a little bit tough. But yeah, like Mauricio told you, we went into the laparoscopy, and fortunately, Dr. Nishat, he was like, you basically could try and get pregnant without IVIG, IVF, anything. I mean, I didn't want to risk anything, so I did all of it. But I'm like, everyone's pretty sure, like, now we have like a pretty big team of doctors, which we're super grateful. But everyone was like, of course, it was what Dr. Nishat found. 1 month and a half after the surgery, we were able to conceive again, but this time our baby girl is 1 month old, like after 3 years, almost 4.
Thank you very much, Maria, Maurizio. We are so happy for you. And it is a teamwork with Dr. Talibian and of us, of course. You'll be persistent, and we are very happy for you and we wish you luck. And at one point, I'd like to see the photo of the Manuela.
Of course, I'll bring her.
So if you don't mind to stay around, so we come back later on if you have any more comments to share. Thank
oh,
you.
Yeah,
please,
sure.
please, we'll be in the background, doctor. Thank you, guys.
Oh, thank you. So now we go with Dr. Steve Palter. Dr. Steve Palter is one of the known infertility and reproductive endocrinology physician from Gould IVF in Long Island. And I have had pleasure to work with him for many years. Very scientist, and we share a lot of patients together to discuss with us about his view of the endometriosis and endometrioma and infertility. Steven?
Thank you so much, Far, and thank you to the organization, you, Cameron, Sina, for inviting me to speak today. It's an honor to be here with you. And thank you, Maria and Mauricio, for sharing your story. I'll try and expand on it from the medical perspective a bit. And I have a unique perspective in that I'm currently the medical director of Gold Coast IVF in New York. Prior to that, I was the clinic chief at Yale University, but I trained both in minimally invasive surgery and was part of the Endometriosis Center and the Laparoscopy Fellowship, but also did basic science on endometriosis and also clinical infertility and IVF. So I have the perspective of both the surgeon, the fertility doctor, the IVF, and the scientist that hopefully I can bring to it. And the one thing that I would say that's really important for patients to know is that not all cases of endometriosis are the same. It's a very enigmatic disease. How it grows and where it grows and how it affects fertility is different in every woman. So one of the dangers of reading blanket statements or articles by people who are experts is if they're looking at just one part, like the blind man looking at the elephant, you see the ear or the tail, you'll get a very different perspective. So you can have some people that have endometriosis that's mainly structurally damaging, others that are mainly inflammatory, and others that are a combination. And then the pain comes into it as well. So my take-home message is that treatment must be individualized, and it is different in every patient. 3 things that are important when we talk about endometriomas. So cysts of endometriosis is what Far and the group asked me to talk about today. When you see a cyst of endometriosis on the ovary, one of the big controversies in reproductive medicine is, how do you treat that? Do you have surgery? Do you do IVF? Do you do both? And if you do both, in what order? And so 3 crucial things to individualized treatment that I think you have to know is, 1, what other factors are present? Make a full diagnosis. Sometimes people at some infertility centers will jump to the first diagnosis and that's it. So they'll say you have endometriosis, but they haven't fully evaluated the tubes, the uterus, the sperm. And if you're treating it in a vacuum, you're wrong. Or as you heard with Maria and Mauricio, they're told it's unexplained infertility and unexplained loss, but endometriosis is a portion. And one of the failings of many IVF centers is they think that IVF just automatically fixes everything, and they don't try and diagnose endometriosis. So we have pelvic exams, ultrasound, and the history of pain or with intercourse or periods are vital clues of endometriosis that's often overlooked. The size and the extent of the disease will affect how the patient is treated. So one woman who has no signs of the endometriosis except for her infertility will be treated differently than a woman who has a very large golf ball or tennis ball sized endometrioma cyst. And what are her symptoms? How bad is her pain? So you heard the story from Maria about this. Far and I have treated patients where they've had devastating endometriosis and the IVF was not going to work until it was treated. There was one case I remember that we did together where the woman was going to the ER every month in agonizing, debilitating pain. She did IVF multiple times that failed, finally came to me in desperation, thinking that she needed a surrogate and an egg donor. And what I saw was that her fallopian tubes were blocked and filled with blood from the endometriosis and also her ovary. And when she had her transfers, her uterus was filled with blood. I actually called her IVF doctor and said, how could you do this? There was no chance it was going to work. And they said, well, this is inoperable. So it was the best we could do. It may have been inoperable to them, but there was another expert that could treat it. And if the disease wasn't treated, that IVF wasn't going to work. And Far and I, we worked on this. It was a huge case. And in our first IVF, it was successful. Another very personal case for me was when I was a professor at Yale. My mother had an incidental ultrasound postmenopausal, and they said, oh, you have a little cyst on your ovary. So I said, oh, just send me the ultrasound and I'll look at it. And I said, that looks like a malignancy in an endometrioma. And lo and behold, it was. And her doctor was going to ignore it. So you have to really look, what are the symptoms? What is the patient's whole picture? And does the endometriosis need to be treated? And a huge factor is how many children does that couple want to have and the time frame to pregnancy. So how do we triage between surgery and IVF? Well, here's some big misconceptions that you need to know to make your decision. One, the main effect of endometriosis in most people is on the egg. Now, this is not a blanket statement. So Maria, what you heard was she had good eggs, but it was on her endometrium and implantation. But if you look overall, we now know that the biggest effect is on the eggs. And that came from studies where they used egg donors. If the egg came out of a woman who had endometriosis and went into a woman who didn't have endometriosis, the success rate was lower. If the egg came from someone who didn't have endometriosis and went into a woman who did have endometriosis, IVF usually bypassed it. So the main effect was on the egg. But then we found that you got less eggs and the eggs were often of not as good quality. So that's the main effect in endometriosis. So surgery initially was done on everyone trying to get rid of these cysts. And then danger reports came out that when you take out the cysts and strip them, you damage what's called the ovarian reserve, how many eggs remain in the ovary. Well, the confusion about this is 2 major things. Not all surgeons are the same. So one surgeon does a very minimally damaging surgery with a careful technique, and another can burn and destroy the ovary and leave the woman in menopause. So surgical technique is important. And then a landmark group of studies came out showing that endometriomas themselves damage your egg supply and your ovarian reserve. So untreated endometriomas even damage your egg supply. So it's not just the surgery, it's the endometrioma themselves. So why would you take it out before or not? Well, the risk of doing the surgery is if the surgeon's skill is poor, you're going to harm the ovary. The cost, damaging the ovary, and delaying time to IVF and having an invasive procedure if you don't need it. On the flip side, there's risks of doing IVF right away. the disease gets worse. The woman can go into menopause, or her endometrioma can rupture. There's inflammation. You can have a failed transfer like Maria had. You can have infection, cancer, rupture, or poorer eggs. So the take-home message that we use clinically when we individualize it is if the woman has debilitating pain and other symptoms or fluid-filled tubes, the surgery has to be done first for life quality and to make the IVF work. If we can't get to the eggs because of the size of the endometriosis, the endometrioma, then surgery will need to be done first. If we're afraid that the cyst is so big, often more than 4 centimeters, that ovary is going to become damaged over the lifespan of the woman, or if she has a lot of pain, or if she wants multiple children and we're worried about the ovary getting damaged, and especially if she's younger, then surgery becomes better. And one of the dangers is, just like there's not skilled endometriosis surgeons, there can be less skilled IVF surgeons who can pass the needle through the endometriosis, spread it, rupture it, or it can even get infected. So my take-home message is, what's remarkable today is almost most patients with endometriosis now, between surgery and IVF, will take home a baby. That wasn't always the case. But women suffer with endometriosis, with pain and infertility, horribly. You need to make that correct diagnosis. You can't just tell them, oh, ignore it, take some Advil, it's in your head. This can be a debilitating disease. And then you individualize for that woman. Is the treatment not working? Change something, fix the disease. And is it big enough that it's going to interfere? And then you triage individually, IVF first or endometriosis surgery first. Or I think that's, I don't want to take more time, but that's my endometrioma worldview in a nutshell for you. And thank you so much for having me here.
Thank you very much, Stephen. We will come back to you, hope you don't mind, after we talk to Dr. Lewis and also Dr. Siraji. You mentioned that the surgery has to be done properly with endometrioma and not to decrease the ovarian reserve. Dr. Lewis, I know Dr. Lewis is a co-director of the chair of his department, and done minimal invasive surgery fellowship with Dr. Cameron Najat, and he's the director of minimal invasive surgery in the hospital. Michael, please tell us your experiences. How do you approach endometrioma, treat them? Because it's actually in the chat, one of the questions is one of the patients to remove the endometrioma. How do you remove it? What type of endometriomas do we have? Thank you.
Thanks, Dr. Farr, and thanks, Drs. Najat, Sina, and Cameron for inviting me. Dr. Palter, also excellent description and in a nutshell describing everything that really a patient should take home from this. I think, so 2 things that you really pointed on to. Number one is early diagnosis. You know, a lot of the times we have the patients who, if it's not from a fertility perspective, it's the patients coming to the surgeon or a gynecologist for pain. And early diagnosis to get that patient some imaging and, you know, the possibility, if they had failed medical management, to get a diagnostic laparoscopy. But the thing is that, you know, most times, and again, like the story with Maria and Mauricio, is that they did all these tests, they did all this imaging, they didn't see anything. Well, then what happens when you do have a patient who comes to you with that ultrasound showing not a 10 centimeter endometrioma, but a 3 centimeter endometrioma or a 2 centimeter, and they have some suspected pain? What do you do at that point? Do you go ahead and treat them right away? And it always depends on the patient's age. We know that endometriosis is a chronic and progressive disease, and if we don't tackle it from a multidisciplinary approach, this is just going to come back and it's going to get worse. So if we do have, for instance, we have this patient with 3 to 4 centimeter endometrioma, she does have clinical pain, she has failed medical management. Okay, so then what do we do next? In terms for the surgery itself, the best approach, instead of doing a laparotomy or an open incision, is to do something that's minimally invasive, obviously, to decrease the chance of adhesion formation, decrease use of post-op pain meds, and quicker return to their lifestyle, because the whole goal is to improve their lifestyle, but also protect their future fertility. The thing that is, again, what Dr. Palter had mentioned, having a surgeon who can carefully dissect that endometrioma while preserving the ovarian tissue, because the eggs are on the outside of the ovary, on the cortex, and as soon as you get into that ovary, and different surgeons have different tools that they can use. They can use just sharp dissection with the scissors, but there's also a lot of other tools that use cautery, which can cause a lot of scarring, a lot of burning to the ovary. And so you may think that you've had surgery with a surgeon that comes out and says, I got it all, I burnt it, it's gone. But what really they did is that they may have gone in the endometrioma, but they have completely destroyed the ovarian tissue, and in that case, decreased your ovarian reserve. So me specifically, what I've been using, and this is from, again, with my fellowship training with Dr. Cameron and having exposure to a lot of different instrumentation, I use, for instance, for me, I use an instrument called the PlasmaJet, which again is using a bipolar cautery, but this will decrease if I have to use it, in which I try to use it as minimal as possible. I have less thermal spread or less damage to the ovary. But the main objective when they're taking out the endometrioma is to actually get that cyst wall. If the surgeon were to open up the ovary and just drain out the chocolate fluid or the cyst contents and just leave it behind, and then saying, oh, I didn't damage the ovary, I still preserved it, but I drained it, that cyst is just going to come back and you haven't done anything. You have to take out that cyst wall. And it's very important that you carefully dissect it without damaging the rest of the tissue. So for surgeons, it's very difficult in terms of being able to take out the contents, take out the cyst wall while maintaining that ovarian tissue. And so it comes down to the point where, again, you have to have a surgeon who's experienced to do it, understanding to use minimal cautery, if anything, try not to use any at all, while preserving that tissue. And Dr. Farr, remember it was I believe it was Fertility Sterility, that paper back in '94 describing the different types of endometriomas that exist and how they form, and understanding how it, in cases where it invaginates into the ovarian tissue and will make it not almost impossible, but almost taking piecemeal little portions of that cyst wall out. And it makes it very difficult to do, but you need to be careful. And as a surgeon, you have to take your time to dissect it and get that cyst wall. Otherwise, you're just going to be back there several months later with the patient saying, my symptoms have returned or my cyst has come back. So I think it's extremely important that, again, like I mentioned, careful dissection, minimal cautery, taking out that cyst wall. These are extremely important when dealing with an endometrioma. And aside from that, one of the things is that, getting to the patient to the OR, and one of the things that I see all the time is that we have a patient who's scheduled for surgery, but they end up in the ER multiple times, or before I've even seen them for consultation, they've ended up in the ER for multiple times. Rule out ovarian torsion, rule out ovarian torsion. That's the common theme that they always think that the patient has in these cases. But it could be that there's a type of inflammatory response. The endometrioma is leaking. I mean, what we see 99% of the times is that endometrioma is stuck. It is fixed onto that side wall of the pelvis, and it is not moving anywhere. And, if, again, the emergency department, doctors who then send to other gynecologists, they have to understand that this is more likely an endometrioma, send it to a specialist, and get them to someone who can operate on them, and, again, take out this cyst without damaging that ovarian tissue. I think I just see it over and over again. And we have, as a laparoscopic surgeon at our hospital, and I train, I have the privilege of training residents. If you don't know what to look for, you're not going to see it. Unless, when I look back at my training in residency, and we didn't have any specialists in endometriosis, we didn't have anyone who could point out the different colors or what it could look like besides the endometrioma. And endometrioma sometimes could look, you can't miss it, but things that are around the ovary, things around the tubes, the uterus, the ligaments, you need to have that experience to do that. And you need to have gone to the proper training in order to properly excise it. And without it, you're left with ending up having someone who's going to take you to the operating room, damage your ovary, claim that they've actually got, they've taken it, and they've sort of, again, delayed you from then either achieving an improvement in your quality of life or continued infertility.
Thank you very much, Dr. Lewis. for excellent description of the surgical technique and other aspects of endometrioma. In the same line that you and Dr. Porter described the way that endometrioma will present. Dr. Siraji, that she did a fellowship with me, and now she is the faculty of NYU Long Island Hospital. She actually did a research and looking at the presence of the endometrioma, the size, and the stages of endometriosis, because unfortunately some infertility specialists, they say if the endometrioma is less than 4 centimeters, may not be important, and then the patient could try to get pregnant or not do not surgery. But they ignore that this endometrioma could have patient had endometriosis somewhere else. And if we believe that the stage of endometriosis affects the infertility, we should know the size or the correlation of the size and the stage of endometriosis. And she did this research, and I'd like her to briefly tell you about her finding. Dr. Siraji?
Hi, everyone. I'm Shadi Siraji, prior fellow of Dr. Nejad. I had the pleasure of working with him for the past 2 years. Learned so much from him. Thank you, Dr. Nejad, for whatever you taught me. Our research was, we did retrospective research. 222 patients were chosen. They were all operated by Dr. Nejad for endometriosis, and they all had endometrioma. When we look at the sizes, all the patients that they had endometrioma, regardless of the size of the endometrioma, they all had either stage 3 or 4 endometriosis. So we proved that even the endometrioma is a small size, still the patient could have endometriosis anywhere else in the pelvis, and of stage 2, stage 3 to 4. So many surgeons or so many GYNs or REI, they believe that if the endometrioma less than 3 to 4 centimeter, leave the patient alone. But if the patient has infertility, we prove that the patient could have a stage 3 or 4 endometriosis. So we better consider that. And also the size of endometrioma did not correlate with pain in patients. So the patient could have stage 3 or 4 endometriosis and still with no pain.
Thank you very much, Dr. Siraji. One of the, as Maria and Mauricio mentioned, the unfortunately patient not being diagnosed and being ignored. And I'd like Dr. Siraji to share with us her recent experiences that she has had, that she has seen some patient come to her and have had pain and they have been ignored. Dr. Siraji?
As Dr. Nejad mentioned, I recently started practicing. In my residency, I didn't have any formal training regarding endometriosis. I knew endometriosis, but we didn't have any faculty who were specialized in endometriosis. When I had the training with Dr. Nejad, I learned so much about endometriosis. Now going to my practice, I always ask every patient, even if they're with me for another reason, ask them about the menstrual history, every history, and if I'm suspicious, then I start asking, dig in. And the patient don't always voluntarily share with you all this information. Last week, I had 3 patients, 3 young girls in their 20s, and they all had endometriosis, suffered for years with menarche from endometriosis, and everyone, they've been in other GYNs, I think they were undiagnosed, and they were told that, oh, this is normal, the pain that you're going through is normal. And 2 of these patients, they told me that, oh, my mom and my grandma, they went through the same thing, and we were told that this is normal. it's sad, and I'm happy that I had the experience with Dr. Nejat, so I know how to diagnose and how to help these patients.
Thank you very much, Dr. Saraji. Maria and Mauricio, I'd like to ask you, if you don't mind, one question. If you know you have gone through this journey, and fortunately, Dr. Telebian, excellent physician, refer you to us, and we took care of you, and you got pregnant. What messages you could share if you tomorrow meet a couple that they have got the same experiences and they didn't get pregnant? What do you have to tell them?
So I would tell them that one, chemical pregnancy is normal, unfortunate, but normal. But two, miscarriages or chemical pregnancies are not normal, that they would need to step it up a little bit. They will have to have a look. For me, if I would do it all over again, I would probably have a look at endometriosis a little bit sooner than when we did, right? I think it's important for me to say that I didn't have any pain at all, that I was regular on my cycles. And unfortunately for me, the way that I found out that I had was 5 miscarriages and almost 4 years later. So I think that, like, women shouldn't wait that long. And it's, yeah, basically it's amazing that after almost 4 years, 1 month and a half after the laparoscopy, I was able to conceive, and 9 months after, give birth finally. Like, so for me, that will be, I don't know what.
Yeah, just to build up on what Maria said, I guess that I hope that people don't have to go through trial and error, because the error has a lot of value, sentimental value, and economic value also. So I would really encourage people out there to take control of how they think they're gonna start whenever they start thinking about reproductive cycle. And definitely this should be step one, honestly. People talk about Planned Parenthood, people talk about how to make the most out of your life, but whenever you're thinking about evolving as a family, definitely redefine your step one, because you get it right from day one, you can really save yourself a lot of unnecessary turns or painful ones.
Yeah, and I don't think that it's gonna take them, like, I mean, I went through 4 biopsies, like, without anesthesia, without anything. And you, doctor, I mean, I didn't go through any of that for you to know that I had it, right? So it's worth it just to have a look, just to see, like I was saying, like, 1 chemical pregnancy is okay, 1 miscarriage, it happens. Like, everything has a timing and everything, but 2 or 3, that's not normal. So
Far, if I could add, that's really important what you guys just shared. And an important message is that not every physician is going to make the diagnosis the same way or do the same tests. So people often come and say, I've had everything done, I don't have this or that. And the panels of diagnostic tests, or even the interpretations, vary greatly. You could go to a mechanic to get your car fixed because they hear something rattling and they replace the wrong part 10 times until you find the right one. Who knows? So we've seen people who have endometriosis on ultrasound that's been ignored. And if you have unexplained infertility, sometimes you need to look deeper and it's endometriosis or another disorder. Or if you're doing cycles of IVF and it's not working, don't just repeat the same thing over and over. Dig deeper and get a detective to figure out there's always a cause. You just haven't found it yet.
Correct.
Totally. Yes. Yes.
Thank you very much, Maria, Mauricio, and Dr. Poulter. So I just want to summarize this, so what we have learned so far, that endometriosis is a very enigmatic disease, and the only way to diagnose is to think about it. And if you have infertility and you have done all of the work and has failed, ask your physician that could be endometriosis. And don't be satisfied by only saying, oh, you don't have any pain, because as you saw, Maria didn't have any pain and she had endometriosis. Or we did the ultrasound and the ultrasound didn't show endometriosis. So these are not adequate. As Dr. Poulter mentioned, you have to individualize each person. You have to find a physician to listen to you and go over every details. And you also participate in your health and tell them about your history. Like Maria, I had this miscarriage, but Maria exactly says it's one miscarriage, one could be accidental, but 2 or 3, there's something wrong. And then pursue it. And then find the right physician. I am an oncologist, and we spend a lot of time training, 3 years of fellowship, sometimes 4 years of fellowship in cancer. But unfortunately, we are not training enough physicians to properly evaluate the patient for endometriosis, which is at times actually more complex than cancer. And then when it comes to the treatment, also find the right physician to treat, to diagnose endometriosis, treat endometriosis properly, because endometriosis could sit on the bowel, on the bladder, the ureter, and a lot of physicians shy away from tackling them, maybe rightfully, because they should not do it because they could create complications. They could get to the bowel or cause complication. So you find the right physician, it is important. And when it comes to the ovaries, also, I just briefly mentioned that unfortunately, a small percentage of this ovarian endometrioma could become cancerous. There is a questions on the chat that you use birth control pills for treatment of the chocolate cyst. At the present time, the only effective treatment for chocolate cyst is surgery. We do not recommend any kind of hormonal therapy that before treatment of the removing the endometrioma. That is period. That is very clear because, as Dr. Poulter mentioned, endometrioma itself could chew the function of the ovary. So the sooner you remove the endometrioma, even if you don't want to get pregnant, you save the function of the ovary. So this endometrioma, it is 2 centimeters, 3 centimeters, 10 centimeters, has to be removed. Not only to preserve the function of the ovary, because some of them could become malignant. And also it has to be removed, sent for pathological evaluation to be sure there is no ATPO, we call it precancerous condition on that ovary. Now, after the endometrioma is removed, that is different story. After endometrioma is removed, if the patient wants to get pregnant, that is the best time for her to go back and get pregnant. Again, we believe you have to work with a multidisciplinary approach. I am not infertility specialist. I do the surgery, and immediately I will send my patient, Dr. Poulter, Dr. Talebia, all the colleagues that they have referred the patient to me. And I tell them, you have to hurry up. Even if you are not ready to get pregnant right now, you may want to go and do some egg freezing. So frequently we consult our patient to have egg freezing. If they have partnered with embryo freezing, to transfer it later, because unfortunately age is against the patient. So that is important to work in a multidisciplinary condition. After the surgery, if the patient doesn't want to get pregnant, then yes, we put the patient on low dosage of the birth control pills. They could tolerate it, because we have published this paper, as Dr. Lewis mentioned, that original of the large endometriomas are ovulation. And because endometriosis interferes with the function of the ovary, and this corpus luteum, or the ovulation cyst that's supposed to disappear by the end of the month, would not disappear. And that by time this becomes endometrioma. So if you put the patient on suppressive therapy, in a kind of the hormone that suppress the ovulation, and follow that patient, she would not form the endometrioma. And that has been our experience for many, many years. And this is what we advocate to do. So that was on the chat. There was a patient had asked that she had endometrioma and may not be treated properly. As Dr. Lewis again mentioned, you have to, and Dr. Palter, you have to identify the cyst. The adhesion has to be lysed and properly take care of the endometriosis to not only treat it properly, also decrease the risk of coming back. So one issue is that sometimes the patient asks about the cancer. Fortunately, the risk is very low, but we always recommend, if there is any endometrioma and has to be followed by the ultrasound and MRI, if you don't want to operate. I guess, as I said, our philosophy is that endometrioma has to be removed no matter what size it is, and treat endometriosis other area. As Dr. Siraji mentioned, our research shows any patient has endometrioma, no matter how big it is, this patient have a stage 3 and 4 endometriosis and has to be completely treated to decrease the chance of coming back, to decrease to helps the pain and also infertility.
Mark, can I add one thing? It's important that you made me think of. There's a big trend in a lot of IVF centers now to just use a blood test to try and diagnose endometriosis if a cycle has failed, and then they use medications to treat it. And this is not as accurate as a diagnosis as surgery, and it is not the same treatment. And especially if there's an endometrioma, there's, just as you said, Far, there's no medical therapy that's going to address an endometrioma. But this is a trend from a lot of centers where the IVF doctors don't have experience with surgery. So when you talk about the multidisciplinary approach, a good question that someone can ask their doctor is, how often, when you see a patient with endometriosis in your IVF center, how often do you do IVF and how often do they do surgery? And if the answer is 100% of either one, then it's not right. There should always be an individualization and a combination.
Thank you very much, Dr. Parker, bringing this issue up, because frequently we see patients, I'm sure you see it too, that a lot of IVF physicians, they, in spite of endometrioma, they proceed with the IVF. Dr. Lewis, you mentioned that one of the possible side effects of the endometrioma could be infection. Can you elaborate in that topic, that sometimes the endometrioma could get infected?
So there's like two different scenarios, and I've had experiences in cases where patients have developed an abscess in an endometrioma on itself, but then also, like, we usually have, I think it's one case every maybe 2-3 months, presents to the emergency department having undergone egg retrieval and had an endometrioma and came in with an abscess that had formed within that endometrioma. And that could be, I mean, again, every case is a little bit different, but it could be a surgical nightmare for that, for both from the surgeon's perspective and also for the patient, because the fact that that ovary now is infected and has become an abscess, it is extreme. It's number one, it could be life-threatening to the patient, where the infection can spread throughout the body. And in a lot of cases, when you have a tube ovarian abscess secondary to an endometrioma that can get infected, most times you have to try to drain it with IV antibiotics. And if that doesn't work within, if the patient doesn't have a response, then you have to go in surgically to remove it. And those cases have a very high chance of having complete removal of that ovary and tube on that side. And so these are some of the risks of having an endometrioma that can sit and grow and get bigger and larger. And again, the fact that, an endometrioma, can happen, you can have an endometrioma with stage 1 disease or stage 2 disease versus stage 3 and stage 4. Having an endometrioma that is associated with a later stage of disease, 3 and 4, involving your intestines, your tubes, your ovaries, that makes it even more difficult than surgically to remove it, where you have a much higher chance of recurrence. As I mentioned before, we try to meticulously remove that cyst wall. Otherwise, the recurrence rate is going to be a lot higher. And I think someone had mentioned that in the question and answer about having a laparoscopy, the cyst was told to be removed and it came back right away. Again, it depends on the stage of disease that the patient had, the experience of the surgeon, because again, the more complex or other things that are happening inside the pelvis at the same time, it can make it a lot more difficult to resect the ovarian cyst wall completely. So it goes back to, should we remove the endometrioma? And again, as you mentioned, we should be removing all of them in the case of patients are going to have IVF and you may have an infection that happens. I mean, these are some of the things that need to be explained to a patient prior to undergoing an IVF cycle with an endometrioma, because if they don't understand those risks of it happening or don't understand the consequences of having an infected endometrioma and then losing that ovary, then, from a psychological aspect from the patient, I mean, this is detrimental to them.
Michael, that's so important that you said that, because when we do an egg retrieval, the needle goes through the vagina and the vagina has bacteria in it. And if that needle enters the endometrioma, you're introducing bacteria into a perfect closed space for it to grow. And, thank God, I'll knock wood, in 30 years, I've never had an infected endometrioma from an IVF cycle. But if I think my needle is going to have to hit that endometrioma to get the eggs out, I'm going to want that patient to, in most cases, have it removed beforehand. And I'll map the endometrioma to make sure when I get the eggs, I don't get through it. But I know some people just put the needle through it or even try and drain the endometriosis vaginally. And that's when those complications, I think, will go up. And that, you're right, that should be something we try with everything to avoid.
Right.
Thank you very much, both. That is very important points that when you, if a physician, I have seen frequently that about to send the patient, even he calls me, he cares about his patient so much that he picks up the phone and says, "Paul, I cannot reach this ovary without getting to the endometrioma."
Right, yeah. Get it right.
He calls me, he said, "Paul, I mean, you should go and take this endometrioma out," because he doesn't want to get to the endometrioma. And exactly, he doesn't want to have the same scenario that happens to Dr. Lewis.
No one should lose their ovary having an IVF for endometriosis. That should be once in a lifetime that you see that.
And then in the chat, there is some question that can you distinguish between the functional cyst and endometrioma? I think you agree with me, if you have your experience, infertility specialists could distinguish between the functional cyst and endometrioma. And there's another question in the chat that the infertility specialist recommended to aspirate the endometrioma. No, we don't. Definitely, we don't recommend to do that one, because not only a chance of the infection, as was mentioned, it's right, we come back.
It's going to come back in a month.
And also a small risk of the cancer. I have had patients that actually we reported the case that the patient had few cycles of the IVF and had that cyst that had cancer in it. And finally, she came to us and we fortunately took care of the endometriosis, took care of the cancer, and we saved the ovary, and she went back and she got pregnant and had successful pregnancy, fortunately. So to answer the question on the chat, no, aspiration is not good. It could distinguish between functional cyst and endometrioma and has to be properly treated.
One of the reasons why some IVF centers will say don't operate on endometriomas, because they'll say that the ovarian reserve will drop. And you can measure that with a hormone called AMH. But as I mentioned earlier, the study said that if you have an endometrioma and you don't do surgery, it can drop as much as 25% within 6 months. So the fear of damage to the ovary doesn't come just for surgery. It comes from the endometrioma also.
Thank you very much. So we are getting close to the end of the talk. Dr. Siraji, you have a last comment? Or then you go to Maria and Michael and Steven. Dr. Siraji?
No, thank you. Thank you for having me.
Thank you very much. Maria and Mauricio, do you have a last advice? First of all, I would like to thank you, both of you. But do you have any last comments for the session?
No, basically, like I was saying, I would like to encourage the couples that have been struggling with fertility to don't wait too long, or don't wait for an awful experience to go and check out whether or not they have endometriosis. It's once you have had it, it's pretty common to get to know women that are like aware of everything about this.
Yeah, and trust the process, I guess. It's doctors know what they know. Unfortunately, with endometriosis, you as a patient, you're operating in a black box. So talk to your physician. It's there, it happened. We had 2 out of 5 or something, I don't know, but it was there. And whenever it was removed, things started to work. So obviously, I want to thank all the doctors that helped us get this process, and it's worth it. So hang in there, guys, and definitely try your best, because having a baby it's such a blessing.
Thank you very much. Thank you very much for all the panelists. Towards the end of the session, I will ask Dr. Kamran Najat. Actually, he's in the airport. He's flying to Africa to do some charity work and to give the last talk. Kamran?
He is in the airport, so I will say a few words for him. Please be sure to follow EndoMarch on TikTok, Instagram, Facebook, and Twitter to stay up to date on all of our news and announcements. We have a lot of exciting things planned for the 10th anniversary. That will be in March of 2023. So make sure you follow us there to stay up to date. Thank you again to everyone for joining us today. It's been a wonderful session. I'd like to thank the host, Dr. Farnajat and Dr. Kamran Najat, and all of the panelists, Dr. Siraji, Dr. Palter, Dr. Lewis, and of course, Maria and Mauricio for sharing their story as well. We will have another session next month, the last weekend of October, so make sure you register for that one.
Thank you so much.
All right, have a beautiful weekend. Thank you very much.
Thank you for doing this.
Bye-bye.
Thank you.
Good morning. My name is Marion Smith, and on behalf of the Worldwide EndoMarch and the American and Global Congress of Endometriosis Subspecialists, I'd like to welcome Saili, joining us from Mumbai, India, to talk about a topic that is very dear to both of our hearts, endometriosis awareness and advocating for this debilitating disease. Good morning. How are you?
Good morning, Marianne. Thank you so much for such a warm welcome and giving me the opportunity to join you. I'm fine. So yes, if you allow me, I would like to proceed with the things that I would like to talk about endometriosis.
Absolutely. If you don't mind, just start us out with a little bit of background on your experience with endometriosis, your personal journey.
Okay. So just to start up with the background, I would like to mention that currently I've just completed my master's in psychology, and I would like to say that majority of the inspiration towards this was drawn from my symptoms associated with endometriosis and the negative impacts of that I had to face as an individual in my earlier stage of life. And I got to know about Worldwide EndoMarch, wherein I was in initial school days. And then I had just into my first year of university, and I was facing a lot of like these comments that we all get during we have the journey of endometriosis, like not having a definitive diagnosis and having experience of symptoms while navigating through your personal and professional life. Then I just discovered what endometriosis is, because there's a lot of information on Worldwide EndoMarch website itself, for anyone to just go there and read there for the first time. Then I wrote an heartfelt letter to the team that I would like to be the part of this initiative. And I also wrote a poem. And that was the very first time wherein I got in contact with the administration, and they appreciated my poem and added that. After that, I this gave me an inspiration to make my own Instagram account and put a little awareness post which are well researched and medically written. I don't belong from a medical background, but I was always aware about the right information to be put there. So, and I also had read the importance of this again on the page of Worldwide EndoMarch. Like there's like quantum of information and misrepresentation of information as well. So yes, with all these things in mind, I started the journey of raising awareness at a very local level. And then again, when there was this EndoMarch that was happening globally, I contacted the team of Worldwide EndoMarch, and then they allowed me to put forth whatever I was doing in the entire year and present my normal awareness events that I had done locally, and also the posts that I had shared. After that, I moved to Glasgow and I was pursuing my master's in psychology. And then I got an opportunity to do my dissertation on endometriosis, wherein I chose a topic to explore the impact of symptoms of endometriosis and how it impacts on oneself and identity. And then in this, it was an interpretative phenomenological analysis employing qualitative research methods. I interviewed two individuals and then I got a rich data out of it. And then there were 5 overarching themes which emerged out of that. To just briefly state that, I would just like to just roughly mention the themes, which says that symptomatic complexity and external judgment impacts self-image of an individual. The second theme also says that sometimes individuals feel that they are stuck in a vicious cycle of this standstill because of their symptoms. So it's like it's a classic experience that if any one of the individuals who is on their journey of getting a diagnosis or have been misdiagnosed or underdiagnosed have experienced this, that our life goes on and then we get the symptoms around our period cycle, menstrual cycles, then we feel that the life has gone to a standstill because of all the things that we can't do suddenly. And then again, we resume back, because there's no definitive treatment, but we all take curative measures to it. Then the third theme was navigating self-identity amidst diagnosis. There were instances wherein the participants shared that they had questions on their self-worth, their self-image, and how good are they, how valuable are they. Sometimes people questioned them, their integrity. They were seen as someone who have, who are very sensitive, or they have less pain threshold. So all these things were also talked and discussed under these themes. And then there were other themes like late detection and then advanced presentation. So after all these themes, I wrote an analysis wherein I proposed a combination of two models to be used to understand and design an intervention strategy that can help to, better effectively implement it in an individualistic and holistic perspective. And the two models that I proposed was the biopsychosocial model by Egnell and just a second, the biopsychosocial model and the ecological system theory. Sorry, I wanted to get the name right. That's why. In this thing, so the biopsychosocial model, to talk in a very crux and normal language that everyone can get it, it allows us to have a more holistic view towards an individual, which gives us a picture that an individual is affected by the biological, psychological, and social setting around us. So instead of a conventional biomedical treatment way, biopsychosocial model helps us to give a more integrative and holistic intervention strategies. And when this model club with ecological system theory allow us to actually so according to ecological system theory, there are 5 layers, that is like a micro, meso, exo, chrono, and macro. So basically these layers are basically different layers of contact wherein an individual comes into contact. Micro is the immediate stakeholders, meso is the interaction between these stakeholders and the individual faces, and then exo environment is the indirect environment. Macro system is the social and cultural context, and chrono system is the overall time duration that an individual goes through. So after combining these two models, we come to a very integrative understanding that, say, for example, if I am an individual and I am navigating through an healthcare setting, so my primary healthcare center will be coming under my microsystem, under my physiological, biological aspect. So when we see an endometriosis intervention through these two lenses, combining them, it actually gives us an overall picture as well as, an in-depth picture at the same time. And we can put in interventions based on these needed as needed, and also design individualistically. And then since it can be changed, since it acknowledges different culture, different boundaries, so it has an generalizability, and this can be used all over the globe. So this was the little study that I did, and since I was having a limited time and limited data, it was very limited to 2 individuals. But yeah, this was it that I did. Yeah.
Well, first of all, congratulations on completing your master's degree. I know that's a big feat in and of itself, especially like you said, with that vicious cycle, for lack of a better term, that we who suffer from endometriosis go through. There's times when you feel great, and then there's times where you're not feeling so well. And when you're going to school or working and trying to have that work-life balance, and you're not feeling well, it can really exacerbate going to school compared to someone who's in the same program that maybe is not suffering from this condition of endometriosis. So congratulations on that. And it sounds like your passion for endometriosis awareness, really you brought it into your academic field, and this research is going to be very valuable. And I can tell you, just from the anecdotal interviews that I have done with so many women like you and myself who have suffered from endometriosis, it sounds like your findings go along with what I'm hearing just in general. And now, with regard to the medical care of endometriosis in Mumbai, in the area of India that you reside in, how have you found it to find medical care that is quality and knowledgeable of endometriosis and treating it?
Thank you so much for acknowledging my research and all the compliments that you gave me. Talking about your question, so I have always felt that I was an individual, even though I did not know anything about endometriosis, but I was an individual who belonged to a substantially medically aware background. So I was so that actually distinguishes me from other people who are, who might not know where to access healthcare and in what way you are supposed to go there. So my perspective will have that benefit of it. Uh, yeah, but overall, if you say, I will say that healthcare services over here are primary healthcare centers are very much accessible, but the knowledge that a physician has at the primary health center might not be of one that endometriosis specialists have. So there are chances that things might get misdiagnosed or like not acknowledged at the right time. So I would say yes, there are in quality, yes, there are clinics available in at your dispense that you can go, but quantity is something that is questionable, and it is obviously at an area of development.
Yes, it sounds similar to what so many women experience all over the world is not taking so long to get the accurate diagnosis, trying to convince healthcare specialists that it's not in your head, that we really are feeling these pains. And I think through advocacy, through works such as your personal study that you did as a part of your graduate dissertation, these kinds of things will help raise awareness. What other things are you doing? I know you're a part of the Worldwide EndoMarch in Mumbai. What kinds of things are you doing through the Worldwide EndoMarch and your group in Mumbai to advocate and raise awareness in Mumbai as well as in India?
Okay, so actually, this was due because of the inspiration I got from the entire team of Worldwide Endomarch, that I started this initiative, Worldwide like Endo Welfare Mumbai. And frankly speaking, as of now, there's no team. I am just like an individual who is working towards this. But yes, in the upcoming like next 4 to 5 months, I am planning to get in contact with more passionate individuals who would share the same dream and who would like to join me in this journey. And talking about the next 3 to 4 months, I aim to visit the interiors, the pockets, as well as the like certain areas around Mumbai which are in like at the exterior ends and near the rural areas, to raise an awareness at both the ends, because we always have this notion that it's mostly the rural areas that need awareness. But I think that in terms of endometriosis, even it's as common as diabetes, but most of the people are not aware about it. So I would not just want to look at it from the lens of urban rural settings. I would just want to go and raise awareness anywhere and everywhere possible, including the medical fraternity, the colleges, the schools, the educational institutions, and all these kind of things. So yes, obviously I plan to arrange certain small workshops in school and colleges, so that they get an idea of what is primary dysmenorrhea, what is secondary dysmenorrhea, and pain is something which is actually an important factor for us to decide that we might have an underlying medical diagnosis, not necessarily endometriosis, but even PCOS, PCOD, or anything else. So yes, that would be my apart from that, I would want to talk with my local authorities and try talking with the other authorities. And if I get an opportunity, yes, I would like to connect with higher authorities. And then long term goal is obviously setting up my own NGOs towards the advocacy.
Wow, you have excellent plans, and I sounds from talking to you that I am confident that you will make great pathways with regard to endometriosis awareness in your area. Great works that you've done thus far, and where you're headed. One last thing before I let you go, can you tell us? You said you have an Instagram account. So, what is your Instagram? How can we find you on Instagram or any other social media outlets in case we have any listeners that maybe live in your area and would like to be involved, or just to get information? It sounds like you have a lot of great research and things that people from all over the world could benefit from reading. What are your sites?
Thank you so much. I'm glad that you think that. So my Instagram account, basically Endo Welfare. It's named as Endo Welfare Mumbai, Endometriosis Welfare Mumbai, and the Worldwide EndoMarch is following me. So, any of the followers who are already following the Worldwide EndoMarch can just find me in the following list and the followers list. Yeah, so that's where, and as of now, I don't have any organization like it's a big thing like Worldwide EndoMarch has been brought up with such an effort and dedication by Sir and all the other administration team. So that's a very great thing. And I would want to draw inspiration from that and at least be a part of it, so that I can make awareness in my terms.
Well, excellent. You already are a part of it. The work that
Oh,
you've done thus far and your plans for future works are definitely making you a part of the Worldwide EndoMarch. That's definitely for sure. So thank you so much for taking time out of your busy schedule to chat with us
oh,
today. It's been a pleasure talking with you. And again, you are inspirational to so many for your work. So please keep it up. You're making a huge difference for a
thank you so much. Your
very
words. I
necessary
mean,
cause.
thank you so much. Hearing from you, you yourself has, gone through all the journeys like you mentioned, and your vibrant smile and vibrant personality gives me such a hope, that I will be there down the line somewhere after so many years. So yes, I am just so inspired by the entire team. I've always been, and it's lovely always that you give opportunity to individuals who are just getting to know about endometriosis, and trusting that is a very big very big thing, and this in itself is an initiative to change in a way.
Oh,
So
absolutely.
yeah,
Absolutely. Definitely. Just talking with you today
yeah,
and for our listeners and viewers, we are advocating
yeah,
and having our voices heard. So it's all anything that we can do to get the message out there in any form is increasing advocacy and awareness. So please keep up the great work and thank
thank
you
you
for
so
taking
much.
time with us and best wishes to you moving forward.
Yes, I would
Thank
like to just say bye to everyone. Thank you so much for hearing me out, and best wishes for everyone. Thank you.
thank you.
We demonstrate the management of a patient with stage 4 endometriosis with disease that involved the cul-de-sac and uterosacral ligaments. We anticipate bleeding during the dissection. Thus, we begin the case by securing the major vessels first. We enter the retroperitoneal space on the right side. Blunt dissection is done to identify the uterine artery as it branches from the hypogastric vessel. Hemalock clips are placed along the uterine vessel. We now turn our attention to the infundibulopelvic ligament. We fenestrate the broad ligament in order to skeletonize the vessel. Hemalock clips are placed and the vessel is transected. At this point, we begin to mobilize the ureter from the posterior leaf of the broad ligament. We now turn our attention to the left side. Similar to the previous side, we approach the vessels first. The retroperitoneal space is entered on the uterine artery as it branches from the hypogastric is identified. Hemalock clips are placed and the vessel is transected. The infundibulopelvic ligament is identified, skeletonized, and secured by hemalock clips. The vessel is transected. Prior to approaching the pararectal space, we mobilize a few loose posterior adhesions. The ureter is identified and further dissected. We are now able to enter the pararectal space. We strive to identify normal anatomy and take down loose adhesions to facilitate the dissection. Although we still encounter some bleeding, this amount is greatly reduced because we secured the vessels first. We're now entering the right pararectal space. At this point, we can visualize the rectovaginal septum. Having identified normal anatomy from the right pararectal space, we can continue to take down the scar more safely. We continue the dissection on the left side as we mobilize the colon from the uterosacral ligament. We use a combination of cutting current and electrocautery to dissect around the uterosacral ligament. A Raytec is placed for hemostasis. The ureter is further mobilized on the right side. Now that the rectum has been mobilized and the ureter is identified, we can now resect the uterosacrals. We resect the diseased portion of the right uterosacral ligament. We turn our attention back to the left side, where the ureter is further mobilized. This allows us to safely approach and resect the left uterosacral ligament. We now turn our attention to the anterior portion of the uterus, where we mobilize the bladder flap. Although we already took the uterine artery as it branched from the hypogastric, we sometimes choose to take the paracervical uterines to prevent bleeding from the vaginal branches prior to doing the colpotomy. Hemolock clips are used to secure the vessel. We now proceed with the colpotomy incision. The specimen was removed vaginally and the cuff was closed with barbed suture. At the end of the case, the patient was hemostatic and debulked of endometriotic disease.
Roy Tagavi, and I'm a Worldwide EndoMarch Headquarters volunteer. I'm here today with the EndoMarch representative of Team Ireland, Kathleen King. Once again, it's very nice to meet you, and thank you for taking the time to answer some questions today. To start off, how did you become involved with EndoMarch?
Thanks, Roya, and all the Worldwide EndoMarch team. I became involved from the very first Worldwide EndoMarch that the Nejat Institute had instigated a number of years back. And while there was no appetite to have a physical EndoMarch in Ireland, we did mark those days for the first number of years by holding local awareness events and small personal events and online things. So from the very beginning, it was great that Ireland was represented, albeit a small country and in a small way, but it was great to have our voice heard amongst some of the larger countries as well.
That's amazing. So currently, in your opinion, how easy or hard is it to find an endometriosis specialist in your area?
Oh, in Ireland, it's incredibly difficult. And that's not just, in the Republic of Ireland, but also Ireland as an island. We have Northern Ireland as well. And women find it very difficult to access appropriate treatment and appropriate care. A lot of women travel. And we find that people are constantly looking for expert surgeons outside of the country. And in Ireland, the average delay to diagnosis is 9 years. And this is really compounded by that very strong lack of appropriate care and lack of appropriate recognition of endometriosis and the severity of the condition as well for people. So we do see that it is a struggle. We have some up and coming surgeons who are starting to, train and starting to look at endometriosis. The government has promised us some appropriate treatment centres, but again, it's very far from what is needed for the 200,000 plus living with endometriosis in Ireland.
Yeah, absolutely. As I speak to various countries, I see that it's a common pattern, of course. First of all, lack of access to specialists in this area, lack of knowledge, lack of awareness, lack of education. These are all sort of factors that contribute to this diagnostic delays. And you said 9 years, which is quite a bit. But as we sit here and talk, I'm like hoping, people, it sparks interest in endometriosis and people start to get educated, and maybe people will enter the field too. So could you maybe tell us more about the efforts and maybe projects that you're working on or Team Ireland is working on to increase and endometriosis awareness in Ireland?
Yeah, so like I said at the very beginning there, at the very first EndoMarch, we had very few people willing to come out and actually speak about the condition and to sort of come forward. And jump 10 years later, and we have so many strong individuals now who represent not only the endometriosis community, but the awareness community as a whole. So we have not just our, people living with the condition, we also have their supporters as well too. And this was really borne out at a recent EndoMarch where we had, some good family and friends involvement. We had people come up to us, in the park during the march and say, oh, I've heard about that. That was on the news recently, or that was in a magazine article. And that's been really, really good. It's been really progressive. And I think that is the big change over the last 10 years, is that we are a lot more comfortable speaking about endometriosis. There's a lot more awareness pieces in the media, which is fantastic. But again, we have to temper that with the actual balance between accurate information and what's actually portrayed in the media. So this is where long-term advocates like myself and the rest of my team here come in. We're there to make sure that the accurate information is portrayed in the media, that there is accurate information given at school level and at government level. And we've been involved in a very minor way in trying to sort of campaign to the government to improve education, to improve education at, not just school level for the public side, but also in healthcare professional settings as well. And we would like to try and get the government to look at, the bigger picture of endometriosis and not just focusing on hospital treatment as being the end point. We need to look at the societal impact as well. So at the moment, we are working on bringing a schools education programme into Ireland. There's a small group of us here working on that, and we're hoping to make that the first step in the education process. And second to that then is we will continue on as small ad hoc things that we have in terms of educating individual groups, be it clinicians, GPs, nurses, and all of that. So all of that continues.
Yeah, you totally hit my next topic, which is regarding endometriosis policy on a government level and education. So how has the government responded, or if they have responded to your guys' proposal?
We find that the government here feel that what they've proposed is sufficient. And unfortunately, the majority of the advocacy community don't agree with that. It doesn't go far enough. It doesn't recognise the complex and wide-ranging reaches of endometriosis and life with endometriosis. And unfortunately, the proposals there don't take into account that expert surgeons and, a multidisciplinary team are needed. So we have a long way to go, I think, to have our voices heard. Ireland has a very complex history when it comes to listening to women. We have a very complex history when it comes to, suppressing women, and particularly incidents in women's health. So I think this is going to be an uphill battle. But I think, when we have the strong voices of everybody together, I think that will make a huge difference. And we just need to keep pushing on this one and make sure that, the government will listen through time.
Yeah, of course. And that in and of itself, the not listening to women, not taking women seriously is part of the contributing factors to diagnostic delays. And of course, if we're not taken seriously, and no one's really educated on the topic of endometriosis and this disease, not much change will happen unless we increase our efforts. So back to your what you were talking about, the media. I wanted to specifically ask, how is Team Ireland utilizing social media? Because social media is like a big factor in today's society. I just wanted to see if there's anything you guys are doing on social media that is increasing awareness of endometriosis.
Yeah, social media is one of those tools that's a very double-edged sword, isn't it? On one side, we've got fantastic advocates out there. We've got some great personal stories and great information getting out there. And on the other hand, we have to balance that with information overload and also the accuracy of that information. So what we tend to do is we try and reach out to anybody who is sharing their story, who is wanting to become an advocate, and try and work with them to make sure that they have the up-to-date information, that they have all the facts, that they have, appropriate figures for endometriosis in Ireland, and try and support them in that. Because while everybody's journey is different, the facts remain the same. We know that there are certain things in endometriosis that's going to be universal. And I think that's very important. And we also look to our colleagues then in different countries as well too. And we find great inspiration, like from, a lot of different countries where they've used social media quite creatively. I think we have a lot to learn. We have a long way to go in this as well. But I do think that given the very short information span that's there, like in a lot of social media at the moment, I think that can be utilized really well. And I'm really excited to see what we can do with that, in the coming EndoMarch season.
Yeah, of course. I think social media, especially like in terms of targeting the younger population, is such a great tool, because if we can target the younger generations, then maybe we can prevent the progression and reduce diagnostic delays, right, of endometriosis. Yeah, absolutely. So my last question for you is, what changes do you think are still necessary in your area specifically to aid in furthering public knowledge of endometriosis?
Oh, I think we have huge changes that need to be made. I think, first of all, we need to recognise that endometriosis is a huge condition in terms of societal impact, impacts the individual, impacts the family, impacts the workplace. Like we know that it touches every sort of facet of life. And I think that recognition is coming. It's coming very slowly. But I do think that, certainly our government, our health services as well too, need to look at that as being one of utmost priority. If you can diagnose somebody early, you can get them treated early in an appropriate manner. You can stop them being stuck in this cycle of repeated admissions to our healthcare service, which we know is absolutely creaking at both sides, north and south. It is a big issue. And we find that, education at that very early level, allowing people to recognize that symptoms are actually relevant and maybe an indication of something going on. And as well, too, on the medical side, education where they can recognize that there is something in the patient that's sitting in front of them as well, too, and put them through the appropriate pathways. And of course, we need to follow that up then with appropriate access to surgery and appropriate access to all the multidisciplinary treatments that we need, to live an effective and good quality life with endometriosis. We know that's possible. And I think, we're probably mirroring what everybody else is saying throughout the world. I don't think anybody has this perfect at the moment. I do think Ireland would have the potential to lead that out. We're a small country. I think we need the buy-in of a lot of people behind us for that, but we can live in hope. We can certainly keep fighting for it.
Yes, and I love that you mention education a lot and changing, policy in your area and enacting education programs in schools and institutions is something that's so necessary to see a wider scale change. So thank you for bringing that up. And I really can't wait to hear what Team Ireland continues to accomplish in the future and your efforts in raising awareness around such an important issue. Before we end, is there any last words you'd like to share?
No, we'd just like to wish everybody involved in the EndoMarch this year all the best, and to say that we feel your solidarity and support every year, and it is truly, truly amazing. And for everybody who's fighting the same fight worldwide, the best of luck. And if you crack the secret to getting endometriosis being taken seriously, please share it, because we would all love that. And, we can all learn and benefit from each other. And I think, like anything, we're stronger together. So thank you very much for all your support.
I second that. Absolutely. Thank you again for your time, Kathleen, and have a great rest of your day.
Perfect. Thank you very much, Raya.
In this video, we will review the nerve-sparing robotic treatment of endometriosis and discuss the innervation pathways of the pelvis. This is a case of a 37-year-old Gravida 2 Para 1 with history of infertility and stage 4 endometriosis, diagnosed on prior laparoscopy for bilateral ovarian endometriomas 13 years ago. She had one successful pregnancy by IVF after treatment of endometriosis, then was unable to get pregnant again. She underwent 2 failed embryo transfers and presented for repeat surgical treatment of endometriosis prior to pursuing further IVF. Her past medical history was significant for polycystic ovarian syndrome, and her surgical history was significant for her previous laparoscopic bilateral ovarian cystectomy and a dilation curettage polypectomy. She was on oral contraceptive pills and metformin. She was taken to the operating room for fertility-sparing robotic treatment of endometriosis. Chromoperturbation revealed bilaterally patent fallopian tubes. She was found to have filmy adhesions on the uterine serosa and dense adhesions of bilateral ovaries to the posterior uterus and bilateral pelvic side walls. Filmy adhesions were excised from the surface of the uterine serosa. Next, the ovaries were freed from the posterior aspect of the uterus. Adhesions between the left fallopian tube and ovary were carefully lysed to free the fallopian tube. Next, attention was turned to the right ovary for ovarian cystectomy. The plane between the cyst wall and the ovary was developed, and cyst wall was carefully separated from the ovary using tension and blunt dissection, with close attention paid to avoid any injury to the underlying ovarian parenchyma. Attention was then turned to the left pelvic side wall to open up the pelvic side wall for identification of the ureter. The peritoneum was tented up and carefully opened. The left ureter was identified retroperitoneally, and can be seen vermiculating here. The left ureter was further dissected along its path and identified retroperitoneally along the sidewall towards the uterosacral ligament to safely perform nerve-sparing excision of endometriosis in this area. The left ureter can again be seen vermiculating here along the sidewall, exposed laterally to the uterosacral ligaments highlighted here in blue. Exposed here are also the inferior hypogastric plexus nerves extending posterior-anteriorly on either side of the uterus. Contributions to the inferior hypogastric plexus include superior hypogastric plexus, sacral splanchnic nerves from the sympathetic trunk at vertebral levels T10 to L2, and pelvic splanchnic nerves which contribute parasympathetic efferent fibers to the plexus. Here is a schematic view of the pelvic nerves in the female pelvis. The inferior hypogastric plexus can be seen here, extending posterior-anteriorly along the uterus and bladder. Contributions to the inferior hypogastric plexus include superior hypogastric plexus, sacral splanchnic nerves from the sympathetic trunk at vertebral levels T10 to L2, and pelvic splanchnic nerves which contribute parasympathetic efferent fibers to the plexus. The inferior hypogastric nerves supply innervation to the bladder and urethra, and innervate the smooth muscle fibers of the visceral portion of the levator ani muscles. Endometriosis excision in this area must be done with due diligence to avoid damaging the nerve fibers of the inferior hypogastric plexus, as the disruption of these nerves may cause sexual, bladder, and bowel motility dysfunction. Here we can see the spared inferior hypogastric plexus nerves after excision of surrounding endometriosis. Next, an EEA sizer was placed into the rectum to excise endometriosis of the rectum, again paying attention to spare fibers of the inferior hypogastric plexus. Here is a look at the pelvis after complete nerve-sparing excision of endometriosis in bilateral pelvic sidewalls. Nerve fibers of the inferior hypogastric plexus can be seen as spared, traveling posterior-anteriorly along the uterus. Thank you for watching.
Morning, everybody. I want first to thank Dr. Kamran Nezat for the honor he gave me to participate to this global conference. Thank you. My name is Dr. Vanina Ngono from Central Africa, precisely in Cameroon. I am Gyn and Obs at the Gynecological Endoscopic and Human Reproductive Teaching Hospital, Paul and Chantal Biya in capital Yaoundé. I want to discuss about sociocultural barrier for management of endometriosis in Africa setting, the case of my country. Endometriosis is a disease in which tissue similar to the lining of the uterus grow outside the uterus. It affects about 10% of reproductive age women. It is one of the gynecological pathology with a greater delay in diagnosis. It is a chronic disease associated with severe life-impacting pain during periods, sexual intercourse, chronic pelvic pain, abdominal bloating, infertility, and sometimes depression and anxiety. Access to early diagnostic and effective treatment of endometriosis is important, but is limited in low and middle income countries. Cameroon is a low middle income country with a population of 27.2 million with 7,200 medical doctors, 300 gynecologists for an average of 10.5 million of women. For the management of endometriosis, we face many barriers which can lead to delay management of the patient. First, in the level of the population concerning the decision to go for consultation. Furthermore, the knowledge of practitioner and tool of diagnosis. Finally, the acceptation and availability of the treatment. Concerning the main symptom, dysmenorrhea is considered like a normal process in inheritance of parents, and it will certainly pass with the birth. Intercourse is marital duty, and rape doesn't exist between couples in Cameroon. Otherwise, polygamy is allowed. The high prevalence of sexual transmitted disease due to poverty, the unavailability of health insurance does not always allow prior investigation. It means that pelvic pain is managed directly as PID for many years. Also, we have a traditional disease called woman worm, which causes pelvic chronic pain, and it is not considered like a medical disease. Women who do not give birth can be considered as a witch in some areas. It is like a sperm, leading to no more investigation. Even if patients decide to be consulted, where do they go for advice? Traditional medicine with no or low cost, spiritual and marable, considering that it is a sperm, few proportion go to the hospital. For those who go to the hospital, who do they encounter for diagnosis? Gynecologists? Certainly not, because in Cameroon, we just have 300 gynecologists for about 10.5 million women. General practitioner? I don't think, because we have 7.2 thousand general practitioners for a population of 27.2 million of inhabitants. So many of them go on to nurse and nursing auxiliary. It is the same thing for surgical management, and the particularity is that in remote area, nurse and nursing auxiliary can do the surgery. No matter who they consult, we are faced of lack of knowledge by practitioners. The availability of ecography just in the urban area, availability and cost of MRI in the country where the average salary per inhabitant is $100 US per month. Laparoscopy is available just in the big town, and the total cost is around $700 US. For the 300 gynecologists for 10 million women, how many have skill in endometriosis surgery? Concerning the treatment, we don't have national guidelines. Combined oral pill is not allowed, is not always accepted for the adolescent and nulliparous because in some behavior, it can induce infertility. Analog of GnRH are available, but the cost remains high. For the surgery, we don't have a real expert in endometriosis surgery. Every laparoscopist tries to do his best. So between 2019 and 2021, we did 157 surgeries in total. Concerning IVF, we just have one public center and 3 private centers in all the country, and all are just in the 2 big towns. And the cheaper is $3,300 US. This last year, in our hospital, we had 4.2% women with endometrioma in IVF. Concerning our action at the level of the community, we collaborate with women associations. One of them is Butterfly Association with my colleague, Dr. Yves Cassia, who play a very big role in the community. So we organized this year 2 fitness walking for endometriosis with Butterfly Association. Also, information education and communication on severe dysmenorrhea in high school. Concerning our action in hospital, our mentor, the general manager, Professor Jean-Marie Cassia, bring endoscopy in Africa in 1992, organized the training of young gynecology twice years with International Society of Gynecological Endoscopy. Medical campaign for the reduction cost of surgery and international expert for surgery. Political, it is also a political actor in endometriosis fighting. Our perspective concerning training of frontline staff, nursing, auxiliary, nurse, general practitioner, gynecologist, radiologist, creation of website to inform and orientate patient to preferring doctor. Organization of surgery campaign with international experts. Thank you for your kind attention.
To all of our viewers around the world, I am Dr. Cameron Nejad, the founder of EndoMarch and Endometriosis Day. I would like to thank you for your interest and for your interest in patients with endometriosis and their families. Since its inception, EndoMarch, almost 10 years ago, its mission has been to raise awareness about endometriosis, find a non-invasive diagnostic test, find a method to prevent it, hopefully, and better methods to treat it. By yard is hard, by inch is a cinch. We are very pleased to say that the worldwide EndoMarch has made significant progress, at least internationally, by raising some awareness. We have raised the mountain an inch. We see more and more programs from everywhere internationally that they are talking about endometriosis and interest in academic centers about endometriosis. We thank you for your interest in doing that. It's all because of your doing. And for that purpose, Worldwide EndoMarch has had series since the COVID that has been very successful for educating the interested parties about this disease, endometriosis. These are webinars that have been watched by hundreds of thousands of people around the world, and every session more than 10 to 20,000, sometimes 30,000 people on a monthly basis watch these seminars, and that is thanks to you for your interest. Because you like it, we have more scientists are being supported, and we thank you again for the support of the scientists, their work to finally find and unlock the dilemma of endometriosis. Please go to the Worldwide EndoMarch webinars if you are interested for the previous sessions and of interest for you and your families to watch it. All you need to go to the worldwideendomarch.org or endomarch.org and go to the webinar button at the top, and then if you touch it, it will get you to the session that you need to go. Also, for those of you internationally who do not have access to a surgeon or an endometriosis specialist, and you think you may have endometriosis, there is a free app. It is called Nejat Endometriosis Advisor. That is an app that is completely free, could help you and guide you that you may have endometriosis, and you go from there to get help from a physician. To continue, today we are very lucky. We have 4 of the scientists, the most known and respected scientists around the world, that they have done significant research about endometriosis from Oxford, from Harvard, Yale, and UCSF, that are joining us and are going to express and tell you how they got interested and they speak about endometriosis. We are very, very lucky to have today Drs. Zondervan, Dr. Taylor, Dr. Misma, and Dr. Judis that have honored the EndoMarch, and they are going to speak about their work. Please, if you have anything, any question, you can address it to us or to them directly. So I will proceed first with Dr. Zondervan. She is professor of reproductive and genomic epidemiology at Oxford University and head of the Neufeld Department of Women's and Reproductive Health. She is co-director of Oxford Endometriosis Clinic. And Dr. Zondervan is one of the most highly cited authors in reproductive sciences. And in 2013, she was recognized as an outstanding female scientist. She is in Oxford, England. We thank her very much for staying up late. And we welcome her. And please go ahead. Go ahead, please, Corina.
Thank you so much, Dr. Nejat, for that really kind introduction. And I'm absolutely delighted to be able to speak with you all today. So I thought I'd first start by telling you all a little bit about me and how I came to research endometriosis, which is a journey that started more than 25 years ago now. I am an epidemiologist originally from the Netherlands, where I trained first in biomedical sciences and then in epidemiology. And I came to Oxford as a student back in the early 1990s. And during my studies, I had developed an interest in women's health and epidemiology, which I felt was an area that was very understudied. So that really led me to want to work in that area. As you know, some of you may know, epidemiology is a field of research that studies the prevalence or the frequency of health conditions and also risk factors for those conditions using very large-scale data-driven studies. And the aims of such epidemiological studies are to shed light on the burden of diseases from a public health perspective and to find factors that are linked to their causation. And a famous example of a link that was made in using epidemiological studies is one that we all know about, which is a link between smoking and lung cancer, for example. So, you know, having always loved mathematics and data analysis, the field of epidemiology always appealed to me, but I really wanted to apply those techniques to women's health. So when I first came to Oxford from the University of Leiden in the Netherlands, I started a PhD in public health and obstetrics and gynecology, working at the time with doctors Stephen Kennedy and David Barlow. And my PhD involved the mapping of prevalence and risk factors for chronic pelvic pain in women in the UK, because there were no robust data at all about how common pelvic pain was in women in the UK in particular, and there are actually very few data worldwide on this topic. And these studies show that chronic pelvic pain was extremely common, affecting 15 to 20% of women, but also that many of these women had these pain symptoms for many, many years before receiving a diagnosis, as I'm sure you are well aware of from your own personal experiences. So, and because of my own biomedical background, I was intrigued that a common diagnosis was endometriosis, which was a common that actually very few people around me that I spoke to had heard of, and that we knew very little about in terms of its causes. So I decided that after my PhD, for my postdoctoral research, I really wanted to study endometriosis to help shed light on the impact that this condition had globally on women and to better understand risk factors and causes for the disease. So first of all, together with the World Endometriosis Research Foundation, I led a study investigating the impact of endometriosis globally, in which one of my first PhD students, Kelechi Noaham, at the time analysed data from women first undergoing surgery for endometriosis in 10 countries across 5 continents, really. It's a very large study. And these data showed a remarkable consistency in the experience of women impacted by endometriosis. I mean, on average, there was a delay of diagnosis between first onset of symptoms and diagnosis of about 7 years. And that delay mainly related to the time it took for women to be referred from a general primary care physician on to a gynecologist and a specialist in endometriosis. And it also showed that endometriosis had a huge impact on the lives of women and their families, both in terms of daily lives, but also the effect on work, with an average of 11 hours a week lost due to endometriosis that we sort of calculated from these studies. And this was really a study that was very close to my heart because it raised a lot of interest, and I got a lot of questions about, you know, what is endometriosis and how can we research this further. And it was a study that was ended up being highly cited and was amongst a sort of 25 historic papers published in Fertility and Sterility at the 75th anniversary of the American Society for Reproductive Medicine. But I mean, as I mentioned, you know, that is work on impact and on prevalence, and it's hugely important. But I also really wanted to work on understanding causes and risk factors for endometriosis. And one of the aspects that intrigued me with my background in biomedical sciences was that endometriosis has a very strong heritable component. In other words, endometriosis can run in families. It doesn't always do, but it can do. And my PhD supervisor at the time, Dr. Stephen Kennedy, had started collecting DNA and data from women with a family history of endometriosis in the 1990s and had led analyses investigating these families. And what I wanted to do is follow on from that work by starting large-scale studies into endometriosis, not just focusing on families with a strong family history, but also looking at genetics of endometriosis in the wider population of women. And I really hoped by understanding which genes and which DNA variants in these genes are involved in the development of endometriosis, that would tell us more about the biological causes, but also about potential subtypes of disease. This knowledge would then hopefully lead to new ways of diagnosis and new medical treatments potentially. So with that sort of vision in mind, I ended up getting some fellowships from Medical Research Council here in the UK and a Wellcome Trust, and started my own group focused on endometriosis research back in 2007. And together with Dr. Christian Becker, a gynecologist in Oxford, I co-founded the Oxford Endometriosis Care Centre in 2012. And we've worked together ever since, and building the research arm of the centre to around 25 staff and students now. So studying genetics of any disease means you have to, and genetic epidemiology, you have to study large amounts of data. And that was very apparent from other such studies that were successfully carried out for other diseases with a large public health impact. And you can think of diabetes, cardiovascular disease, cancer, and we learned a lot from that. And one key aspect that we realized quite quickly was that this required collaboration between groups. And it's been a huge privilege to work with wonderful clinicians and scientists across the globe to understand the genetics of endometriosis better. And that includes the other panelists here on the call, which I'm very excited to join, together with. So, but even more importantly, it relied so heavily on the willingness of women with endometriosis to participate in the research studies. And I cannot tell you how grateful and impressed I am with the dedication, and the rest of my team, with the dedication we've witnessed, and the enthusiasm with which women have participated in the studies, and those of our collaborators. And it's been a true source of inspiration for me personally as well. I just wanted to really highlight that. So you will probably ask, where have we come to in understanding these genes or gene variants that are associated with endometriosis? Well, we've just submitted for publication the results of the largest collaborative genetic study to date, involving DNA analysis from more than 60,000 women with endometriosis and more than 700,000 of women without endometriosis as a comparison. And these data were derived from 25 data sets and centers across the globe, contributed within a research consortium, the International Endometriosis Genome Consortium. So we found 42 genetic risk variants for endometriosis, 31 of which we had not known about before. And we also showed that ASRM stage 3-4 disease appeared to be really quite different in terms of its genetics than stage 1-2 disease. And work that Dr. Mismer and her group did subsequently show that the effect of these risk variants seemed to be different between ovarian endometrioma and superficial lesions. In other words, these seem to be regulated differently genetically. And this has started further work on subtyping endometriosis that I know Dr. Mismer will touch upon later as well. Now, knowing which DNA variants increase the risk of endometriosis does not necessarily tell us which genes are affected by these variants. And this is quite a complex area. We need to ask the question, which genes are affected in their expression by these variants in the tissues that are relevant to endometriosis. And the tissue that is clearly most relevant to the endometriosis is the endometrium. So as part of our recent consortium study with collaborators, Dr. Montgomery and his team in Brisbane, we studied the effect of these DNA variants on gene expression in endometrium and also in blood, using different data sets that our groups had available. And that led for the first time to a strong list of genes that we know are affected by these variants. And many of these genes are involved in hormonal regulation, but also inflammatory response and cell growth. And our follow-on studies that we are doing now, we can now use these gene lists to identify potential new targets for medication development that could be designed. And of course, in particular, we are interested in genes that impact non-hormonal biological pathways, in particular inflammation. And just as a very brief example of that, we've just published a paper in Science Translational Medicine that really showed the power of genetics in this. In this time, we used data from family-based studies, and we identified a gene called MPSL1 associated with endometriosis. Now, MPSL1 was a really interesting gene because it also had been associated with other inflammatory conditions, asthma, inflammatory bowel disease, rheumatoid arthritis. And we then worked with other academic groups and industry collaborators to block MPSL1 in both cell assays and in other models. And look at the effect. And what we saw was a reduced amount of inflammation and a reduced amount of pain. So although we need to do a lot more follow-on work on this to understand the mechanisms involved, we were really quite excited by the potential of this particular target to be a non-hormonal target we can work with as we move on. Now, then as a final point I would like to make, I'd like to come back to my earlier point of the need of large-scale data. And of course, as an epidemiologist, I would say this, but it's so crucial to our work. And we've been collaborating with Dr. Mismer for many years on sharing data. And quite early on, we became aware that in order for us to collaborate effectively, we needed to collect the same data and collect all our samples using the same protocols. Otherwise, if we can't replicate each other's findings, we don't know whether that is because then they're false or whether we're just not comparing the same data. So Dr. Mismer, together with Christian Becker and I, founded the WRF Endometriosis Phenome Biobanking Harmonization Project, or EFFECT for short. You can look this up online if you like, but that really is the culmination of 30 centers that participating to come up to a consensus for data and sample protocols for sample collection. And now there's these were freely published online, and anyone can use this. Any research center worldwide can use this. And there's now 50 such research centers using these tools worldwide, and they have already led to new funding to fund research into endometriosis, also in studies sort of led by Dr. Jadis and Dr. Mismer here on the call. So I think that's where I should stop now. I hope that's given you a very brief flavor of some of the work that I'm passionate about, and you know, I will spend, you know, the rest of my working career certainly working on. And to say also many thanks to our collaborators in working with us on this, and thank you to you for your interest. Thank you.
Thank you very much, Karina. It was a wonderful presentation, and congratulations for your outstanding work and what you are doing to help the patient with endometriosis. Please stay online, because our fellows and others have questions for you. And already I have been informed there is a lot of interest, so we might even go a little bit longer, and that is okay. So I will proceed. Next, we come from England to the East Coast of the United States, to Yale University, to Dr. Hugh Taylor. Hugh has been an outstanding researcher and interested in endometriosis. He is the chair of the department of the OBGYN and professor of the Anita O'Keefe Young Professor of Women's Health. And he is the past president of American Society of Reproductive Medicine. He has been devoted to research and treatment of endometriosis and trying to find out what is going on, how can we help the patient, and it's a pleasure and honor to have him. Hugh, please proceed.
Thank you so much. And I first want to just start out by thanking Dr. Najat for organizing this, for founding EndoMarch, for bringing all the awareness that is so needed to this disease. Awareness, access are so important for patients with endometriosis. So thank you for helping raise awareness, and this EndoMarch has been a tremendous asset to the field. So thank you for that, and among all your other contributions to the field, but particularly today, thank you for EndoMarch. So I started out as a physician and scientist interested in doing research to help improve healthcare, and I started out actually working on uterine biology, and I was interested in the endometrium and how embryos implant and pregnancy. But it was the patients that brought me to endometriosis. Working with patients in gynecology and reproductive endocrinology, I found that patients with the endometriosis were the probably least understood. This is perhaps the least understood disease that we treat. And the stories of patients not getting the correct diagnosis, being dismissed, could sometimes bring me to tears, were always frustrating, sometimes got me just plain angry. I couldn't see myself working on anything other than endometriosis. And since that time, I devoted my career to this. And again, it was all driven by the patients I worked with and hearing their stories and wanting to make a difference and improve that. So we've spent a lot of time working in my group on understanding the cellular and molecular mechanisms using laboratory-based models and animal models to better understand this disease. So a little different approach than you heard from our last speaker, but takes many different approaches to get to the bottom of a disease and move things forward. Our results have helped us to understand what drives endometriosis, what makes it grow, and potentially even come up with some novel treatments. Over the last few years in particular, I've been most interested in all the effects of endometriosis outside the pelvis. It was more obvious that endometriosis in the pelvis can cause pelvic pain, but we all know that that's just the tip of the iceberg. Endometriosis can occur in areas outside of the pelvis, in the lungs, the brain, many other places, not commonly, but it does. We've all seen that. Women with endometriosis have all sorts of other effects due to the disease. They have a lower BMI on average, they're lower weight. There's this generalized inflammation, as we heard about before from our last speakers, identifying some of the genes that are driving that inflammation with association with autoimmune conditions. There's an immune component to this disease. There's an effect on the brain. There have been associations with anxiety, depression, pain sensitivity. And so we've used our in vitro, laboratory-based models and animal models to really get at the cause of these things. We did some studies where we create endometriosis in mice, and we can really get cause and effect. When you see an association in women that women with endometriosis are more likely to have anxiety, well, did endometriosis cause the anxiety, or did anxiety lead to more recognition of the endometriosis? And our animal models have been really able to get at cause and effect. For example, we create endometriosis in a mouse, and the mice don't gain as much weight. We know women with endometriosis have a lower BMI, they have lower weight, lower body fat. And I've seen it in many textbooks say being thin is a risk factor for getting endometriosis. No, in our model, we proved it's just the other way around. The disease itself will cause weight loss. And we show effect on the liver. We show an effect on adipose, the fat cells. And we show how these cells are changed in a way that would make one lose weight. Endometriosis has a metabolic effect. Your metabolism is different if you have endometriosis that leads towards weight loss. So again, it's not just an effect in the pelvis. The whole metabolism is different. We create endometriosis in mice, and we see whole body inflammation. We see propensity to immune disease, even autoimmune disease in our animal models. So again, endometriosis causes these whole body systemic inflammation that explains some of the conditions that we see in women that are far too often dismissed or thought to be unrelated. We know women with endometriosis take years to get an accurate diagnosis, are often misdiagnosed. And I think because of all these different effects on other organ systems, it often leads us to follow these red herrings. You have some sort of inflammatory condition that distracts healthcare providers sometimes from looking at the real diagnosis of endometriosis. It's important we understand the bigger picture so that we're not misled, and we understand the totality of the disease. We really understand everything that our patients are going through. Again, we know that women with endometriosis are more sensitive to painful stimuli. They're more likely to have anxiety and depression. And again, I get, one of the things that makes me angry is when I hear people say, and you probably all heard it, oh, these are patients are just more sensitive to pain and they're anxious. It's all in their head. We've all heard endometriosis patients dismissed and insulted. And our work in the mouse model shows that when we create endometriosis, it changes the brain. We can see changes in genes in the brain. We can see changes in the electrical connections in the brain. And the mice develop anxiety, depression, and increased pain sensitization. So anxiety and depression are a direct result of endometriosis. We know the endometriosis causes this. It changes, it reprograms the brain. Again, it's not just about what we see in the pelvis. Endometriosis has these broad effects on the whole body and explains what our patients are going through. And we know the endometriosis causes that pain sensitization. It causes the anxiety and depression. So the animal models and the molecular understanding can really be very helpful at understanding what our patients are going through to help us not dismiss these other symptoms as irrelevant, and to help us focus our diagnosis on endometriosis when somebody may have a broad range of symptoms. It's still all typically endometriosis. We've also looked at some of the mechanisms. We really want to get at the molecular mechanisms that drive these long range effects so we can help understand them, diagnose, and treat them. Maybe some of the long range effects might be better treated with different treatments than treat the primary lesions in the pelvis. We can remove those surgically or we can treat them medically, but some of these long range effects, how do we revert the remodeling of the brain? How do we revert the inflammation? How do we reverse those metabolic changes in the liver and the adipose cells? So we wanted to get at the mechanisms, and our group over the last 10, 15 years have shown a role for stem cells in endometriosis, that stem cells coming from bone marrow and other places, or stem cells directly from the endometriosis themselves, can travel through the bloodstream and lead to endometriosis in remote areas in the body which they can't get to through retrograde menstruation. We've again worked on drivers of inflammation in endometriosis, and we think some of those may be very good targets for treatment to get rid of some of the whole body systemic inflammation and autoimmune conditions that plague women with endometriosis. And finally, we've looked at microRNAs. These are small RNA molecules that can be made by endometriosis, but enter the bloodstream and can have effects very far from where they're produced. We know that some of these microRNAs go to the liver and help cause some of those metabolic changes, go to the fat cells and help cause some of those metabolic changes, go to the brain and start to reprogram gene expression of the brain. So maybe by altering some of these microRNAs, we can reverse some of these long-range systemic effects. Also, with differences in these circulating microRNAs, we note in endometriosis, we also think that they may be a good diagnostic. We may be able to start to use those differences from circulating microRNAs that we can detect in the blood to tell if someone has endometriosis when the diagnosis is uncertain, or maybe lead to earlier detection, or when someone's being dismissed and you know you have endometriosis. If we could get a definitive blood test to tell when somebody had endometriosis before we go to surgery, then decide after that whether medication or surgery is the right treatment. But if we could just detect it early, we certainly could clarify that decision. There are a lot of people who, especially non-gynecologists, who aren't very familiar or aware of the disease. So raising awareness is critical. And what we're doing here today, raising awareness, is very critical. But if those people who don't know how to diagnose endometriosis, weren't familiar with it, would have an easy blood test and then could refer them to the specialist in endometriosis, I think that would do a lot to move this field forward and shorten that tremendous delay of 10 years or so between when someone has classic endometriosis symptoms and when they actually get an accurate diagnosis. So I'm very passionate about this disease. We've done a lot in the laboratory, I think, to understand it better. It's always been frustrating to know about all these whole body symptoms of endometriosis, but I think we're starting to understand how and why they happen. And I think that will help us treat the whole patient, not just the lesions in the pelvis. So thank you, Dr. Nejat, for all you've done. Thank you for inviting me here today, and look forward to hearing from the rest of our speakers.
Thank you very much, Dr. Taylor, for your outstanding presentation. Congratulations for your outstanding work. It is fascinating, and you opened up many eyes today with what you do, and we really are grateful for and all the patients with endometriosis owe you a lot, and thank you.
Thank you.
So we go from one star to the other star, and we are among the stars today, and very lucky to have the next star, who is Dr. Stacy Mismer. Dr. Stacy Mismer was previously at Harvard, and now is a combination of Harvard and also Michigan State. And he is the Global Impact Initiative endowed professor in obstetrics and gynecology and reproductive biology at Michigan State University. She is adjunct professor in epidemiology at Harvard Chan School of Public Health and lecturer in pediatrics at Harvard Medical School. She is the co-founder and scientific chair of Boston Endometriosis Clinic. And she has done significant amount of work to help patients with endometriosis. And it is a true pleasure to have Stacy here. Please go ahead.
Thank you so very much. It's an honor to join all of you, and also to highlight the wonderful contributions that EndoMarch has made across the globe in such a short period of time. And, you know, I started out in medical school. I actually then was inspired by a professor, Dr. Judy Lasker, really highlighting the importance of mentorship and inspiration as we're finding our career paths. And Dr. Lasker is a medical sociologist. She was focused on reproductive health, particularly around pregnancy loss and the impact on women and their families, and also focusing primarily on who had a voice, who was listened to, what information we had and didn't have. And I knew that endometriosis was described, particularly at this point in the early 90s, and still hasn't adequately shifted from being a condition of well-educated white women with type A aggressive personalities. And this really inspired my thinking and growing thinking as an epidemiologist, where we're taking, as Dr. Zondervan so nicely described, the necessary data, analyzing it in the correct way, and comparing and contrasting the appropriate people. But we knew that there are these large biases in who is suffering from symptoms associated with endometriosis and who is actually receiving a diagnosis in part of our studies. We also knew that as I was building my understanding of epidemiology and appropriate scientific approaches, that thinking of who we compare is so critical. So for example, if we're studying a pain associated with endometriosis, we're answering very different questions if we're comparing those with endometriosis to those who are healthy and have no other medical conditions, versus if we're comparing those with endometriosis to those with other pain-associated conditions like migraine. So as Dr. Taylor so nicely summarized, we see similar patterns in those with pain conditions who have been struggling for diagnosis in terms of the emergence of depression and anxiety and other comorbidities. We also know that there's differences if we compare those with endometriosis to those with other gynecologic conditions like fibroids or PCOS. These are all valid comparisons, but they're answering different questions. And I personally was selfishly inspired because my own severe pelvic pain symptoms began before menarche. And I struggled to find answers and appropriate treatment through my teens and into my 20s. And similar to as Dr. Zondervan was saying, many people didn't know about endometriosis. Certainly my pediatricians weren't mentioning endometriosis. And as someone who loved science and loved mathematics, I went to the library and found information. And at 17 or 18 years old, wrote to the Endometriosis Association of America to get more answers. And that really inspired my pivot to scientific discovery, knowing that we knew so little to help those like myself and my friends who were struggling with these symptoms. So as a doctoral student, I launched what became the first longitudinal study of risk factors for and consequences of endometriosis. So we studied in a large cohort of women across the United States, 100,000 women total, and looked at risk factors and exposures specific to early life and in utero exposures, also during adolescence around maturation, physical activity, diet, and then into adulthood. And then moved that work into focusing on long-term health of endometriosis. Again, as our first two panelists so nicely talked about, we helped to establish looking at relationships of a higher risk of cardiovascular disease, earlier onset hypertension, associations with autoimmune disorders, and also risk of infertility, starting to look at what were the associations between those with endometriosis who ultimately had successful achievement of pregnancy and successful family building versus those who experienced infertility. So starting to think a lot about what data we needed and what was absent from what we were trying to explore. As Dr. Zondervan said, she and I have collaborated for a very long time. And in the early 2000s, we, along with our colleagues, Christian Becker and Dr. Mark Laufer, were looking to establish new studies based at Oxford and based at Harvard University, and decided that we would synergize and consider how we could establish appropriate data collections. And that morphed into their EnDoc study and our adolescence to adulthood cohort study. And we utilized the tools developed through the Worth Effect Harmonized initiative to establish not only for ourselves, but now what has been globally accepted data collection for not just information about patients themselves, but also the biologic samples that we needed access to support biomarker discovery. We also are now within our cohort established in Boston, looking at longitudinal pain symptoms, prediction of long-term symptom remission and collection. Our cohort now has been followed for between 4 and 10 years for participants. So it's also very gratifying to see the enthusiasm and contribution of so many with endometriosis and those who care about them in the studies that we do. We also, following on the excellent work led by Dr. Zondervan for the International Endometriosis Genetic Consortium, we now have some new funding to look at not only those the variation in the genes associated with endometriosis overall, and how it then associates with those loci with subtypes of symptom presentation and comorbidities. But now we're funded to look and to discover new and novel genes that may be specific to subtypes. So for example, they may appear in only those with endometriomas, or they may appear in only those who have endometriosis plus emergence of autoimmune conditions or emergence of hypertension. They may appear only in those who have stage 1 on the ASRM staging condition. So we're very excited about what is to come in the discoveries for this work. Also, Dr. Zondervan and I have a collaborative project that combines our tissue and data samples along with those from the ENDO study started by Jermaine Buck-Lewis, and focusing at over 800 patients with endometriosis samples, looking at markers in those samples, particularly around the transcriptome, and tying that to this really deeply rich information that all these patients have so generously contributed around their symptoms and their changes over time. We're also focusing on effect now. We're expanding from those patient collections and the tissue standard protocols to now adding Paul Young in Canada is leading a new tool development for the physical exam and what can be documented more accurately and in greater detail from physicians seeing patients presenting with pelvic pain and infertility. We're also led by George Kondos in developing a tool for imaging and documentation of what is seen at ultrasound and MRI. And then finally, Aaron Greaves and Kaylin Bruner-Tran are leading new development of tools for experimental models, trying to introduce greater rigor and understanding so that we can better compare and contrast findings from different laboratories across the globe. And then finally, some new work that we're focusing on is in many ways inspired by the attention and intentions of the EndoMarch, recognizing that so many suffer from endometriosis-associated symptoms, but never achieve adequate treatment or even a healthy engagement with healthcare providers. And so we know that many of you here today may have struggled with this along your journey, that many remain silent, not recognizing symptoms as being problematic or embarrassed and stigmatized about them. Or when they present to healthcare providers, those providers don't understand the import of those symptoms and that this may indicate endometriosis. And so we've launched a new study called the WORK study, Women's Outcomes Research and Knowledge, focused for now enrolling across the state of Michigan, those who are not necessarily diagnosed with endometriosis, but those adolescents and young adults who are experiencing pelvic pain and may not recognize that this is an important indicator of health that needs some appropriate healthcare interaction. And we're collecting a great deal of information on their perception of their symptoms, their attempts to interact with healthcare and how they've gone, and also looking at referral patterns, misdiagnoses, and trying to give voice to those underrepresented, those who, as of now, their information, their path and their journey hasn't had a voice in endometriosis discovery. And then finally, we're most recently looking at the impact directly of COVID and the COVID pandemic on endometriosis, and whether those with endometriosis had a higher risk of COVID, whether the pandemic itself has impacted their access to care, their experience with their pelvic pain symptoms, their experience with infertility. And so that's new and exciting work that we're very interested in dedicating to doing now. So I thank you, and It's just such a pleasure to be here with today's panel and having these discussions.
Thank you very much, Dr. Misma. Fascinating, and thank you for being so up to date and including the patients with COVID, because often I know in our clinic, we regularly are asked questions about the, especially again, COVID and endometriosis. So congratulations on the wonderful work that you are doing with yourself and Dr. Zondervan. And for all of our audiences, as I mentioned, we are among the stars, and Dr. Mismer and Dr. Zondervan are next year heroes of the EndoMarch. So let me be the first to congratulate both of them and also announce it here that, again, Dr. Mismer and Dr. Zondervan, they are the next year heroes of the worldwide EndoMarch.
Thank you so much. We're both so honored and humbled by
thrilled.
this award.
Thank
you. My pleasure, our pleasure. Thank you so much. So we move to the last, but not the least, the Dr. Linda Judice. Dr. Linda Judice is very well known to the audience of the EndoMarch internationally, but I will proceed to further introduce her one more time. She is Distinguished Professor of Obstetrics and Gynecology and Reproductive Sciences at the University of California, San Francisco. She is the past chair of the Department of OBGYN at University of California, San Francisco. She is a biochemist and reproductive endocrinologist specializing in endometriosis, adenomyosis, ovulatory disorders, and infertility. She is past president of American Society of Reproductive Medicine. She has many accolades. It has been a pleasure for me to work with Dr. Judice for the past almost 30 years on endometriosis, and her contributions are enormous to endometriosis. And she, again, one of the original co-founders of the Worldwide Endometriosis March on Endometriosis Day and EndoMarch. So I welcome her, and Linda, proceed.
Thank you so much, Cameron. And I want to just express my gratitude to be able to participate in today's panel. I'll give a little background how I got into doing research on endometriosis. My PhD was in biochemistry, and I worked on the hormones from the pituitary gland that stimulate the ovaries. So of course, steroid hormones were always there in front of me. But then I needed something more. The human connection wasn't quite there for me. And so I went to medical school. And then after going to medical school, it became pretty clear that there were many areas of need, and women's health became something that I became very interested in, and then specialized in reproductive endocrinology and infertility. And it was really through that experience in caring for couples with infertility and individuals with infertility that I began to see that implantation was a new frontier, that despite IVF, there were many opportunities, and still the implantation rates were not keeping pace with much of the advances in IVF. So in my laboratory, as an early stage investigator, I began really looking at human endometrium. And around this time, I was at Stanford, and Dr. Najat was also there in Palo Alto, and we began operating together and talking about science. And the rest is history, because we have been really collaborators for, as Dr. Najat said, for a very long time. So our group in the lab focuses on human endometrium. And I did want to say that, I think Dr. Zondervan pointed this out, that in working with human samples, whether it's blood or tissue, one really needs to have standardization, because it's hard to compare a tissue from one group versus another if they're not handled in exactly the same way. And also, as Dr. Mismer also mentioned, how important it is to have what we call clinical annotation, so extensive characterization, and the Whorf effect questionnaires and database is really a treasure trove and so important for interpreting the data that are obtained in the lab for the clinical translation. So we began to first look at the so-called transcriptomics in the endometrium and the genes that were expressed across a normal menstrual cycle, so different hormonal milieu, and then became very interested in what was happening in women who had endometriosis. And then also, adenomyosis is not that, not always just observed in isolation, and many patients have both adenomyosis as well as endometriosis. And so we expanded our studies to looking at the endometrium of women with a number of reproductive disorders. We established a tissue bank at Stanford when I was there, and then when we moved to UCSF, that has now been transferred there. Dr. Najat's contributions were quite significant in that. And again, this has been really so important for moving this research on human tissue, because we only work in human tissues. We do not do animal studies like Dr. Taylor does, and I know he also does human studies. But ours are exclusively in human tissues. So we were among the first of essentially the original discoverers of what's been called progesterone resistance in women who have endometriosis. So at the level of the endometrium. And we know that the endometrium is the source of endometriosis for the majority of women who have disease because of retrograde menstruation. And what we found was that not all women, but some women who have endometriosis, within the lining of the uterus, the lining is resistant to or has aberrant progesterone signaling. So why does that matter? It matters because progesterone is so key to establishing pregnancy, keeping a pregnancy, and also for what's called normal tissue homeostasis, the whole menstrual cycle and then normal bleeding in the absence of pregnancy. And as we look a little further upstream, if you will, there are the lesions, and Dr. Taylor and others have shown that progesterone resistance can also prevail in the lesions. So it's not too surprising that some progestins may not work in terms of mitigating disease and symptoms. And in addition, there may be progesterone resistance in other parts of the body. It's not totally clear right now what's happening with the immune system, and does progesterone have a role? But it's important that progesterone is able to act because progesterone basically opposes estrogen, and endometriosis is an estrogen-driven disease. The other thing that we found in the lining of the uterus was that it looked like it had some inflammation in it, so-called inflammatory phenotype. And we and others have shown now over a number of years that this inflammation does play a role in promoting the resistance of progesterone and actually augmenting the actions of estrogen. So that can result in increased disease and also in increased pain. It can also affect fertility. And there are now ways of looking at inflammation in the lining of the uterus for those who have infertility by a biopsy, looking at, for instance, a protein called BCL6. The work of Bruce Lessig. So for us, this has been quite a journey. More recently, we have now embarked on characterizing and examining in great detail using some novel technology. And I think that's one of the beauties of science is to be, as technology is developed, technology drives biology, which drives technology. And so we are working now on characterizing the local immune system within the uterine endometrium, in the lesions, and also in the systemic circulation, so throughout the body. Just recently, we have been able to, we've been funded to essentially take a precision medicine approach to endometriosis. So this is essentially looking at multiple omics. I'm sure everyone's heard of genomics and proteomics and metabolomics. And we are working collaboratively with Dr. Najat's group and also a group at Stanford and our team at UCSF with regard to these various omics and also including exposomics, because endometriosis risk is about 50% genetic and it's about 50% environmental. And the advances that are being made in genetics, I think, are just fantastic. And our colleagues who are on this call are leaders in the field. On the exposomics and on the environmental side, we don't quite know as much. It could be environmental chemicals, and Dr. Mismer showed several years ago that women who were exposed in utero to diethylstilbestrol, which is like an estrogen, had a higher risk of developing endometriosis as adults. And there are other kinds of chemicals that might be influencing not only developing the disease, but also the symptoms of the disease. So this is an area that's really quite, I think, an area that we need to pay attention to. We don't have a lot of answers, but we certainly do want to find out what's going on, because there may be an opportunity then for prevention as we look to the future. So what we want to do is to be able to stratify the disease, discover patterns and pathways for diagnostic biomarkers and therapeutic targets, and to develop paradigms to predict treatment responses and, importantly, risk of recurrence of disease and symptoms after medical and/or surgical therapies. So these are ongoing studies. We really are so appreciative of being able to conduct these studies. We're very grateful to our collaborators and also to the women who donate their tissues and their blood so that these studies can be done. So I want to thank you, Dr. Najat, again for organizing all this and the team on the Worldwide EndoMarch, and I'm happy to participate in the question and answer session. Thank you.
Thank you very much, Linda. As always, your continuous work and for so much zest you are putting behind this. I congratulate you. It has been a pleasure to work with you for so many decades and helping the patient with endometriosis, and I admire your work and thank you very, very much for your continuous work to try to end the enigma of endometriosis. As I said, we have been among the stars today, and it is lucky for all the patients with endometriosis that we have people like yourself. So we have our fellows here, Dr. Shruti Agrawal, who is a second-year fellow. Fellows, for the purpose of the audience, we want to let you know they have finished all of their OBGYN training in excellent institutions in US, and now they are doing a program of the fellowship in endometriosis and minimal invasive and robotic surgery. Dr. Agrawal is the second-year fellow. Then we have Dr. Deborah Lee and Dr. Mahkam Tavallahi, that they are first-year fellows, and they have some questions for our panel. And I would start with Dr. Agrawal, Shruti, and Deborah and Mahkam. They are wonderful, the most incredible fellows, very hardworking, very interested, and it has been a pleasure for me to work with them. Shruti, please go ahead.
Good morning, everyone. Thank you. This has been very, very informative to know all the different researches going on. Our patients often ask us questions, so it's really nice to know that we can answer some of them. I have a question for Dr. Zondervan, actually. It's actually also a question. Good morning, Dr. Zondervan.
Hi.
It's actually one of the questions that one of the attendees has also asked, so I will ask on their behalf and mine, we often have patients that the first time mothers who come to us for the first time ever thinking they have endometriosis, and when we tell them that, you know, the symptoms are looking like they possibly do, their follow-up question always is that I have daughters at home, I have, you know, nieces at home who have similar symptoms to what I have. I mean, we literally had 2 patients just yesterday. So do you think that these women and girls, when they come in, they can be screened for genetic variants that can predispose them to endometriosis?
I think it's a really excellent question, and as you mentioned, it's one that we often, you know, hear, and unfortunately, I would have to say at this point in time we can't use that knowledge that we have for that particular purpose, and the reason is because the genetic variants we have identified, each of those increase the risk of endometriosis only by a very small amount. So if you add up sort of the whole sort of panel of 42 variants that we now have, that only explains about 5% of disease risk. And as you can imagine, you know, sort of putting together a test on the basis of that would really not be, you know, very helpful to women, you know, for screening purposes. So I think that the value for genetics currently is for us to understand the biology of the condition and to identify subtypes of disease and to try and identify new targets for the development of medical treatments that actually target those subtypes specifically. That's the vision that we have, but unfortunately they don't have use as a clinical screening tool at present.
I see. Do you think that will ever happen, where we'll ever have it to where we can just screen people and be like, you have endo or you don't?
So I think on the basis of genetics, it's unlikely. And part of the answer is as the statistics that Dr. Gies already mentioned, you know, only about 50% of endometriosis risk is genetic. The other 50% is environmental, and that's to do with factors that are, you know, that either predispose or potentially protect to develop endometriosis. So, so that's one. So only about 50% we know is genetic. Actually identifying all those variants that contribute to that 50% is a very, very difficult task indeed, and is almost impossible. And we know that from other disease areas. I mean, for example, if we look at a field like breast cancer currently, they're now nudging up to, you know, understanding perhaps about a quarter of genetic risk. And they're starting to think about, you know, can you know, tools that combine genetic risk variants combined with known environmental exposure, you know, risk assessment, family history, it all together, can that be developed into a tool that is useful for screening? But I think even then, the question is, well, the answer probably is it's a screening tool. It will never be a diagnostic tool. So I think we need to look at other ways of diagnosing endometriosis. For
right. A couple of genes in breast cancer, at least, that have a huge effect size. We don't think we're going to
Well, yeah, familial breast cancer, certainly familial breast cancer, but non-familial breast cancer, you know, the genetics of that it looks just the same as it does for endometriosis. So you're absolutely right.
Wow.
Yeah,
that's amazing. Do you think your project with EFFECT will one day be able to achieve this, like try to find out the environmental versus genetic factors for endometriosis? Is that the final goal of having the standardized data?
So I think what we're hoping is that, you know, if many research centres collect data the same way and collect samples the same way, we'll start to be able to leverage the power of those studies jointly and start teasing out these environmental factors that Dr. Gies also mentioned, and Dr. Mismer, and because we need the sample sizes to tease some of these effects out. So yeah, that's the hope.
Perfect. Thank you so much. I appreciate you answering my questions.
Oh, you're very welcome.
So next we go to our next fellow. Thank you so much, Rudy. You were great. Thank you so much for asking those questions. She is right. We saw these patients yesterday, and that was very good of you to think of it, that we had two of those patients that they were asking this question. And Dr.
Lee is our first year fellow. She's very dedicated mom, the hardest working mom and fellow that I have seen. I am very proud of her. Please, Deborah, go ahead and ask your question.
Good morning, everyone, and thank you so much for sharing with us all of the interesting research that you've been doing for some time and all that you're doing for patients. Like Dr. Najat and Dr. Agarwal have said, we see these patients every day, and you know, even just this webinar today is going to help so many people who have, you know, a lot of questions and concerns, family members who are having these symptoms. I have some questions for Dr. Mismer. Dr. Mismer, thank you so much for taking time out and for sharing all about your research and everything you're doing for women with endometriosis and pelvic pain, for adolescents with pelvic pain. We're in the middle of a pandemic. We're still going through the pandemic, and we know that the pandemic has had effects on numerous medical conditions, whether it's delayed care of known conditions or delayed diagnosis of unknown conditions. In our clinic, we have a lot of patients who, you know, had other conditions along with their pelvic pain or endometriosis, and so they couldn't come to see us. We hear about it all the time, and luckily now with the vaccine, people are feeling more comfortable coming in. We wanted to ask if you feel that the COVID-19 pandemic has had an impact on, you know, chronic pelvic pain and endometriosis in any capacity that you feel.
No, thank you,
Thank
Dr.
you very much, Deborah, for asking. And Dr. Mismer, exactly what Deborah is asking. And the same way, the majority of our patients, almost 95% of our patients who come to us, they are infertility patients who have endometriosis, who have not gotten pregnant, and they have had IVF, failed IVF, their husbands are okay, all of their lab works are okay, and we work with wonderful endocrinologists, REIs like Dr. Ebazadi, Amy here, and Dr. Sally Tazuke, Dr. Bake in Los Angeles, and Dr. Sunny June. And these patients that they have failed, and also Dr. Judith, of course, we do, and they come here to have surgery for endometriosis because they have been diagnosed by recent receptiva tests for possibly having endometriosis. And their question is constantly about COVID and what it is. So that would be great. Thank you, Deborah, for asking that question.
No, absolutely. It's certainly something that's impacting everyone, but those who, there's really two different areas of focus here. One is those who were already experiencing endometriosis-associated symptoms, whether they were chronic pelvic pain or infertility. How has the pandemic impacted that? And Dr. Lee, you alluded to something really important, which is that particularly in our pain-suffering patients, many already had coping mechanisms established, already had interactions with healthcare that were working successfully. And with the pandemic, many of those were upended or went away completely. And so the reality that those coping mechanisms now were no longer accessible or the access was diminished. And then add to that this heightened reality of stress. Many have had economic stressors, many have had familial stressors. So independent of whether women themselves have been infected, whether they have had access to vaccination, we're seeing changes and impacts that are negative and need to really be addressed. The second part is looking at whether infection itself is impacting these symptoms, whether it's impacting fertility, time to pregnancy, becomes a really important question that it is difficult to answer cross-sectionally, because again, we know that stress itself and large life upheavals do have impacts on pain and on fertility. And so we've really started going to those cohorts and those data where we have long-term information. So we have pre-pandemic information and post-pandemic information to compare and contrast. So for example, in our adolescent population, we are seeing that heightened stressors are resulting in higher, more frequent flares of pain, and less responsiveness to their current treatments. But we're also seeing that although in preliminary data, and we're just adding an extra bunch of data collection to reinforce this, but in preliminary data, we are not necessarily seeing that our patients with endometriosis have a higher risk of COVID infection. However, those who have had an infection seem to have a higher risk of longer term symptoms. And so they're more likely to be not necessarily fitting the full criteria of a long haul COVID patient, but they are on average having longer fever, longer upper respiratory impacts, and perhaps more severe symptoms. And so, these are very early days in these studies. A close colleague of ours, Lauren Wise at Boston University, she has a study that has been for almost a decade now, looking at women who are attempting pregnancy and factors influencing time to pregnancy. And she's now looking at whether COVID infection and or vaccination is influencing time to pregnancy. So far, thankfully, seeing no negative impacts of vaccination, but they're now looking at that infection information. So all very early days for data, but such important things to consider and definitely having impacts on the patients that we all care about.
I just add something to that. I'd really like to emphasize what Stacy said, is that we don't have any evidence that vaccine is harming anyone. There's good evidence now that it's not compromising future fertility. And I just want to make it very clear to everyone that we encourage you to get the vaccine. Certainly the risk of infection is clear. As Dr. Misper just pointed out, there may be some increased risk for long-term complications if women with endometriosis get this disease. So getting the vaccine is the right thing to do.
Absolutely.
Everyone should get their vaccine. The risks are even higher in pregnancy. And if you're infected and can't get your endometriosis care that you need, that could further compromise your condition. So I just want to make a clear plea to everyone to get vaccinated.
And absolutely, and Hugh, that's so important. And to reinforce again, we all knowledgeable in this footprint ran to get our vaccinations. We also ran to get our children who are eligible vaccinated. And so reinforcing again that that the vaccination is absolutely a critical step toward prevention.
Thank you very much, Dr. Mismer and Dr. Taylor. You don't know how much you really help our patient, because we receive all the time for our infertility patient. As I mentioned, the majority of our patients are patients who want to get pregnant and they have endometriosis, and this is their question. You don't know how many of them you really helped. And I promise you, your videos are going to be immediately given to all of our patients that they ask this question. That is, I say, here are the experts. You should listen about the COVID. And so I thank Deborah for asking. So, excuse me again. The last fellow of ours has a very interesting background. She quite knowledgeable, interested, and dedicated to endometriosis. She actually, beside OBGYN, she did a fellowship and work in pathology at Stanford. And I have known her for a long time. Before, she has had rotation with us. And she's so interested that despite not feeling very well, and I asked her, please rest. She says, no, I want to participate and I want to have the opportunity to talk to this panel. Dr. Makam Tavallai is our fellow, and it's a pleasure to have her. She's quite bright. And please, Makam, go ahead and ask your questions.
Good morning, everyone. Thank you very much for the impressive presentations. And I'm very impressed by all the research from everyone. So my question is from Dr. Taylor, actually. And it is a question that one of the attendees asked as well. And I was wondering, I think you briefly talked about how we think that endometriosis is a systemic disease. And
I'm thinking about when you're choosing medical treatment compared to surgical treatment for the disease, how are we choosing between the hormonal treatments, oral contraceptive pills versus the GnRH antagonist, and where are you going to choose between these two? And also, one of our attendees asked if we think that the hormonal treatments are only going to control the symptoms versus preventing endometriosis from progression. And is there any data and research on that?
Well, let me take that. I think there were several questions there. Let me start with progestins versus GnRH antagonists. I generally start with a birth control pill, an oral contraceptive, and tend to use it continuously rather than cyclically. But as Dr. Giudice pointed out, and was one of the first to identify the progestin resistance, it's the progestin, the birth control pill, that has the therapeutic effect, and a good percentage, probably up to a third of patients with endometriosis will have or develop progestin resistance and need to go on to a second-line therapy. In the old days, that was cumbersome with the GnRH agonists, the injectables, and the delayed onset of action and the profound suppression. With the GnRH antagonists now, it's a lot easier with an oral medication. Although there may be progestin resistance, endometriosis is always estrogen dependent, and reducing estrogen or eliminating estrogen can treat most endometriosis. But there's always a role for surgical therapy as well. I mean, removing the lesions is a rapid way to treat this. Removing lesions can help improve fertility. Removing scar tissue adhesions, no medication will do that. So they're disease that, not because it's resistant to estrogen deprivation, but because it's the damage and cause fibrosis, scarring, adhesions that will never be treated by any medication, that will need surgical therapy. So it takes an endometriosis expert. It's a subtle distinction as to what's treated by what means. But even after surgical therapy, I think medical therapy is a good idea to prevent recurrence and to help alleviate some of these systemic effects. My hope is that as we define these systemic effects better, that we define the mechanisms by which endometriosis causes effects on brain, on immune system, on metabolism, we might be able to specifically target those in ways that are non-hormonal, that may have fewer side effects. And that's something we're working on right now in the laboratory, that might be able to specifically target those systemic effects rather than this blanket approach with hormonal therapy. But for now, I usually would still start with an oral contraceptive. They're easy and inexpensive, and for a good number of patients, they're very effective. But always keep a close eye on my patients. I don't let anybody go for months without bringing them back to see if they're failing on an oral contraceptive. I think that's important. It's not the kind of drug you prescribe a progestin and say, come back in a year. Let's see how you do. You know that a large number of these patients will be resistant to progestin, and you need to bring them back for close follow-up and be clear that you can advance therapy to, I would recommend either a GnRH antagonist or surgical therapy if progestins fail.
Thank you very much, Hugh, and thank you very much, Malcolm. There are some questions from all the fellows that have told me, well, we know Dr. Giudice, we are working with her. So let me see what, they had a question. I think you can, all of you ask Dr. Giudice. Shruti and Deborah, you told me that you had a question. Linda, let me ask you, do you remember yesterday you told me I told you which one of you are going to ask question from Dr. Giudice, and you told me we would all know her, we want to ask her questions. So please go ahead.
Yes, sir, absolutely. Dr. Giudice, good morning. Thank you so much for being with us today and sharing more with us about your research. I had a question about endometriosis and infertility. We know that infertility is a condition with a wide variety of causes. There's many different treatments for infertility depending on what type you have. And we know that endometriosis can cause infertility or subfertility. So if a woman has infertility, are there any tests to diagnose endometriosis? And what kind of treatments are available to increase a woman's chance of pregnancy if she has endometriosis causing subfertility or infertility?
That's a great question. Thank you. So you're right. There are many causes for infertility and subfertility. And perhaps the most challenging from a diagnostic and therapeutic perspective is unexplained infertility, and also infertility or subfertility associated with endometriosis, so known endometriosis. And the usual paradigm is, as you know, ovulation stimulation and insemination, whether one uses letrozole or clomiphene for unexplained infertility, and also for endometriosis-related infertility. The issue, I think, becomes, if someone has unexplained, then how do we know if endometriosis may or may not be a cause of the disease? Surgery is one way to find out, as you know, a diagnostic therapeutic laparoscopy for the reasons that Dr. Taylor mentioned in terms of adhesions, plus also decreasing the burden of disease and the associated inflammation within the pelvis that can not only affect egg quality, but also with regard to embryo toxicity, and can affect the lining of the uterus, so the receptiveness, if you will. There is a commercial test, and I have no conflict of interest in this regard, called Receptiva, which has been marketed essentially to look for markers of inflammation within the endometrium. And this is looking at BCL6, which is something that should not be present in the endometrium, or is very lowly expressed in women who do not have endometriosis. And most of this work comes from Bruce Lessie's group. Dr. Najat and his team also have published on BCL6 as well with Dr. Sally Tazuke and your team. And so, when you send so should everybody get screened for it? We're not quite there, I think, with regard to everybody getting a BCL6 as part of their infertility workup from day one. The most, I guess, impactful part of getting a BCL6 test is with recurrent implantation failure, or with euploid embryos, say, after IVF. Now, maybe some people don't want to go through IVF and have 3 failures and then get a test. So it's not totally unreasonable. But if there are known causes for infertility, say severe male factor or ovulatory disorder, polycystic ovary syndrome, then getting BCL6 may not be the first item on the list. If one does get a positive BCL6 expression, which is an abnormal result, then the question is, okay, what can we do about it? And the data right now, I understand, at least on clinicaltrials.gov, there is a clinical trial underway and a randomized control trial. And the goal really is to understand what's going to help with regard to getting rid of the inflammation and therefore lowering the BCL6. So the correlative data that have been published suggest that, or demonstrate that, treatment with GnRH agonist or with progestin for 2 months or 3 months is correlated with higher live birth rates, both in the IVF setting and in the non-IVF setting. We don't really know, though, are these the optimal medications? Does it really restore BCL6 or decrease BCL6 expression? No one's done the assay after to see if the pregnancy happened because of that, or did it just happen by chance? And so I think the next frontier is assessment of inflammation within the endometrium, if that is essentially sort of the last frontier of the infertility evaluation and treatment. And we really need randomized controlled trials to understand what and if certain therapies will restore fertility and for what durations of time.
Thank you very much, Linda. That is wonderful. I appreciate it. And thank you very much, Deborah, for asking. And Dr. Agrawal, that you know, she also wants to ask you some questions about infertility and BCL6. And also she did a research, as you say, she published it. Perhaps she can talk about it and ask you. Go ahead, Judy.
Good morning, Dr. Giudice. It's been a pleasure working with you lately. So thank you for that. You were talking about BCL6, you know, being a marker for inflammation. And as the patients themselves learn that part too, they start asking questions about, you know, their body being inflamed. And if their whole body is inflamed, how should, you know, they take care of that? Because there are several things on the market for inflammation of the, you know, a lot of people start using turmeric nowadays. So they start asking us questions about what should they do for this systemic inflammation, how they should decrease it, if there's supplements for it. So what are your thoughts on these patients saying that?
Thank you for the question. My patients also ask me the same thing. And what I tell them is, because many come in with being on antioxidants and a variety of other anti-inflammatories, there are ways to, at least from a nutritional perspective, you know, the endometriosis diet has been suggested. The hardcore data, and I'd look to Dr. Mismer and Dr. Taylor to comment on that, because I think, you know, there's not everything has been shown to work. However, it may work. And at least as we sort of rationalize the mechanisms, we tend to support going after some of these anti-inflammatories. The other thing is with regard to whole body inflammation, I think it's important that we distinguish a highly inflammatory state from one that is subclinical or a low inflammatory state. And women who have endometriosis, for the most part, have a relatively low inflammatory state. I think being concerned that your whole body is on fire because of inflammation would be misleading. I see Dr. Taylor is shaking his head, and please feel free to comment, Hugh.
No, I couldn't agree more that it is a low-level inflammation. I mean, I think going too far with trying to combat inflammation can also have negative effects on implantation in somebody who's trying to get pregnant. If there's an inflammatory-like reaction that goes on in the endometrium that's required for embryo attachment. So we don't want to go too far. Some anecdotal or some interesting evidence on some anti-inflammatories like fish oil and resveratrol seem to be promising, but I wouldn't go all out with strong anti-inflammatories that could have other negative consequences.
Correct.
I'd like to thank you, but there are a lot of questions coming in. So we thank you for staying online, and with your permission, we will continue to address at least some of the questions, because a lot of more and more questions coming in this regard. So I would ask you some of them myself, that we believe, and as you said it, the question is, often they are asking, why do patients after surgery they get pregnant? Because we recently published a paper that Shruti Agrawal was part of it mainly, and Shruti, I'd like you to present it in a very short part, that when we saw the pregnancy rates ourselves, we couldn't believe this. Years ago, we published a paper with Dr. Giudice that essentially when she was at Stanford, they would send the patients to us who wouldn't get pregnant in their division. We did the surgery, and Eva Littman was the fellow. And at that time, it was a small number of patients, but the pregnancies were amazing. We couldn't believe it. This passed down until recently. We have had a large group of patients that they have no reason infertility. The husband is okay, the wife is okay, they have no pain at all. They only don't get pregnant. There are patients of Dr. Amy Abazadeh and Dr. Kelly Bake in LA, and Dr. Sadi Tazuka and Sunny June at CCRM, and Dr. Talebi Nejad in Talebian in New York, who works with Dr. Parnijat. When we did surgery in these patients and when we treated them, we could not believe the pregnancy rate ourselves. I questioned my fellows when they told me we have that higher pregnancy rate. I told them, are you sure? They went, they evaluated the data with the physician that I mentioned several times, and they said, well, this is the pregnancy rate. So if it is true, obviously we need surgeons who are very trained and treat endometriosis properly. As I said, I was questioning myself when they told me this patient, more than 90% of them, and even higher, getting pregnant either spontaneously or with continuous IVF. And I want Shruti to comment. And so there is a reason that it works when we treat the disease. The limiting factor is the skill and experience of the surgeon and the availability of proper instrumentation. It should be properly surgery done, number one, to cause no harm, not to cause problem for the ovaries, and also treat the endometriosis properly. And endometriosis is far, far more common than we think. And that is upon us to find a good method to diagnose it. And endometriosis globally, if we diagnose it and treat it better, probably would unlock, in my opinion, the treatment for ovarian cancer. For some reason, when we treat this patient surgically, properly, we have seen the quality of embryos better. We don't have randomized studies. It's very difficult right now to prove it. Sometimes Dr. June, Sonny June at CCRM tells me, look, I see the eggs are getting better. For some reasons, these people get pregnant. Dr. Judith has, in her paper with Dr. Cow years ago, showed all the reasons that they cause infertility. But these people, when it is done properly, they get pregnant, and we need more help people to get trained and treat these patients. Shruti, if you want to say something, go ahead.
Thank you, Dr. Najat. Yeah, we looked at these patients. They were aged around 29 to 47, and they were all trying to conceive beforehand. There were 74% of them were nulliparous. They'd been trying to conceive for about 2 years on average, and then they were all tested positive for BCL6. They all underwent surgery with us, and then we looked at the clinical pregnancy rate after some of them we lost to follow up. At the end of it, from the 75 patients, we had about 40 at the end of the study to look at. And when we published the paper, it was about 90% of them were able to get pregnant. And we kept following them. Right now, I know the paper should be updated. It's about at 100%. All 40 of them ended up getting pregnant. I went back and looked at these 40 patients to see how long they had been, trying to conceive before surgery, and then after surgery, how long it took them. That's the paper I recently presented at ASRM as a poster presentation. And it was 29 months to conceive before surgery and an average of about 4 months after surgery to conceive. And all of them had pathology proven endometriosis. So it also further solidified that the predictive value, the positive predictive value of BCL6 is pretty high.
I mean, we've known since the days of the EndoCan study that, a prospective randomized trial that showed surgery improves pregnancy rates. So I think this, and that was, stage 1 and 2 disease. That was not with the same level of surgical expertise. That was a group of different people performing those surgeries. So it's not surprising in more advanced disease and in the hands of a surgeon who can recognize the more subtle variants of endometriosis that really can completely excise it, that doesn't do harm to the ovary, that we might see some very good pregnancy rates with surgical therapy. It doesn't surprise me at all. It would be great if we could do a prospective randomized trial like the EndoCan, but I think these days that would never be acceptable. Who's ever going to allow a surgery without removing the endometriosis? We'll never be able to do that. But this data is exactly what I would predict.
Thank you very much.
Kind of prospective study I think that might be doable is for those who are BCL6 positive, to be randomized, say, to medical therapy for 2 to 3 months, and then a rebiopsy. So not necessarily a pregnancy outcome, because I think you're right. When patients have an abnormal test and they're trying to get pregnant, it's very hard. And I think we all understand that it would be difficult to recruit. But at least for proof of principle, I think there could be a randomized controlled trial looking at BCL6 positive patients and what happens on therapy to BCL6 expression. And then also probably another control group of BCL6 negative patients and see what happens in terms of response to medication.
Thank you very much. And that is, I'm glad you brought it up, Linda, that the issue is you have to remember the data that Dr. Agrawal presented. A lot of these patients, not only they had failed IVF, they also failed medical treatment. Finally, the physician decided, okay, let's do surgery. So they have already received medical treatment, 2 to 3 months of GnRH agonist or antagonist prior to also. There are questions for the panel, and this not a lot of questions, and any of the panel would appreciate it if you address it. They, one of them asked Dr. Mizmer that, do you think food preferences during the lockdown played a role in COVID in your patients, or should women with endometriosis be treated as high-risk pregnancies?
So, you know, the food question is a very good one. We certainly know that dietary patterns did shift particularly during lockdowns. I will say that in our adolescent population, where we're looking at before pandemic to intra-pandemic changes, their diets, they were mostly eating French fries and mac and cheese to begin with anyway. So, you know, we're not seeing informative dietary shifts, but it's definitely something that should be evaluated and certainly can have a relationship with symptom expression. In terms of pregnancies, that there's not evidence sufficient that anyone with endometriosis needs to be categorized as a high-risk pregnancy. I certainly defer to Dr. Taylor to weigh in here. There is some evidence of increased early pregnancy loss, but that's very different from categorizing patients as, you know, high risk to be monitored throughout their pregnancy. Hugh, do you want to lean into that one a bit as well?
There is some association with some adverse pregnancy outcomes, but these are rare. I would not call an endometriosis pregnancy a high-risk pregnancy per se. A slightly higher risk of some pregnancy complications such as preeclampsia, but it's still unusual and I would not consider someone with endometriosis becomes pregnant at high risk.
Absolutely.
Agreed.
There is thank you so much. I know that you were recently on the WHO panel at the ASRM, and all of you, thank you for being there, and there was a lot of interest. Would you please share, and what do you think is the plan of WHO, World Health Organization, for increasing awareness about endometriosis? What do they want to do? Can you share?
It was wonderful to see WHO put on a panel at the ASR meeting. We're very, very pleased that it's getting that sort of international recognition to increase awareness, to increase access. I think that's where it starts. This is a worldwide problem. It's not just here in the United States that awareness is inadequate everywhere around the world, and access is even worse in many places than in the United States. It's not good enough here by any stretch of the imagination, but you can only imagine what it's like in other places. So the attention brought to this by WHO, I am so thrilled that they are recognizing it and helping to increase awareness. Wonderful that they presented at ASRM.
Yeah, that they released the fact sheets. I'm sorry, Linda, that they released a fact sheet specific to endometriosis. It is hugely impactful and really not only raises awareness across the globe at various ministries of health, but starts to build the foundation for requirements around inclusion of endometriosis and pelvic pain in the dialogue about focus and responsibilities for healthcare across the globe. Linda, I cut you off.
No, I was going to say exactly the same thing, that on the World Health Organization website, you can access the fact sheet. It's an amazing acknowledgement on the part of WHO, and an important one. So their interest in it, I think, is quite firm, and I'm sure we'll be seeing more in the future.
So we thank all of you, and it is, as you mentioned, it is great to see that finally World Health Organization and other organizations are coming to the rescue and help of patients with endometriosis. As I said, by yard is hard, by inch is a cinch. And we are very pleased to see that some of the, everybody has, a lot of people are doing this. And we are very happy to see some of the efforts of EndoMarch is also getting globally and getting other people interested in women. If endometriosis was a man's disease, I really believe there had been significant progress. And I am a man, I am saying that. We see patients every day in our offices with our fellow that you don't believe it. They cry when we believe them. They say it is not in your head. They cry when they come, and finally they say, at least I know why I'm not getting pregnant. And you know, so it is something that needs attention to really believe our patients. It's not all the physicians mean well, they have good intentions. It is an issue that it is not on the radar of medical professionals, other people. We should let it know more. Autism is significantly a small number of people have autism than endometriosis, but endometriosis is not well known. It should be publicized more, and hopefully we do more. This has been a fascinating program. We thank very, very much Dr. Zandervan, Dr. Taylor, Dr. Mismer, Dr. Judis, Dr. Agrawal, Dr. Lee Tavallahi, and our organizer, Zoe Pennington. You have been great, and we really appreciate. Hopefully we can get you back in again in another session, because there is a lot of interest still, but I don't want to keep you. I know Dr. Zandervan has to go to sleep probably. But in the next 2 months, we are going to be in holidays. The other worldwide EndoMarch webinars are on the website, Worldwide EndoMarch. Go to the website and look at the webinars. You can look at them. And if you do think anywhere in the world you have endometriosis, the Najad Endometriosis Advisor of EndoMarch is free. You can use it. At least it could help you. It is highly, highly accurate. It has been taking many years for us to do it. Our fellows have confirmed it over and over. It is more than 92 to 3% accurate in diagnosing endometriosis on infertility patients and also on pain patients, in both of them. So we thank you, all of you. You have asked occasionally. Some patient was last week asked me, I wanted to donate. If you want to donate to any of these scientists, please look at their website. If you want to donate to Worldwide EndoMarch, please go to the Worldwide EndoMarch website. By yard is hard, by inch is a cinch. Forward we go. We are going to make this successful, and we will help the patient with endometriosis and their families around the world. We thank you. We wish you a greatest holidays, and we will be back beginning January with new sessions of Endo Explain, and we congratulate all the panel, especially next year Endo Heroes, Dr. Mismer and Dr. Zandervan. Thank you very much again, and forward we go. Bye-bye.
Thank you.
Thank you so much.
Thank you.
Bye-bye.
Good afternoon, everybody, and thank you so much for your time. My name is Gerard Paulian, and I am a worldwide EndoMarch headquarters volunteer. And today we have the EndoMarch representative from Team United Kingdom, Jody Hughes, joining us today. Thank you so much for your time, Jody, and how is everything going?
Thank you for having me. It's going really well at the moment, thank you. It could be better with the way the financial situation is in the UK at the moment, but yeah, it's going not too bad.
Well, I'm glad that everything's at least going okay. Well, I'm happy to announce that Team UK has been around for 3.5 years, and throughout this time, they have been making efforts to increase advocacy and involvement to fight endometriosis. And I was wondering if you could give us a rundown as to how Team UK's efforts have furthered endometriosis awareness in the area, and if you could tell us about any specific events in the UK that have been particularly successful.
So we try and get involved in as much government policy making as we can. We have sat on quite a few meetings for the all parliamentary group that get together. I think there's about 4 of them for endometriosis now in different areas. So there's work and pensions, there's disabilities. So we try and get to as many of them as possible so that we're advocating for the people that we support, so that their voices are really getting heard. We do as much advocacy and awareness as we can. We get out and do as much in the public as humanly possible. We shout in as many places as we can. We're getting into quite a few businesses now and talking about what endometriosis is and how people can support their employees. But our biggest thing that we're proud of is that we got all of the local talking services around us, so around Portsmouth and Southampton, and we got them all together and we sort of said, look, this is the situation. You're putting people with endometriosis and adenomyosis into a situation where they could be in a group session with a 60-year-old man with rheumatoid arthritis, and that's just not going to work. Like, people with endo and adeno are not going to want to talk about what is going on with them, and that older gentleman may feel really uncomfortable if that person did want to talk about everything that was going on with them, their ridiculous heavy bleeding and painful cramps and stuff like that. So we really we schooled them really hard on what the conditions are, and we said there needs to be a pathway for not just women with endo, but people that suffer with endo. So our trans and non-binary brothers and sisters with endo, so that we have somewhere safe that we can go and talk about it. And not just the regular CBT practices either, because most people with endo, we know, have done them CBT practices themselves. They will have dug deep and done their research, and 9 times out of 10 been through them CBT practices themselves. So if someone self-refers into the talking services around Portsmouth now, they will go straight into 3rd line counselling through our hormone health pathway, rather than having to go through CBT therapy and stuff like that. So that is like our proudest thing, and we're looking to roll that out across the country now. So yeah, that's our proudest moment.
Well, that's an amazing accomplishment. People that are going through endometriosis, of course, there is a sense of privacy. People, it's a careful subject, and you definitely need to establish that privacy. It's amazing that you've done so. So I also wanted to ask you a little bit more about that hormone health program. It's very intriguing. I was wondering if you could tell us a little bit more.
Yeah, so it's just what I just talked about, but it's just, we wanted to make sure that it's not just women with endo that are being looked after within that mental health service. It is our trans and non-binary brothers and siblings, because endo is such a lonely experience for our endo siblings, that we really wanted to make sure that they were looked after. It's one of the areas of my PhD study is how endo services for gender non-conforming people are so much worse than our female-bodied endo sufferers.
Mm-hmm. And with this hormone health program that you've established, would you say that as these 3.5 years have gone by, and of course it's not too much time, but since you've accomplished so much, has there been a noticeable difference in access to endometriosis specialists, or has that kind of remained the same throughout these years?
I think the demand for access to endometriosis specialists has increased. Unfortunately, due to COVID, the ability to get into said specialists has decreased. So the demand has gone up and the supply has gone down, which has increased our wait times, our wait lists. To get in to see a endo specialist at our local hospital at the moment is 18-month wait list.
Oh, wow.
Because over in the UK we have the NHS, so we get free healthcare, which is fantastic when it works, but unfortunately for chronic conditions it doesn't work quite so well. And we don't have very many specialists in endometriosis in the UK, which is, it's the same around the world. But our specialists don't get paid enough to be able to work full time. So they do 1 or 2 days a week. So we have 1 or 2 specialists that only work 1 or 2 days a week. That's in our local hospital anyway. It does change in different areas of the UK. London and Liverpool, the big cities are better than the smaller cities. But yeah, demand has definitely gone up, supply has 100% gone down.
And as we know, 1 in 10 people suffer endometriosis. With this 10% of people suffering, there is definitely enough cases, enough people going through this condition that will allow these specialists to work full time. It's totally applicable. So hopefully through your efforts, we can 100% see that change coming up in the UK, because it's definitely possible. We know you guys can do it.
Oh, it's definitely possible. And like you say, that there are so many people. And I think where there's so many good advocates now are across social media and stuff, and like the work that you guys are doing and the work we're doing, there's so many fantastic advocates that people are learning about it on social media and then going to their doctors and then getting referred, that the demand is just going to keep going up and up and up and up and up. So surely there has to be a breaking point that they will give us more doctors.
100%. And it's difficult for people going through suffering through endometriosis to like realize they have the condition, it's a possibility, when they're completely unaware of the condition's existence. So how do you guys propose to bring this condition to the forefront of people's minds to make sure it's aware that it's a possibility?
It's keeping on doing what we're doing, really. Keep going with the advocacy work, keep going with the awareness raising. Schools is a massive one, that I think all organisations are looking at getting into schools at the moment and doing better at teaching our young people. And not just young girls either, it's the young boys and our young trans and non-binary people. They all need to learn, because one day they could be parents, they could be uncles, aunties, whoever they are, they're going to know someone that has endometriosis. There's 1 in 10 people that have endometriosis, so they are going to know someone that has endo.
No, definitely. Do you guys have any efforts right now or coming up to educate the younger population at this moment?
At this moment, it's in the works. It is in the works. We have one of our trustees is a school teacher, and she is squirreling away behind the scenes, making fantastic resources. But we want to teach the teachers how to teach it properly, so that it's a self-sustaining prophecy, really, rather than going in and teaching the kids every year and keep going and keep going and keep going. If we can teach the teachers how to teach it properly, then it will be a self-sustaining model.
Of course. And comparatively to other teams, Team UK is very young, and hearing about this hormone health program in itself is a huge accomplishment for the 3.5 years that you guys have been established. You all should be very proud of yourselves. And we all look forward to hearing about all the amazing things that are going to happen when you guys get to your 10-year anniversary. We cannot wait.
I hope we get there. I really, really hope we do get there.
And truly, Team UK has made very monumental impacts towards endometriosis awareness, not only in the UK, but truly everywhere. Thank you so much. Are there any last words you would like to add on behalf of your team?
Just not to forget our trans and non-binary brothers and sisters and siblings, because they are left out of the conversation and they really shouldn't be.
No, of course, everybody, this condition can affect a wide array of people, and nobody should be put down because of how they conform or how they act or how they look. Everybody should be treated equally, definitely.
Absolutely.
Thank you so much for everything, and I hope everything goes well. Have a great day.
Thank you for having me.
Hello. I just wanted to start by thanking the AGCES and the Worldwide EndoMarch for this, and Doctors Cameron and Farnazat for this opportunity to speak today. My talk today is on fertility preservation and endometriosis. And as mentioned, my name is Dr. Linda Sung. I'm an associate professor of the NYU Grossman School of Medicine, the Division Director of Reproductive Endocrinology and Infertility at NYU Langone Long Island Hospital, and I work at the NYU Reproductive Specialist of New York. I have been practicing infertility for approximately 26 years, and I'm going to start by sharing my screen. And my objectives today are to review fertility preservation treatments for adult females with endometriosis who wish to have children now or in the future, and to discuss what embryo and egg freezing cycles entail and the process for getting pregnant when ready, and to suggest who may benefit from fertility preservation. This graph here shows that, unfortunately, as women age, our pregnancy rates decrease, our miscarriage rates increase, and in the United States, our CDC has shown a delay in childbearing over time, and over tenfold delay since the 1970s. And in terms of women physiology, women have the maximum number of eggs when they're 4 to 5 months pregnant in their mother's womb before they're born, about 4 to 5 million. At birth, it becomes 1 million. When they hit puberty and they finally become reproductive, it's approximately 300 to 500,000 eggs, in which they ovulate 300 to 500 eggs during their reproductive lifetime until they hit menopause. As we get older, the number of genetically normal eggs also dramatically decreases. So fertility fact is that pregnancy rates are higher in younger than older women. Miscarriage rates are lower in younger than older women. There is a delay in childbearing that will definitely contribute to infertility, and therefore strong reasons to preserve fertility in younger than older. Let's talk about some endometriosis facts. Approximately 30 to 50% of women with endometriosis will experience infertility. And the chance of getting pregnant each month for women that have no endometriosis is 10 to 20%, and with women with surgically documented endometriosis is 1 to 10%. So women with endometriosis should consider preserving their fertility by freezing their eggs or embryos as soon as possible. Let's briefly discuss how endometriosis affects reproduction, and I more particularly want to discuss fertility options for reproductive age females. So I'm first going to talk about freezing eggs and embryos, then I'll talk about freezing ovarian tissue, which is considered experimentally in the United States, and then I will talk about the use of hormonal suppression and or surgery prior to conception and or after fertility preservation. So when discussing freezing eggs or embryo, it's like doing an IVF cycle. So commonly, we may start our females with oral contraceptives, and some women who are having endometriosis may be on it, and then you would stop it, and then you would go on to doing hormone injections. These hormone injections are given to grow eggs, and the more eggs a woman has, the higher her estrogen is. The higher her estrogen is, as we know, the more stimulation for endometriosis that can happen. So sometimes what we do is we can give letrozole, which is an aromatase inhibitor. And what aromatase inhibitors do is they inhibit the conversion of testosterone to estrogen, thereby lowering the overall estrogen levels during the stimulation. This injection stimulation is approximately 2 weeks, followed by a trigger injection. Commonly, HCG is used, a pregnancy hormone, or LH, but we end up, for our women with endometriosis, giving them GnRH agonists that will help to stimulate the LH surge, but eventually downregulate and lower the estrogen after the egg retrieval. Sometimes before the stimulation, we don't give any of these modalities, depending on how low her egg reserve is, and sometimes we give them birth control pills with Lupron prior to starting to help minimize symptoms. Now then, the egg retrieval is performed under transvaginal ultrasound, and a vaginal ultrasound is placed in with a needle guide into the ovary, and the eggs are aspirated on the right and left side. And as you can see in this video here, the needle goes into the ovary and the oocyte is aspirated, and all of the eggs are collected on both sides. Once the eggs are collected, if you're freezing eggs, we freeze the eggs at that point in time. If you're freezing embryos, we put the eggs and sperm together, and sperm source can obviously be male partner, donor sperm, known donor sperm, and you can either dump them in the petri dish and let them fertilize in vitro if it is a good semen analysis normal sperm. If there is a low count or low motility or high abnormal shapes of sperm, we may opt to do ICSI, which is intracytoplasmic sperm injection, where we inject the sperm into the cytoplasm of the egg. From there, we mimic what would have normally occurred in the fallopian tube in vitro in our laboratory. So after putting the eggs and sperm together on the day of the egg retrieval, we check the next day to see if they fertilized, and we see if they're hopefully growing mitotically 2-cell, 4-cell, 8-cell, bunch of cells to a blastocyst 5 to 6 days later. And when we check on them, we see how many of those fertilized eggs make it to that blastocyst stage. That is the stage that's ready for implantation. So at that point, we can either freeze the embryo, or if the desire to do pre-implantation genetic testing is wanted, we can genetically test the embryos before we freeze them. And this particular technique will check to see if there's 46 chromosomes and the sex of the embryo. And as well, it can rule out things like Down syndrome, any aneuploidy, abnormal number of chromosomes. The pre-implantation genetics technique involves biopsying cells from the trophectoderm, which is the placenta to be, then doing polymerase chain reaction, where you denature and amplify the DNA. Then we sequence them through the next generation sequencing to see which of these embryos are normal. As I mentioned, you can freeze eggs for women who are not interested in having a baby now. We've developed new techniques approximately 12 years ago with vitrification, where it's an instant freeze, and it minimized the damage of the eggs, which have a high water content, from forming ice crystals, which could damage the intracellular structures, such as the nucleus that has the DNA and the genetic material. So this has revolutionized the outcome for freezing eggs. And when we do freeze eggs, we do notice, though, that the outer layer, the zona pellucida, hardens, and I believe it's to protect the egg. And so therefore, when you eventually thaw the eggs to put with sperm and hopefully have the baby, ICSI must be performed. Frozen eggs from females that are 35 years or younger can result in a cumulative live birth rate of 65%. And freezing immature eggs is at present in the United States experimental because the pregnancy rates are not comparable. But we do freeze immature eggs in our NYU institution, and with the hope that as technology continues to progress, we will have better techniques for in vitro maturation. So factors in considering fertility preservation is, do you as a woman desire having a children either now or in the future? How old are you? Because obviously the younger you are at the time of the freeze, the higher your live birth rate and the lower your miscarriage rates. We do check ovarian reserve, which is a blood test called AMH, anti-Müllerian hormone, and a blood test called FSH and estradiol that's done on the 3rd day of the period, as well as doing a pelvic ultrasound to measure the antral follicle count, the little cysts on the ovaries. These tests do not have predictive value on what future fertility may be like. It just gives you a snapshot of today's fertility. So with women that do not have endometriosis, they tend to have a higher AMH and a higher AFC, and women who do have endometriosis tend to have a lower AMH and a lower AFC, again demonstrating the lower pregnancy rates because of the lower number of eggs in women with endometriosis. I mentioned that when doing these cycles, modifications to the IV cycles can be done. And after the egg retrieval, you can give hormonal suppression treatments if you're presently not trying to conceive. You can also do surgery. Should surgery be done before or after fertility preservation? Well, as I mentioned, fertility preservation can aggravate endometriosis symptoms since eggs produce estrogen. And after the egg retrieval, hormonal suppression can be used to minimize overall estrogen and the symptoms, or surgery can then be performed, followed by potentially hormonal suppression. So sometimes the surgery is delayed to freeze eggs first, but sometimes the egg surgery is performed prior to the egg freezing, and we do definitely recommend this when there's a case of having difficulties to access retrieving those eggs, either transvaginal ultrasound, or we've developed a transabdominal technique to get the eggs. This is all balanced with the woman's egg reserve, her age, and her desire of whether she wants to have children now or in the future. As I mentioned, ovarian tissue preservation can be done. Historically, whole tissue was performed, but now freezing the ovarian cortex tissue, which is the outer layer of the cervix of the ovary, is now performed. And I do believe that there is a role for ovarian tissue preservation for endometriosis patients, and it's for those that are about to have surgery or are considering surgery, because in doing so, if there's an endometrioma, a cyst in the ovary, there is a possibility of removing the ovary. And there can be an option, if the ovary is removed, to freeze the ovarian cortex at the time of the surgery and then transplant it, put it back in later on. The transplant can be put in orthotopically at the original site of where the ovary was, or it can be put in heterotopically at other sites, such as under the skin of the belly, in the forearm, under the peritoneum in the belly, under the rectus fascia. So the problem with transplantation and the reasons why it is considered experimental is that the pregnancy rates are lower, and the biggest risk factor for failure is the revascularization, reforming the blood supply once you transplant. What are the advantages of first doing fertility preservation before long-term treatment, hormonal treatment, and/or surgery? Well, when you treat for endometriosis, you're putting them in a low estrogen state. So after the retrieval, you can give hormonal suppression, you can do surgeries, and these long-term hormonal medical treatments can be given to minimize the endometriosis symptoms and its progression, and therefore minimize its future negative effects on fertility. Once you have frozen these eggs or embryos and the woman is ready to have her future baby, then since treatments have already been utilized to minimize recurrence and symptoms of endometriosis, you can immediately stop those treatments and start to help try and get them pregnant. So generally, the time to conceive is much shorter, and therefore the time for endometriosis to recur is minimized as well. After freezing, and if you have frozen eggs, as I mentioned, ICSI would need to be done. You can grow them to blastocysts and transfer them, or you can genetically test them. And we do have to freeze the embryos in our facility, and then we do a frozen embryo transfer. With a frozen embryo, you can just immediately transfer it in a cycle. The cycles we tend to use are what we call a natural frozen embryo transfer cycle for women that have endometriosis. And these are women that hopefully ovulate on their own. So you would stop whatever treatments you are doing for them, monitor their ovulation. Sometimes we do a trigger shot, and then we transfer the embryo. And we can give supplemental progesterone support. Sometimes we can use aromatase inhibitors if they're not ovulating to help them ovulate, and then do the trigger and transfer the embryo and possible supplementation with progesterone. This minimizes the estrogen source and therefore the potential recurrence of these symptoms. Prior to doing a frozen embryo transfer, sometimes we recommend an endometrial biopsy to test for a marker called BCL6. And when we do the biopsy, it's sampling cells in the endometrial lining. And we have found that this BCL6 can negatively affect implantation. And so those that have that positive marker have an 11% implantation rate versus those that tested negative have a 59% success rate for live birth. And if we do find that they have this marker, we can treat with GnRH depot agonist treatment for 2 to 3 months, or to perform surgery prior to doing the frozen embryo transfer. And possible candidates for this are women who don't have explained fertility, because as we know, some of them have endometriosis, the actual history of endometriosis, and those who have unfortunately failed to implant with everything else looking normal. So who can benefit from fertility preservation? Any woman who's interested in using her eggs to have a baby now or in the future. Freezing eggs at a younger age maximizes the quality and quantity of eggs, and anyone who may require surgery or the surgical possibility of removing one or both ovaries, you can freeze eggs or embryos prior to and possibly after the surgery. Anyone who would benefit from hormonal suppression to help control the spread of and or progression of disease symptoms. And this hormonal suppression can be done either before or after fertility preservation. For women that are severely symptomatic from endometriosis, it's better to start with the long-term hormonal suppression in order to get pain management and then perform the fertility preservation once she is stabilized. Other options, if women are not able to freeze eggs or embryos and are experiencing infertility, are doing surgery. And it is very important to pick a surgeon who has expertise in fertility sparing surgery and works with fertility specialists to maximize fertility now or in the future by balancing the need to ablate and resect endometriosis and with improving symptoms of endometriosis and minimizing damage to fertility. And of course, there's the intrauterine insemination IUI techniques that only work if the tubes are open, IVF, in vitro fertilization, if the tubes are not. And you can use any combination of the above, and including possible hormonal suppression in treating women with infertility. If you're still unable to achieve pregnancies, donor eggs if there is a low egg reserve or an egg quality issue, gestational surrogacy if there's concern for not having implantation failure, adoption, foster care, or just having the choice to not have children. So in conclusion, women with endometriosis experience higher infertility, and it is important to discuss fertility preservation options with a fertility specialist for any adult females who wish to have children and are experiencing symptoms consistent with or has endometriosis. Egg and embryo freezing are standards for fertility preservation, but I do believe there is a role for ovarian tissue preservation, although it is considered experimental. This obviously has to be balanced with the age of the woman and her egg ovarian reserve with the symptoms of the endometriosis. And consideration to preserving fertility at a younger age can greatly improve pregnancy and live birth chances for women with endometriosis and allow for better management and less severity of endometriosis through earlier and longer hormonal suppression, which obviously would have to be stopped when the woman is trying to get pregnant. I want to thank you all for your attention from all over the world. Thank you for attending, both women, friends, as well as colleagues. I'd like to thank the American and Global Congress of Endometriosis Subspecialists for their invitation. I'd like to thank the Worldwide EndoMarch for sponsoring this talk, and in particular want to thank especially Dr. Farnazad, who I've worked very closely with through my 20-something years of performing the infertility field that I have in, as well as Dr. Cameron Nazat. Thank you again.
Hello everyone, I'm Dr. Wang from Bronx Care. It's my honor to be invited by Dr. Nazat for EndoMarch, and today my topic is surgical management of endometriosis. Before I talk about the surgery, I think other topics about endometriosis are also very important and it's good to know, such as the definition of endometriosis, etiology of endometriosis, presentation, diagnosis of endometriosis, medical therapy, diet modification, physical therapy, pain management, sexual therapy, and psychotherapy. Endometriosis surgery is probably one of the most challenging surgeries in GYN field, and there are several rules that I followed in my own practice. Number 1, surgical management is always the last step. Number 2, pre-surgical counseling is the most important step. Number 3, the pre-surgical workups are fundamental. Number 4, I think this type of surgery should be only performed by the expert but not by general OBGYN. Number 5, The surgery is a debulking surgery, and we need to dissect out all of the endometriosis lesions, no matter where's the location. But in the meantime, we should minimize the complication and do no harm to the patient. Last one, the surgery is not a cure. Most patients still need non-surgical management and long-term follow-up after surgery. Pre-surgical counseling and workup are as equally important as surgery itself. I would not bring any endometriosis patient to OR without proper counseling and workup. It's true that there's no definitive diagnosis of endometriosis without surgery, but with thorough history and examination, more than 80 to 90% of the chance we can detect endometriosis in clinic. The history includes the time of menarche, the bleeding pattern, dysmenorrhea, dyspnea, if there's any chest pain during period, the history of infertility, neurologic deficit, bowel symptoms, or urinary symptoms. The examination is completely different from general OB/GYN examination, and I will talk more details in next slide. We also need to ask the patient about her priority of the treatment. Is it for pain or for infertility? Because sometimes the management can be different. We also should educate our patient that endometriosis is not a cancer, but it behaves like cancer and is a progressing disease. Endometriosis is unfortunately not curable. Therefore, we need to set up a realistic goal to the patient. There's no magic medication or surgery can cure your disease in one shot. The treatment of endometriosis is multidisciplinary, not only surgery. We probably need to involve multiple specialties, multiple personnel, and multiple approach. We also need to display all the possible complications and our backup plan. It's also important to tell patients sometimes pain can be the same or even worse after surgery, especially the nerve endometriosis. Therefore, the bottom line, the surgery is always the last step. Pre-surgical workups normally include physical examination and imaging study. I normally perform cardiac testing to check abdominal muscle pain, the fibrous testing to check the joint pain, and also the pelvic examination to check the superficial and the deep muscle pain, and the uterus pain, and also if there's any nodules around the uterus. Transvaginal ultrasound is the first-line imaging study for endometriosis. Some of the centers are so good they can almost detect all of the endometriosis lesions in the pelvis. So they can map the endometriosis lesions in the pelvis even before the surgery, so the surgeon can do proper preparation for the patient, such as the bowel prep or collaboration with colorectal surgeons. For centers without excellent ultrasound support, we use MRI. MRI is also an excellent modality for endometriosis. Overall, we want to have as much information as we can get, and we don't want surprise in OR. Now I want to present you a short video about endometriosis surgery that I performed several years ago. In this video, I want to show you number one, the endometriosis surgery is a debulking surgery, meaning we need to dissect out all of the endometriosis lesions as much as we can. Number two, when a patient has deep infiltrating endometriosis, the surgery is excisional but not only ablation. Number three, the safety. In this video, I demonstrate the preserving of the nerve, avoiding the injury of the ureter, careful checking the bladder and the bowel after surgery. I hope you enjoy this short video. I put a probe into the rectum and the endometrial lesion was shaved off from the rectum. The deep infiltrating endometriosis lesion is very close to the ureter artery and the ureter. They were excised without injury of the artery and the ureter. More endometrial lesions were excised from left uterosacral ligament, and the left hypogastric nerves were well preserved. The integrity of the rectum was checked here. Extensive endometrial lesions were also found on the bladder. Large amount of endometriosis were shaved from the bladder, and the bladder muscle were reinforced with suture. The staging of the endometriosis is recorded per AAGL classification. Dr. Farnazat was my mentor, and he is always my mentor. I cannot thank him enough for training me and guiding me. I always wish you the best, sir.
Hello, my name is Roya Tagavi. I'm a Worldwide EndoMarch Headquarters volunteer. I'm here today with the EndoMarch representatives of Team Kenya. Once again, it's nice to meet you all, and thank you for taking the time to answer some questions today. To start off, how did you all become involved with EndoMarch?
Okay, thank you so much. Yeah, so we first heard about EndoMarch about 3 or 4 years ago. Yeah, we just saw it online, and it was a call for anyone to participate, and we thought, why not? And so that's how we just participated in the first one. Yeah, so it was just really online around March, because of course, well, slightly before March, of course. It was just talking about, submit your videos, say something, we're rallying around, bringing endo warriors together. And we thought, wow, I mean, this looks like fun and something we'd want to be associated with.
Amazing.
Yeah.
So 3 to 4 years ago, pretty recent. So in your opinion, is it easy or is it very difficult to find an endometriosis specialist in your area?
Yeah, thank you very much. Maybe I can respond to the question, and thank you for inviting us to this meeting. We are so grateful. In Kenya, of course, we do have few endometriosis specialists, but it's not easy to reach them because most people do not know about this condition, and most of the time when they go to the hospital, they are going there with issues of menstrual, like the cramps and so forth. And the gynecologists, at the first instance, they are not able to say it's endometriosis. So they end up just giving some pills or some treatment, which is not really related to endometriosis because of lack of diagnosis or proper diagnosis. So the few experts that are available, most people do not know about them, and maybe when the condition has worsened, that's when people start looking for really specialists. So it's a bit challenging in terms of accessibility. And what actually we are trying to do is creating awareness about endometriosis so that it's no longer a myth, but actually it's a reality. So that now people from the early stages, if they have some serious pains, they can actually try to get specialists so that at least proper diagnosis is done. So that is the challenge we have. But at Endo Sisters, I think we are trying really our best to be able to advocate for access to treatment and diagnosis, especially because there's no treatment, it's just management of the condition. Thank you.
Right. So you mentioned lack of proper education and awareness regarding endometriosis, and of course the lack of access and knowledge to endometriosis specialists leads to these diagnostic delays, of course. But what else do you think contributes to that diagnostic delay or lack of access, I guess, to an endometriosis specialist?
Yeah, thank you. You know, the issue also is the method of diagnosis is mainly laparoscopy.
Right.
And laparoscopy, it's more or less a surgical procedure. So, and not all hospitals or not all clinics actually have the laparoscopic equipment. So most of the time, before people reach to say that let's do laparoscopy, first of all, it's a bit expensive. So that is not like the first line of options that are available, but also accessibility to it is also a challenge. So that is also the other issue that that leads to lack of access or misdiagnosis. Thank you.
And maybe to add something, also the lack of excision specialists is also a problem. Yeah, so we have gynecologists who can perform, laparoscopy at least for diagnosis, but the excision surgeons has been lacking. So that's been a problem. And maybe Havin and Amina, you'd like to chip in?
As you said, it's just lack of awareness and also the thought of going for the surgery, and even access to the excision specialist is just not there. So that has been the challenge.
Right. So it seems, from my understanding, it's both the lack of resources and lack of training and knowledge that contributes to all this, like diagnostic delays and improper, I guess, treatment of women going through endometriosis. So I wanted to ask, now going back to the efforts, your guys' efforts, how have they increased or furthered endometriosis awareness in your area?
I think the most notable, okay, sorry, Amina, please go ahead.
I was going to say we have the yellow nail movement. So what that is we partnered with some salons in Kenya, which started in 2019. So the idea was to paint your nails yellow and then use the hashtag yellow nail movement. Because yellow is sort of not a common color, it gets the conversation going. So people ask you why you need yellow, and you get them started. It's because of endo, and then they get to find out more about that. So it gets the conversation going, and then more people know about it. Yeah, and so just targeting young women and adolescents.
Thank you. In addition to what you have said, we have a lot of campaigns in high schools because at the adolescent stage, sometimes these issues start early and it's not clear because when they have pain, they think it's just a normal menstruation, but sometimes it's actually associated with endometriosis. So even starting from the early age, we have made effort to try and give them knowledge on this, that when you experience severe pain, most likely it might be endometriosis and it's better to look for the specialist. The other thing Endo Sisters have done is also to talk to Endo warriors who come over to give their experiences to other women and say actually how they were feeling before they got the proper diagnosis. So that is also giving confidence for many women to come forward and be able to share their experiences. So those are some of the efforts that we are doing actually to bring awareness of endometriosis to people of especially reproductive age where the problem is common. So Doris, do you want to add?
Yes. I wanted to add that we also have research. We've undertaken a research study together with Columbia University in the US. And we were looking at women living with endometriosis in Kenya. And so it was just published in March of this year. And from the study, we were able to identify issues such as stigma, access to proper healthcare, self-efficacy, social support, like, as issues, as critical issues. And so, by creating awareness on these shortcomings, has helped also in helping to create awareness on the condition.
The thing we do is actually also telling them the progress of research. Personally, I am a researcher. I work with the Institute of Primate Research, and also I'm the board chair of EndoSisters. So I bring the research experience and actually the efforts that we are doing to be able to deal with this issue. And that is very positive for the women who are living with endometriosis, because what we do is testing new treatments that are coming to the market and trying to see the efficacy, how they can reduce pain and all this. And just trying also to share what alternative there is. EndoSisters also have gynecologists on board who actually also provide counseling to the women who are living with this disease, and trying to provide with them available options. So that is really positive for anybody who is sick, because you want to hear, what can I do when I have this condition? So that is also bringing many women on board, and they are coming out to speak their experiences. Just like what Doris said, in the publication that we made, many women shared their experiences, how endometriosis started from their youth throughout their life, and those experiences are recorded on how it was affecting their quality of education, their quality of life, and also in the communities they live, all those challenges. So the challenges are also contributing to actually give confidence to those ones who have similar conditions, that actually they can be able to overcome the challenges and be able to move on with life. So these are some of the things that we do to be able to share the experiences, so that many people can have positive thinking about this life, and they should, and then they are able to move on. Thank you.
Yeah, I actually took a look at that recently published paper with Columbia University. And I think in the realm of healthcare, research like that is so important, especially for an area like Kenya, because there's a lack of awareness. There's a lack of education regarding endometriosis in the area. And so I believe that a research like this brings about more awareness, especially in the realm of healthcare. So that's really amazing. Back to when adolescents were mentioned, I read about the book that you guys recently published. It was called When Something is Wrong.
Yes.
That aims to enhance awareness culture among younger population to encourage seeking early diagnosis, I guess. So how do you, so if you could tell me more about this book, and also how you ensure that this book reaches the hands of young adolescents.
Okay, yeah, thank you. What we did initially is that we lobbied the Ministry of Education and actually really pushed for having education on not just menstrual health, which was we had already started for grade 7, but also going a step further and talking about menstrual disorders, which was, now something new for grade 8. Of course, that now would bring in the issues of dysmenorrhea, painful periods, and that's where you find issues such as endometriosis. So we lobbied for that, and we were very happy that the ministry actually accepted and incorporated it in this new education system, so that then all kids have access to this information. And then the book itself, When Something is Wrong, is written in a very, very simple way. It's a story. It's seen through the eyes of children, of young adolescents rather, both girls and boys, who are just, just discovering and learning about this education about menstrual disorders and, and all that, and then learning about the different terminologies, adenomyosis, endometriosis, and learning about this. So it's told in such a nice story manner so that it's engaging for them and it's easy for them to understand. So what they take home from the book is, after they read it, they're able to say, wow, so these are the symptoms. If I have this kind of symptoms, then I ought to go and get medical assistance. Yeah, these are the things that would, I need to go and get get diagnosed if this is the way my periods are presenting. We even talk about amenorrhea in the book, so that if you have never seen your period, then that's something else. Yeah. So that's what the book is about. And so through the ministry, we've tried to do that. And of course, we are also actively seeking donors who will help us even further distribute the book. Yeah. And likewise, maybe I should add that it's also, once we wrote it, we got it reviewed and endorsed by the Kenya Obstetrics and Gynecological Society. So they also reviewed it. Yeah.
Wow, that's amazing. I don't, it's hard to see policy changes these days. And for you guys to have already enacted this this change, especially in the context of education, is so important. And to target the younger population is such a great idea, because yet again, they're not aware. They're not aware of normal menstruation. They're just starting to experience these things. So to target the root, then I think we could start to see change, and maybe adolescents seeking help. And I really can't wait to hear about what Team Kenya continues to accomplish. It already seems like you've done a lot, but your efforts are going to continue to raise awareness around such an important issue, and I can't wait to hear more. But before we end, are there any last words that any of you would like to share?
Yeah, thank you. Again, is to appreciate you for inviting us to this meeting. And because all these issues of awareness, advocacy also requires resources, we are appealing to anybody else who is willing to partner with us, give us support in terms of finances, add to what we have, the small we have, so that actually we ensure that all women better access healthcare and they live better. So thank you.
Thank you so much. And thank you again for your time, and have a great rest of your day.
Okay. Thank you so much.
Thank you.
Yeah. Thank you very much. Have a nice evening.
Bye-bye.
Goodbye.
Hello, I'm Dr. Kamran Nejad, the founder of the Worldwide EndoMarch and the Worldwide Endometriosis Day. I welcome all the viewers, and I give my greatest greetings to all of you. Worldwide EndoMarch is very thankful to all of its chapters around the world and in more than 60 countries for their significant contribution and calling to arms and responding to raising awareness more and more on a daily basis about endometriosis. Since its inception, all of you have been fantastic. Every time, every day, in the news media, you see more articles about endometriosis, and hopefully more involvement of the government, more funding that would lead to more research and finding a method to prevent endometriosis. a method to diagnose it earlier, and a method to cure it. More medical societies are advocating or giving time to endometriosis. Example of it is International Society of Gynecologists and Endoscopy in the month of March devotes one session all about endometriosis, and it is open to all the public. So we thank you very, very much for your contribution and your interest to help young girls and women with endometriosis. The session today is about a lot of misunderstanding and myth about endometriosis. Many of these misunderstandings have been in the cultures around the world for years. We have an excellent panel that are going to address that, which includes Dr. Azadeh-Nejad, Dr. Sina Nejad, and Dr. Joel Osayas. And we have another great panel of the patients and advocates that they are going to tell their stories about what has happened with their life and the misunderstanding and myth about their life that we are going to address those. That includes Ms. Tiffany Letowski, Ms. Carla Cressy, Dr. Stacy Holt, and Ms. Christina Divan. So I welcome all of you again. And as we said, Worldwide EndoMarch is a philanthropic organization. We participate and we appreciate and we welcome all of your participation in any way you want. There are many, many webinars that we have addressed past issues like endometriosis of the bowel, bladder, ureter, diaphragm, pain, back pain, infertility and endometriosis, and ovarian cyst and endometriosis and endometriomas. All of them are available by and has been discussed by excellent panel, and you will see their view. In this session, we also appreciate, we acknowledge Dr. Farah-Nejad, who is having another assignment and couldn't be here. And also we appreciate our other co-founder, Miss Barbara Page. We thank all the assistance that headquarters of the Worldwide EndoMarch is giving, including Zoe Pennington, Sean Stetner, and the rest of the physicians of the headquarters, Ms. Shruti Agrawal and Janelle Jackman and Melanie Salem and Genesis. Thank you very much for your participation. And we will start with Dr. Azadeh-Nejad, who is an endometriosis specialist. And her main interest is endometriosis in adolescent and teenagers. Dr. Azadeh-Nejad, please go ahead.
Good morning, everyone. I hope everyone's doing well. I was going to talk today about the some of the myths about endometriosis. The first one was going to be there is a cure for endometriosis, a curable disease, but unfortunately, that is not correct. We only have, at this point, we only have treatments that helps the pain or symptoms of endometriosis. The other myth that I was going to talk about, it is that hysterectomy cures endometriosis. That is also incorrect. We know that only hysterectomy helps the symptoms of adenomyosis, which is endometriosis into the muscle of the, growing into the muscle of the uterus. We know that if you do hysterectomy, which is the removal of uterus and cervix, it helps the symptoms of adenomyosis, which is
bleeding and cramping with the menstrual cycle. The other misconception is I hear it all the time that people talk about having total hysterectomy, and they would think that having had a total hysterectomy affects their ovarian hormones and puts them into menopause. That is also incorrect. Total hysterectomy means removal of the uterus and cervix. When we talk about, as physicians, about total hysterectomy is just removal of the uterus and cervix. When the removal of the ovaries and the fallopian tube are talked about, that's when the hormones are affected. So when you remove the ovaries and the tube, it's called bilateral, whether it's the both ovaries and the fallopian tube is bilateral oophorectomy, and then bilateral salpingectomy means that removal of the both fallopian, whether it's unilateral versus bilateral is removal of the fallopian tubes is salpingectomy. So those are some of the misunderstanding or misconception. So to kind of wrap it up is when we talk about hysterectomy cure for endometriosis, unfortunately, there is no cure for endometriosis. At this time, there are only certain type of treatments, and hysterectomy does not cure endometriosis. That's another misunderstanding. Only particular type of endometriosis, which is the adenomyosis, those symptoms are when you remove the uterus, obviously, you would not have heavy bleeding and cramping with your periods, and has nothing to do to treat endometriosis at that time. You should, there is always the removal of the removal of the lesions or endometriotic lesions that is over, whether it's over the ovaries or anywhere else in the pelvis. Those are also considered treatments for it, not necessarily definite cure for it. Another misunderstanding is that if you get pregnant, it would cure the endometriosis, which that is incorrect. When you're pregnant, the symptoms of the endometriosis would
All right, well, it seemed like we had a little bit of problem with the dog. That's no problem. So as Dr. Ozzy was addressing the issues of the pregnancy is a cure for endometriosis, exactly correct. When you are pregnant, it is not a cure. Pregnancy doesn't cure endometriosis. Only symptoms disappear at that time, but the lesions of endometriosis stay there. Endometriosis, we have to remove it, and when we remove it, it doesn't mean it is cured. It could reoccur. Okay, Dr. Ozzy Najat is back. Now
I apologize, bad timing as far as the postman coming to the door. So I was talking about, I'm sorry for interrupting you, Dr. Cameron. So basically, there's only treatment for endometriosis. The hysterectomy does not cure, it's not the cure for endometriosis. Because as long as you have the ovaries and the fallopian tubes and stuff, there's a possibility that the lesions that remain inside of in the pelvis, anywhere they were existing before the hysterectomy, they would cause pain and they will cause discomfort on the other symptoms that is associated with endometriosis. I was talking about does pregnancy cure endometriosis? It does not. We know that while women are pregnant, their symptoms of endometriosis are reduced, but and while they're not, because the hormonal changes that is caused by pregnancy would affect the activation of those lesions in the pelvis. But once the baby is delivered, and once the cycles are resumed, the endometriosis and most likely the symptoms of endometriosis would return. I think there are many other myths that is I see on the internet, but I only have 5 minutes, so I'll hand it over to Dr. Cameron, and if their other panel is not addressing them, I'd be happy to talk about the does herbs cure the ovarian cysts, or excision versus ablation? What is the difference and which one is better, and how does it affect the symptoms of the endometriosis?
Thank you very much, Dr. Azinejad. That was a wonderful start. Great. Now we will proceed with other myths that endometriosis does not affect only affects the white professional women. And we have Dr. Joelle Osias, who is an endometriosis specialist. Also, she has had background on training in endometriosis, and also herbal therapy, and also diets, different methods of alternative therapies. And we welcome Dr. Osias, who has been a long persisting panel of the Worldwide Endometriosis March and EndoMarch, and with background training in Tufts, Johns Hopkins, Stanford, and etc. in her training. Go ahead, Dr. Osias, welcome.
Oh, hi, Dr. Nisha. Can you hear me?
Very well.
Can you hear me? Okay,
yes,
perfect. All right, thank you so much for this opportunity. Okay, thank you. Yeah, thank you for the opportunity to talk about addressing some of the myths about endometriosis. I think Dr. Oz, they did an excellent introduction about some of the misconceptions that a lot of patients have about endometriosis. Some of the things that we've encountered is some disparities in the diagnosis of endometriosis, particularly in women from different ethnic and socioeconomic backgrounds. As you've alluded to, there's a perception that endometriosis is a disease that affects affluent Caucasian women, but that is not the case. I think, unfortunately, endometriosis does not discriminate, and it does not impact a particular ethnic group or a particular socioeconomic status. So all women are vulnerable to the symptoms of endometriosis, and women from Afro-American backgrounds or Hispanic women can also suffer from endometriosis. But the challenge that they experience is the lack of sometimes access to care, or the tendency to have their symptoms be dismissed and not properly addressed. So that can cause a delay in diagnosis and a delay in treatment. Dr. Najat has often taught us that there's often a very long delay between the patients experiencing symptoms and getting their disease diagnosed, to be as long as 7 to 10 years. So that means a lot of women suffer unnecessarily and do not get the help that they need. So that's a big issue for women who are seeking to enjoy a normal quality of life, or to have their symptoms properly addressed. in terms of getting the diagnosis, one of the main symptoms that women have is, as Dr. Ozzie mentioned, heavy bleeding. That's often due to the endometriosis involving the uterine wall. And as she mentioned, that is treated effectively through hysterectomy. But unfortunately, endometriosis is not limited to the pelvis. So people oftentimes think that endometriosis is only a disease of the pelvic organs. So we think about the uterus or the ovaries or the pelvic abdominal cavity. Unfortunately, endometriosis can affect many different organs, like even the lungs, the diaphragm, the brain, anywhere where the blood vessels travel, the endometriosis can implant itself. But you're right in the sense that endometriosis is primarily affects the pelvic organs and the abdominal cavity, but it's not limited to those areas. And then endometriosis, often people perceive that it's only about pain. So the hallmark of endometriosis is painful periods, but the pain can occur outside menses. So people can have pain during intercourse. They can have pain that radiates to the rectum, pain that also radiates down to their legs, back pain. So pain is definitely a very common feature of endometriosis, but it's not the only symptom that can occur. And there are many women that have severe endometriosis and don't have pain. So pain, unfortunately, is common, but it's not the only defining symptom of endometriosis. And I think of endometriosis as the great masquerader, because oftentimes it presents in some enigmatic ways, and it's very important for the physician and for the patient to have a high index of suspicion so that they can remember to do a thorough evaluation to make sure that they don't miss the diagnosis. So for women who are experiencing symptoms, I think part of the purpose of Dr. Nejat's Worldwide EndoMarch is education and empowering women so that they know more about their own physiology, so that they can know how to address their concerns to the right professional so that they can get the help that they need. Because there are some biases, both on the side of physicians and also for oftentimes women don't feel strong enough to advocate for themselves to make sure they get the help that they need. The other big issue that women encounter is being told that it's all in their head and that they should just bear it and that they're being hysterical. And so I always reassure patients that it's never normal to suffer from your menses, and that if you're having persistent symptoms, that they should continue to ask for. And if you're have to fire her and get someone who's going to be listening to you and be willing to take your symptoms seriously and do the appropriate workup. The last 2 minutes I wanted to address is the perception that endometriosis is always improves with menopause. Although it's true that menopause can alleviate the symptoms of endometriosis, but it's not always the case. Because as you may already know, endometriosis is a hormone-dependent condition, so that the presence of estrogen is more likely to cause the symptoms to be exacerbated. And so oftentimes people may experience a relief of their symptoms after menopause, but that is not always the case. So the importance here is for being vigilant about making sure that if you're experiencing pain, experiencing symptoms, that you address your concerns to the appropriate provider. And if that provider is not adequately trained or doesn't listen, to make sure that you continue to search for the right person. I think the benefit of the internet is that it's empowering us as women to look for the right help, look for physicians like Drs. Nejat, who've devoted their entire lives to making sure that women's voices are heard and that they know that we are here to help and that we are committed to helping them get better. Lastly, we talked about the idea that that pregnancy cures endometriosis. Dr. Azadeh Nejat already addressed that the pregnancy just masks the symptoms, but that the symptoms are likely to recur after a woman delivers, because the hormonal changes are gonna resolve, and with the disruptions of menstrual cycles, the pains is likely to come again. Some patients ask me about the use of supplements to help with pain or help with ovarian cysts. There aren't any supplements that are going to help ovarian cysts per se, especially endometriomas. There have been in the literature back in the 50s, some report about using iodine for simple cysts, but I don't think it's likely to help women with endometriomas, which are what we call them complex cysts, because they're not as they have more, we call it cellular debris, and they're not simple. And so for those patients, I don't think that's iodine is going to help per se. I do think that diet plays a role in lowering inflammation. So for my patients with endometriosis, I do recommend a healthy lifestyle, avoiding sort of genetically modified foods, and making sure that they avoid things that are going to create more inflammation, because that's going to worsen the pain. So I think that endometriosis is a very important issue that affects a lot of women throughout the world. And I'm so grateful for Doctors Najat for the work that they've done throughout their lives to make sure that this condition is properly recognized and properly addressed, and that we as physicians become more sensitive to the needs of our patients, and as well as that patients are also informed about the availability of expertise throughout the world to be able to address their needs and make sure that they enjoy the best possible quality of life. So that's finishes my section.
Well, I thank you very much, Dr. Rosayas. That was fantastic, as usual. Now we proceed with Dr. Sina Nejat, the co-founder of the Worldwide EndoMarch, that he is going to address some other of the myths and misunderstandings about endometriosis.
Thank you very much. I'm Sina Nejat from Atlanta, Georgia, and my greetings to all of you around the world. One thing I like to supplement to Dr. Nejat and Dr. Rosaya is about a better understanding about endometriosis. We think endometriosis is one disease. It is not. We have different variation and different manifestation of endometriosis. There are subtypes, like we have diabetes, different diabetes, or better compare it is different type of, for example, ovarian cancer. Endometriosis could be infiltrative. Endometriosis could be scattered or localized. Endometriosis could be superficial, or it has different manifestation like typical, atypical. And also, when we talk about the pattern of the function of endometriosis, it could be progressive, it could be inflammatory, it could be infiltrative. So having said in the background, I would like to supplement to the two previous speakers about, for example, pregnancy could cure endometriosis. Pregnancies could not cure endometriosis, but in certain cases could slow or stop the progress of the disease. So instead of being progressive or infiltrative, it could stop it. That's why we use certain medication to create a pseudo-pregnancy. On the other hand, like menopause, they say menopause stops the hormones, so it could cure endometriosis. It does not, but it could slow down the process. So this is the one thing I like to address. The second one is endometriosis, adenomyosis, and a type of hysterectomy. For many years, since early 90s, we have advocated that patients who have deep infiltrative endometriosis and severe pain involving the vaginal, rectovaginal area, and the cervix, it is not a good idea to leave the cervix behind unless surgical safety indicates. So supracervical hysterectomy or subtotal hysterectomy for infiltrative endometriosis and pain and adenomyosis causing bleeding would not completely take care of the problem. It is better to remove the entire disease along with the cervix. I supplement what Dr. Nejat and Dr. Rosaya said. Hysterectomy just removes the uterus. If a person has endometriosis on the diaphragm or on the side walls or on the intestines, they remain the same. They require their own treatment. So in our patients, even if they want to have a hysterectomy, we advocate first treat pelvis and extrapelvic endometriosis, and then do the hysterectomy for a long-term better results. Thank you for the opportunity. Thank you very much, Dr. Sinanejad. You notice all the presenters that the myth about endometriosis. Some other myth that it is very important to address is not always patients who have endometriosis have pain. A major portion of the patients with endometriosis have no pain at all. Why does endometriosis cause pain sometimes and sometimes it doesn't? That is an enigma to a large degree, but it could be explained. I often explain for my students and fellows, endometriosis is like a piece of sand in your eye or a rock in your shoe. If the rock is in your shoe and the sand is in your eye, it causes a lot of pain. But if the sand is in your pocket or the rock is in your backpack, you might not even notice it at all because it is not sitting near a nerve. When the endometriosis is sitting on a nerve and causes inflammation, that is why it is causing pain. That is one reason. So endometriosis doesn't always cause pain. And actually, a lot of times there are couples that they are trying to have a child and the husband is completely okay, the wife or the partner, the female partner is completely fine, all the tests are normal, they don't get pregnant. In our experience, the majority of these people, more than 90% in our hands, in our practice, have endometriosis. So couple who try to have children and they don't have children and everything is normal, it is not normal. That could be endometriosis, and endometriosis could have no symptom. That is very important to address. So saying all of that, there are some other myths that we are going to address. And I would start with our first speaker, Tiffany Litowski, that she is going to address all of the discrepancies that she has noticed as a patient over the years when she has been dealing with endometriosis. Tiffany, please go ahead.
Hi, Zoe, can you just take my video off? It's not letting me add my video back. Thanks. Sorry about that. Hi, thank you so much for letting me share my story. So, first of all, thank you all of you for addressing all of these issues for us women and people with endometriosis out there, and just debunking these myths that a lot of us. I am an advocate for endometriosis. I work with Dr. Farnajat, for those of you who don't know me, and I also help out with everyone else here in the Endometriosis Worldwide EndoMarch and the Najat Family Foundation. I help out a little bit getting these things set up. And one of the things as an advocate, these myths are constantly being asked, even as just working with Dr. Farr in the office. I see a lot of these questions constantly. Patients come in with these. So just thank you all so much for doing this today, because it's really important issues that everybody really needs to hear the correct answers to. So I appreciate that. But my story that I just wanted to share was I have endometriosis, and I started suffering at a very, very young age. I actually started feeling sick a lot before I even got my period, like around the time that I was starting to, I guess, go through the hormones were changing. And at that time, I have a few women in my family. It's actually pretty prominent in my family. There are a lot of women in my family, unfortunately, that have endometriosis. So I was one of the few that as a young teenager actually knew what it was, because I'd seen relatives that have had it. So it was something that was mentioned to me very young when I started having a lot of the symptoms of a lot of, constant pain all the time. I was fainting a lot. All of those things, that go hand in hand with the heavy bleeding. I was missing a lot of school. So my mom actually took me to the doctors pretty young, right after I got my period when I was 12, shortly after, sometime in that 12 to 13 year. And unfortunately, I was told at that time, even though we have family members that have had it and very young that have had it, that hadn't had children, I was told that as a Latina young woman, that I needed to worry more about getting pregnant because typically Latinas are very fertile, and that I shouldn't even be worrying about endometriosis because this is something that happens to women much later in life after they haven't had children, and you know that maybe later on in life decide to try to have children like in their 40s, and that I was way too young to be worrying about this, and it's not something that I could possibly even have. So that was initially immediately how it was brushed off. So not only was I completely judged just for being a Latina girl, I was not sexually active at all at the time. I was very young, and they basically made it like they put me on birth control right away and said, this is something you need to worry about. You need to go on birth control. And over the course of the next several years, I had a lot of cysts that ruptured. I had a lot of stuff going on. I was in and out of the emergency room. All the way back then, it already started that I was in and out of the ER. And they basically just treated me every single time saying, you just should have pelvic inflammatory disease. Let's just check for STDs. Are you sure? Like, how many partners have you been with? And just really stress the fact every time that I went that it was like a sexually transmitted disease that was causing my pain, that was causing all of these different issues that I was having. And again, much of the time prior to this, I was not even sexually active at all. And they just, made it like, this is just something, this is what's causing it. And I didn't really think much of it at the time because I was so young, but now obviously as a woman and looking back on all of it, that really impacted me in it. It took a toll negatively on my mental health as well, because they were telling me, basically, you're going to have no problem getting pregnant and you don't need to worry about this. Come to us when you're 40 if you're still having issues, blah, blah, blah. And fast forward to after I had a few surgeries, because I actually wasn't diagnosed properly with endometriosis till my third laparoscopy. The first two, they said I just had scar tissue and they said I don't have endometriosis, but the third one, they finally found it. And after my third one, they said, now I was in my early 20s, after all these years of being told birth control is going to fix it, if any problems you have, and you'll get pregnant and it'll go away if you have any problems. Now I was told after all that, you're never going to be able to have kids. And I was told, you've had 3 surgeries already and you're 22 years old. It's not going to happen for you. So it was like the flip flop from one extreme to the other that really, impacted my mental health a lot at that time, because I didn't know what to think. I didn't know what to do. I felt like I wasn't being helped, in any way, which many of us, with endometriosis feel, unfortunately. That's why I'm so thankful for all the doctors like you that are out there helping us and getting the right education out there. But, this is something that's a common misconception. And this was many years ago now. We're talking like 20 years ago, but doctors are still thinking that way. Still now, we have patients come to us and tell us that they said, oh, if I got pregnant, it would go away. And for me personally, I did get pregnant. I'm happy to say I was not infertile and I did get pregnant, and my endometriosis got worse after I had children, like a lot worse. So, this is just one of those myths that really needs to be, knocked out of the park, and they need to really get the correct information out there.
Thank you very much, Tiffany. That is a fantastic story that you said. And, unfortunately, as Tiffany said, still to this day, we see patients that adolescent girls, teenagers, they come and they say, I have seen so many physicians, and they say, oh, don't worry about it. It is something you are imagining it. Your ultrasound is negative. Your colonoscopy is negative. Your upper GI is negative. all of your MRIs are negative, you don't have anything. And are you sexually active? And perhaps this is sexually transmitted disease. She said that she is not even sexually active. Well, they said, well, you have irritable bowel syndrome. Well, it is not irritable bowel syndrome. And then if they continue, but you need some antidepressant. So Tiffany is absolutely correct. Unfortunately, it still continues. And thanks to all of you around the world with EndoMarch and other endometriosis organizations that you are trying to educate and debunk that this is not correct, it is not in your head, it is not hysteria. And unfortunately, Freud made it worse for women, that they call it hysteric women. So pain is not normal. And if you have pain, it should be evaluated. And if you are not able to get pregnant and everything is normal, you don't have pain, that could be endometriosis. Endometriosis is multifaceted, should be taught everywhere, and in the medical schools, in different disciplines, all the organs could be involved. And we do not want women and their families, their mothers, their fathers, their husbands, their wives, their children to suffer. So that is, we appreciate your education, Tiffany, and your work. Another person who has suffered a lot because of the same concept is our next speaker, and that is Ms. Carla Cressy. She is in England, and Tiffany was in New York, and Dr. Sayas was in Dubai. All of our speakers from internationally that are speaking. Carla, we would welcome you. Thank you for staying, for sharing your story. And please go ahead and explain your travel or journey with endometriosis and your the misconceptions about what happened to you.
So my story is a little similar to Tiffany's in the beginning, where my symptoms started really early on. I think I was 13 when I first started going to the doctor. My periods, they were just really irregular, terribly painful. So when I was 14, I was put on my first pill. And by the time I was 17, I tried, I think, 6 or 7 different birth control pills, but nothing helped. And I would just bleed all the time. I would collapse in pain. I had migraines. I was always fainting and taking time out of school. So things just progressed. And I remember I'd keep a diary. I'd always keep a period diary, and I'd write down all the days that I'd bleed. And there was one time I bled straight for about 60 days. And I just remember my doctors quizzing me, like they didn't believe me. So yeah, I had quite a battle with the doctors. But then once I turned kind of 2021, that's when things started to really progress, and I was being taken to and from the hospital a lot, sometimes 3-4 times a week by ambulance. And they would kind of suggest pelvic inflammatory disease, IBS, sleepy bowel syndrome, because I had a lot of bowel symptoms. Again, I would just be given pain relief and sent home. And it got to the point when I was kind of around 23 where my bowel would just stop working, and I would go 2-3 weeks where I couldn't physically go to the toilet. And my periods were so awful that I lost my job because I was just passing out all the time in pain. And I was just in the hospital more than I was at home. And that's when a doctor kind of said to me, "Oh, I think you might have endometriosis." So I went into surgery and they diagnosed me with stage 2, but they had done ablation. So after that surgery, nothing got better. My symptoms kind of come back even worse. So I was back and forward to my GP again, saying, something's not right, it's not helped, things are getting worse. And I just kind of had to persevere with it. And then 6 months after that surgery, I was rushed into hospital again with suspected appendicitis. At first, they thought it was gastroenteritis and sent me home. And then the following morning, I was taken back into hospital again. And they rushed me into surgery and removed my appendix. And a few days later, I was still in the hospital and I was getting worse. My infection the markers were through the roof, and I just wasn't getting better. I was really, really poorly. Couldn't stop being sick. So I had the drains and everything, and it was horrible. So they rushed me back into theatre again, and this time they cut me from hip to hip, and they drained a lot of blood from my pelvis, and they said that they described that it looked as though someone had kind of opened me up and poured cement into my pelvis, that there was just scar tissue everywhere. And that's when I was diagnosed with frozen pelvis and stage 4 endometriosis. So from then, I spent a good few weeks in the hospital just getting better. And then I was sent to a specialist hospital who done loads of MRIs and scans. And luckily for me, my endometriosis showed up on the MRIs, and even the physical exams, they could feel the nodules, and it had kind of invaded my cervix and my intestine and everywhere. So I then went on to have more surgery, and that was just to kind of look around and plan for an even bigger surgery, which I had October last year. And the endometriosis had just progressed and it invaded my intestine, everything. So I had to have a pelvic clearance. So they removed my cervix, my uterus, my ovaries, fallopian tubes, and part of my bowel. So I now have a colostomy bag and full hysterectomy.
But thank you very much, Carla, for sharing your story. And we are sorry about all what you have gone through. And thank you for your encouragement and for trying to spread the word for the benefit of other patients and people. So as you can see, endometriosis is not only a disease of reproductive organs, and endometriosis could affect all the organs, including bowel, bladder, ureter, diaphragm, and sometimes, unfortunately, a patient could be involved with all of them. And that is another one of the goals of the Worldwide EndoMarch, to encourage more education of EndoMarch in the medical schools across the world. And this is happening. I'm happy to report to you again, more and more societies are getting involved in teaching endometriosis. As you know, Society of Laparoscopic and Robotic Surgeons was the first society who started teaching and training endometriosis specialists 5 years ago, and we have been training endometriosis specifically specialists for the past 5 years in our training program. And that brings me to the next speaker, Dr. Stacy Holtz, that she is going to share with you her story and the misunderstanding about endometriosis that she was confronted with and had to deal with. Stacy?
Thank you, Dr. Najat. Thanks for this opportunity. I think that my story, often many of our stories have a common thread. And for me, I would say I could sum that up with the word enigma, that endometriosis has been an enigma for myself as well as to many of the doctors along the way before meeting Dr. Najat and Dr. Abazadeh before that, which helped me on my journey. So I would probably say I first heard the word endometriosis in my 20s when I had periods and throughout my adolescence. I was actually a distance runner in high school and college. So I would have painful, irregular periods, go sometimes 8-9 months without a period, and also have periods that were what I would term crime scene periods. They were very heavy and severe. I had anemia during my collegiate career and sometimes in high school, but the doctors would just dismiss it as, oh, you're a distance runner. So I'm not sure if that was the cover up, but I think that I just went along with that at first because it was an enigma to me, and I just thought, okay, I guess that makes sense. And fueled on. And then as time went by, and certainly as I was in my 20s, I started to have more symptoms. And maybe it wasn't because I wasn't as heavily distance running, but also I started to have a lot of bowel issues, and something that hadn't been present when I was much younger. And I actually, by the time I remember right before I married my husband, and when we were dating, there would be times we'd go out on a date and I could barely make it home before I would be having awful bowel symptoms, whether it be diarrhea, severe cramping, like someone was kicking you. And right before our wedding, I actually had to go to the ER. And I had an emergency, if you will, colonoscopy and upper GI scope. And this was not in my early 20s. By now, it's probably mid to later 20s. But this journey had been where the doctors would just dismiss, oh, you had amenorrhea or you missed periods because you're running. We're going to have you take birth control pills to try to manage this. And then with that ER visit and the consequential colonoscopy, the doctors, and there were many after that, that would say, oh, well, you seem like you have ulcerative colitis, but your biopsies were pretty normal, but we still think you have ulcerative colitis or some variant of that. So I continued through the decades, if you will, while concurrently not distance running always, but later distance mountain biking, I would concurrently have a physical journey through this. And I had pain, but I guess I would say it was the analogy of like any endurance race or ride. I had pain, but I didn't know what I had until it was gone, which is more recently in the journey. It's not gone forever or gone for sure, but what I mean by that is kind of weaved into this fabric of being dismissed by doctors. And when I would inquire, could this be endometriosis? And I have to admit, I wasn't a good study up on this, since I was learning other species, all the other mammals with tails. I was not as apt to. I would advocate for myself, but I didn't learn this subject matter well. And so if I asked a question of a doctor, oh, could this relate to endometriosis? Because it didn't just happen with periods. It didn't just happen. It was a constant draining, not something that, I mean, I still was able to carry on with a career. There were times I would obviously have pain. It was debilitating, but it was definitely something where the lifestyle choices I was making to be fit and have better races, clean eating and exercise, those endorphins helped a lot. So that helped me get through that. But I think the main misconception that I had, and that the doctors had until meeting doctors that listened to me, is just dismissing that there's no way that could be endometriosis. And I unfortunately usually accepted that sometimes, or just, on to the next colonoscopy. And then as far as the journey more recently, that wound through some decades there. It did seem to have progressively worse symptoms, but I was still chronically taking the birth control pill. And when my husband and I have been trying to conceive, that's something where we actually, when I was not taking, obviously, the birth control pill, I did have some more symptoms, but I think it really became more recognizable when I had an endometrial biopsy or receptiva test that showed that it was a very high score. And it kind of was a wake-up call for me that I needed to, and thank you to my doctor, Dr. Avazadeh, who did that, because it was something where it then enabled me to find answers, and it enabled me to have, I did go through some medical treatment like Depo-Lupron, which I always joke is from the devil, but the medical treatment of that, and then more recently surgery with Dr. Najat. And I feel a lot better. During surgery, there was endometriosis of the bowel. Go figure, right? So it was likely, I anticipated, and I think Dr. Najat would echo it, it may have been there for decades as far as the adhesions and the severity. And so it was something that I hope that just sharing this, and I hope that continuing onward, all of us can increase the awareness, because for me, it was basically this naive college kid, if you will, then winding throughout life and not realizing that the pain that I had from, whether it be my back, my bowel, my pain with going to the bathroom, if you will, I always thought, oh, maybe I just overdid that workout, or that was because I did that 12-hour race. Just, you know, the misconceptions, and it's something that once some of that pain has been removed, it's just an amazing experience to like have your life back. And I think even more so was to have Dr. Najat listen and say that it wasn't in my head, that this was something that had been there. He had the scientific evidence. And so it's something that if more people can have help sooner, and we can increase the awareness, I think that's going to obviously benefit so many women worldwide. So thank you.
Thank you very much, Dr. Deval. That is the story, again, here important, that we would like to thank all of you from around the world who are trying to help raise awareness about endometriosis, because we need to help young girls and women from the early age. Dr. Deval's story and Tiffany and Carla, they didn't, and Stacy, they didn't start it. It took 10 years to 15 years that they to be diagnosed, and that's not fair. Imagine in the good world, if everybody's condition is diagnosed very early. Yes, even now we cannot treat them and cure them completely, but at least we can use some measures that women, young girls, they don't suffer so much and they don't get compromised with their reproductive organs. And that is when there is pain. Imagine those who have no pain, no issues at all. As I said, the story of the sand on your eye or the rock in your shoe. So if we have a method to suppress the disease on the ovaries, that it doesn't destroy the ovaries ideally, or find a method that this young girl might have endometriosis, so if it is possible, she could freeze her eggs. These are methods that we have to work on and eliminate the myth. But by yard is hard, by inch is a cinch. Step by step, we can educate and progress and get things better and better. Especially again, endometriosis doesn't always cause infertility. Some women get pregnant with endometriosis very easily. Why? Some people have no pain at all, and they don't get pregnant and they are infertile. Those couples who do not get pregnant and all of their tests are normal, the majority of them are having endometriosis, and they should be evaluated. And that is a myth that endometriosis always causes pain. It doesn't. And that's bringing me to the next guest, Christina Deval. And again, I would like to thank Christina. And I think I mentioned Dr. Stacy Holt's how she addressed the issue of the bowel endometriosis. And now we will proceed with Christina. Christina, welcome, and please go ahead.
Hi, so I'll very similarly to a lot of the other people who experienced endometriosis, my symptoms started when I was pretty young. I was 15 when I first started having to call out from school because the pain would get so bad. I would sometimes have to go to the bathroom and throw up, like during class. So the first time that happened, my mom came home to take care of me. And I was in a bit of a unique position because my mom had endometriosis. So she recognized the signs of that and was like, you probably have endometriosis, but that was pretty much the end of the conversation. She's not a medical professional, so she's not too knowledgeable knowledgeable about what the actual disease is. She basically just told me it's just causes really bad periods and that's it. And so we never really went to a gynecologist or did anything about it. When I needed to go home from school, she was really, really understanding of that and let me come home. But that was pretty much like, you know, I was given a heating pad and some ibuprofen and water, and that was pretty much the end of the care. And then the period would pass and I would just go back to my normal life. When I was 18, I started becoming more sexually active. So I started seeing a gynecologist every 6 months. And I remember like always bringing up that I had, at this point, they were becoming extremely painful to the point where I couldn't like get out of bed sometimes when I had periods because it, you know, it hurt too much to walk. So I was starting to talk to my gynecologist and trying to ask them, is this normal? Like, this doesn't feel normal. And they would always tell me, yeah, you're fine. Your pap smears came back fine, which is another huge myth. A lot of people think that you can find endometriosis in a pap smear, but it doesn't, you know, to my knowledge, it doesn't show up in a pap smear. It wouldn't. So my pap smears came back normal. My pelvic exams would come back normal. And I just thought, okay, I just have a low pain tolerance, I guess. And, you know, my periods are just, you know, painful and I'm just going to have to deal with that. And if I do have endometriosis, I still felt like I probably did, but every time I went to a doctor, they wouldn't listen to me. So I was like, okay, well, I guess, you know, if all it is painful periods, I can just deal with that. It's like a week every month and it sucks, but it's manageable. Until it started not being manageable. And I didn't correlate this at the time because I didn't know that endometriosis could spread to pretty much anywhere in your body. But during this time, I started developing some really, really serious lower back issues. I went to physical therapy for them. I went to the doctor for them. No one really knew what was going on. But anyways, you know, as you found later when you did my surgery, Dr. Najat, there was endometriosis in my spine. So it makes sense why I was having back issues. But yeah, basically I was with my friend Erica and I was on my period and I was, you know, really not doing well. Like I usually wasn't on my period. It was hard to walk, you know, I was like kind of just like limping around the house. And I started telling her about my symptoms and I was like, yeah, it's just a bad period though. I can deal with that. And that's when she sort of started educating me on exactly what endometriosis was. And she said, no, it's way worse than just a bad period. If you're lucky, all it is a bad period. It can spread pretty much anywhere in your body. It can take over your body. Like it could potentially collapse your lungs and kill you. And so I was like, okay, well, I didn't know that. And maybe it's time to start taking this more seriously, which is when you so graciously helped me and, you know, screened me and did an ultrasound and basically told me there's pretty much a 98% chance that you need to have, that you do have endometriosis. And so I was in a really, really precarious living situation at the time. So I wasn't able to plan my surgery right away, but the months between getting confirmation that I potentially had endometriosis from you and actually scheduling my surgery were the worst they were the worst 4 to 5 months of my life. It got to the point where it spread to my back. I couldn't even stand. I couldn't go to work. I lost my job because of it. You know, I couldn't even make it from my bedroom to the bathroom. My boyfriend had to like help me walk there. So I was like, okay, I'm miserable. I can't do anything. And this is really, I can't even live a normal life right now because, you know, I'm in so much pain. It's debilitating. I was throwing up all the time. Like it was a horrible, horrible experience. And then you did my surgery, which I'm so, so happy about. And, you know, the first thing you said after was the surgery was a huge success. And that was a huge relief for me. And then you told me all the different places it had spread in my body, which was, you know, it was all over my ovaries, all over my uterus, you know, it was on my spine, it was on my bladder, it was like everywhere. So it's crazy though, because leading up to that point, even though my symptoms were so like severe and I literally couldn't live my life normally, I was still scared up into the point that I had surgery. Even like right after the surgery, until I talked to you, I still thought all of it was in my head, because I think I'd just been told so many times, you know, you're normal, your past years are normal, you're fine. Up to the very last point after my surgery, until you talked to me, I still thought it was in my head. I still thought I was just making things up for attention, which I obviously wasn't doing. So it's just crazy. And I think it's really, really important. I've started to like open up about my personal journey online and have received so many messages from people saying the same thing. Like, all my doctors just say I'm fine and I don't know what to do because no one will listen to me. And it's just, it's really, really sad. And I think we really, really need to, you know, squash this idea that severe pain to the point where you're throwing up and passing out is normal on your periods. You know, I was in school, they would tell us like that is normal. Like when I did sex ed in high school, they were like, yeah, sometimes, you know, you'll throw up and that's, you know, severe pain is normal. And it's really, really, it's not. So thank you so much for doing this and giving me an opportunity to speak. And I'm really, really grateful for this. But that's my story.
Thank you very much, Christina, and thank you for sharing your story. For those of you who didn't notice or noticed, Christina was referring to Erica. Erica is the friend of Christina, who is the director of education for the worldwide EndoMarch. And she's a medical student and our friends. And imagine she had a friend, Erica, who is a medical student and is a member of worldwide EndoMarch and is educated about endometriosis. So it took a while for her to convince Christina to go to a doctor because she has been told all along it is in her head, all is normal. Imagine those who do not have an Erica. Imagine those who have authorities telling them that it is normal. They don't mean badly. Those physicians, they mean well, they have good intentions. It is just not the best moment, unfortunately, because what the mind doesn't know, the eyes don't see. They are not aware. The same way it is not on their radar. And that is what you are all doing by this worldwide EndoMarch. And we are getting the next month. Next month, we are having, we could say, large celebrations for raising awareness for a 2-day period. It's going to be all virtual around the world. All the countries from Austria and Australia to Zimbabwe, they are all involved, A to Z, and everybody in between. And we thank you for helping yourself, for helping your children, helping the whole world as a result. There are some questions that we would like to answer. And I want to know if Dr. Sina Nejat and Dr. Azil Nejat have any, and also Dr. Osayas, have anything to add. Please go ahead. If any of you want to add anything, go ahead and address it. If you don't, perhaps one of you, we could start with Dr. Sina Nejat. One of the questions is, does endo spread in the body in the same way as cancer? And the other, essentially, is how endometriosis spreads. Can it go spread all over, just like cancer, or what is the risk of endometriosis and cancer? That question would have been great for Dr. Farnejad, who couldn't unfortunately participate because he had another commitment. But go ahead, Dr. Sina Nejat, please address that question. Well, I like to compliment all the audience for being so interactive and sending so many good questions. Also, I'd like to compliment the panel for sharing their story. At the same time, I like to give good news to all the patients who have endometriosis. True, we have heard that their symptoms were brushed off. I published a paper about 20 years ago that by the time a teenager or an adolescent is diagnosed with endometriosis, it takes about 8 to 10 years, and they may have seen up to 12 doctors. So on that line, I realized there are more and more doctors getting aware. Today, we have more awareness, not only amongst other doctors, amongst other healthcare providers who do understand endometriosis, and they don't tell the patient it's in your head, and they properly refer them to the appropriate center. We just published a book on adolescent endometriosis. It has never been addressed before. And in that book, I've had pediatricians, nutritionists, social therapists, psychologists write their experience, and it goes to all the disciplines. So true that the panel had a bad experience, but I'd like to share the good news that there is more awareness today amongst all the specialties, healthcare providers, that it was 2 years ago, 5 years ago, and exponentially 20 years ago. That's one thing I'd like to address. The other one, that how does the endometriosis spread, and could it be going the same direction as pattern of the cancer? Yes, that's the Simpson's theory, from the left to right. It could go from sometimes, or most of the time, we could see certain endometriosis more severe on the right than the left. At the same time, we could see endometriosis trapped between the sigmoid and the bowel and rectovaginal septum on the left. That is one theory, but on the book that I just mentioned, we have a chapter that diagnosis of endometriosis were done in the autopsy of the babies who did not survive, and they found endometriosis. So it could be a coelomic metaplasia and originating. And that brings me to my first comment, that we look at endometriosis as one entity. It is not. Endometriosis has a different variation, different manifestation. We even have types of endometriosis is reported as endosalpingiosis, endocervicosis. So please, what we need to focus is increase understanding about variation and manifestation of endometriosis. And one more thing I will comment, I saw one of the questions. She said she had excision of endometriosis and she has pain. For God's sake, this excision, and I like to challenge all the excisionists around the world, that they tell the patient excision is the only way to take care of endometriosis, and excision would cure your endometriosis. Please, this is misleading, this is misinforming, the same way that all these patients were told it is in your head. They are telling them, I do the excision and you should be free of endometriosis. I am on the verge of not calling it unethical. I am on the verge of calling it criminal. And the reason I say, I just saw a patient last week. She was told she had excision of endometriosis on her tubes. She was told she had perisacral neurectomy. I look at the pathology report of perisacral neurectomy. It shows fibroadipose tissue. The procedure was not done properly. I look at the pathology of the fallopian tube. It says muscle of, the tube, and it says removal of the muscles of the tubes. 21-year-old girl. Please, you as the audience, you as a participant, understand treatment is not destruction of the organs of the individual. Excision is misleading. Please forgive me for getting emotional, but I do see this happening every day. For the person who brings that question up, I had excision and I still have pain. You have endometriosis. It was improperly treated, or endometriosis was not the cause of your pain and it needs to be looked at. Does Marina going to take care of endometriosis? Not necessarily. All the new medicines that I see them being questioned on the question and answer, they may remedy the symptom, but they would not cure the endometriosis. And thank you very much for the opportunity.
Thank you very much, Dr. Sina Nijat. Excellent point. So, and I echo what Dr. Sina Nijat said, that there are a lot of good news. We want to let you know. On the positive side, if endometriosis is addressed by a specialist who is familiar with endometriosis, the prognosis for pain is excellent. It is not 100% of the time, but the majority of the patient, in excess of 85% of the patient with endometriosis, and they have pain, if they have addressed properly, they could have significant improvement in their pain, not 100%. Some endometriosis patients, unfortunately, no matter how well you treat their endometriosis, the pain continues. And that is an area that we have to address it even more. But the majority, in excess of 85%, close to 90% sometimes, you can see this patient, they benefit, they have a better life, and the glass is almost 85 to 90% full. The same goes for couples who want to get pregnant and they have endometriosis. The chance of success is significantly better, and we have published multiple papers with documentation that when endometriosis in infertile couple is treated properly by the proper surgeon, that they don't cause any harm, the chance of success is much, much better, 75 to 80, even further percent, comparing to 30% if they continue to go doing IVF without any treatment. But it has to be done properly by proper surgeon who are understanding the disease well. So there is a lot of good news for the patient. We want you to understand the good news is there. We are making progress. We are moving the mountain an inch. And by yard is hard, by inch is a cinch. We are making progress, and there is a lot of good things about endometriosis. As I mentioned, Worldwide EndoMarch has an app that it is called Nejat Endometriosis Advisor. That is a free app, free all over the world. If you take it, if you are suspicious of having endometriosis for pain or infertility, it could at least guide you. It is not treating you, it is guiding you to see the proper people. Go to the website of the Worldwide EndoMarch, download the app, give it to all of your friends. It saves them a lot of money. If you can afford it, you can give $1 or whatever to the Worldwide EndoMarch to help them raise more awareness and participate. Participate. The good news is coming. Next month, the Worldwide EndoMarch awareness is going to be 2 days. From the headquarters we are managing, we have good celebration. Please participate on that. And we thank all of you again for participation. We thank Carla, we thank Stacy, Christina, and Tiffany.
and Dr. Usayas, Dr. Azadeh and Dr. Sina Nejad. And we thank all of you for your participation. And we look forward to seeing you. And we thank also the headquarters of the EndoMarch. Thank you, and we wish you a great month until we see you next month. Bye-bye.
Hello, my name is Amal Drizi. I am a private practitioner in obstetrics and gynecology and a hysteroscopist from Algiers, Algeria. I have no conflicts of interest to disclose, and first I wish to thank Professor Kamran Nejad and the entire AGCES team for the kind invitation to talk of hysteroscopy in patients with endometriosis. The first question that comes to mind is, why talk of hysteroscopy in women who have a medical history of endometriosis? Is it supposed to be any different from a hysteroscopy in a patient without endometriosis? Actually, empirically, I did notice in my patients with proven endometriosis some recurrent patterns in hysteroscopy, to such a point that I had to search for an explanation. The more symptomatic the endometriosis, the more marked these hysteroscopic features were. For starters, inflammatory endometrium, but also a trend to more proliferative endometrial conditions like polyps, endometrial hyperplasia, a certain trend to recurrence, to a slow and limited response to progesterone therapy, more pain in office settings, and exaggeratedly hypertone internal os of the uterus, more like a spasm, not a stenosis. It's rather hypercontractility. And these empirical observations led me to do a search on the subject. What is the impact of endometriosis on the eutopic endometrium in particular, and on hysteroscopy in general? Now, we have to get things right. Patients with endometriosis, they have actually two types of endometria. There is the ectopic endometrium, which actually defines endometriosis, and the eutopic endometrium, the one which is normally present inside the uterine cavity. Today, we are taking a closer look at another facet of endometriosis, which has been rather overlooked: its impact on the eutopic endometrium, on the intrauterine endometrium, even in normally ovulating women. The first thing we realize when we search is actually there are consistent data in the literature on this subject. Many parameters have already been reported to be impaired in the eutopic endometrium of women with endometriosis as compared to women without endometriosis. Examples: a higher density of nerve fibers, quantitative and qualitative differences in expression of epidermal growth factor system, different proteins displaying trends of dysregulation. These changes are such that some of them have already been thought of as biomarkers for the diagnosis of endometriosis, which means we can simply take an endometrial sample and test it and identify these changes, which are the consequence of endometriosis, and pose the diagnosis of endometriosis. Of course, this is still an ongoing research and things still remain to be clarified. To make it short and simple, we can read here: there are fundamental abnormal changes within the utopic endometrium of women with endometriosis compared to normal endometrium of women without endometriosis. Utopic endometrium shows enhanced ability of proliferation, implantation, and angiogenesis. Moreover, when we look at all the publications on this issue, we realize that these changes can be summarized in two big essential lines, in two big lines. The first set of changes is related to progesterone resistance, and the second set of changes is related to impaired endometrial inflammation. Now, progesterone resistance was a very interesting discovery. It means that even in normally ovulating patients, progesterone does not act properly on the endometrium because the utopic endometrium does not display, does not express the hormone receptors in a proper way. So actually this discovery was paradigm shifting in endometriosis. Additionally, endometriosis is a major and a very well-known chronic inflammatory condition. And this inflammation can also reflect on the utopic endometrium, which shows reportedly an overexpression of pro-inflammatory cytokines, autoantibodies against endometrial cells, a different behavior of some endometrial immune cells with a trend to pro-inflammatory properties compared to women without the disease, to name just that. More interestingly, and this is something which is well known today, is that inflammation causes progesterone resistance. And progesterone resistance or insufficiency is also well known to create a pro-inflammatory endometrial environment. And so it's a vicious circle going on there. From here, we can better understand why chronic endometritis was reported to be highly associated with endometriosis. Although actually chronic endometritis is an entity that we have been criticizing in our latest works, because today chronic endometritis is consensually defined as a chronic inflammation within the endometrium caused by germs and to be treated exclusively with antibiotics. This definition is not quite correct because, first, chronic inflammation within the endometrium is basically an essential component of normal endometrium physiology. The menstrual cycle is all about inflammation, and this is something that all immunologists, physiologists, and pathologists know by heart. Another thing is that the physiological inflammation within the endometrium needs to be acknowledged and accepted, and it becomes problematic when the balance is disrupted, be it in favor of excessive inflammation or suppressed inflammation. This is when things become problematic. Another major critique of chronic endometritis is not only germs can trigger imbalanced inflammation, and these are the basics of immunology, which has also been highlighted in this SWOT analysis. So now we know that endometriosis is the perfect example of an inflammatory disease, which is not caused by germs, but rather by the presence of active inflammatory endometrium in ectopic locations. So this is actually the core of the concept we introduced about impaired inflammatory state of the endometrium, IISE. Anyway, when we understand these pathophysiological characteristics of endometriosis, anticipating their consequences on the utopic endometrium and on hysteroscopy becomes simpler. Endometriosis cannot be considered any longer to be only involved with subfertility, implantation failures and miscarriage, but more importantly, endometriosis provides a perfect ground for abnormal proliferation. Endometrial polyps, hyperplasia, be it localized, diffuse, with or without atypia, and ultimately endometrial cancer. Endometrial cancer is very well known to be a chronic inflammation-mediated condition. We can see in this worldwide population-based cohort study that an increased risk of endometrial cancer was observed in women with endometriosis in their later life. Although larger investigations are needed, however, part of this makes sense. So, in conclusion, how is hysteroscopy in women with endometriosis? Growing awareness of pathophysiology, immunology, the specificities of endometriosis should lead us to a more thoughtful and targeted practice of hysteroscopy and gynecology as well. We should expect in these women more of first, pain factor, hypercontractility, mainly in symptomatic women. Second, inflammatory endometrium. In this paper we published in the Italian journal, we correlated the basics of histopathology with the basic images of hysteroscopy to set a list of patterns for dysfunctional inflammatory endometrium, mostly micropolyps, strawberry pattern, corrugated irregular surface with uneven distribution of glands. The targeted biopsy is to be performed within the site that displays these features. Third, endometrial polyps, hyperplasia with or without atypia. And fourth, given the progesterone resistance, the response to medical treatment like progesterone should be expected to be slower and more limited. So it could take more time for these hyperplastic conditions to heal. And never forget that chronic inflammation within the endometrium is a very well-known risk factor for endometrial cancer genesis. So all this should lead us to think of the pertinence of endometrial monitoring in women who have endometriosis. Of course, more observational studies are necessary for that, but just that we should give it a serious thought. Thank you for your attention.
Good evening. On behalf of the Worldwide EndoMarch and the American and Global Congress of Endometriosis Subspecialists, I would like to welcome our guests this evening, all the way from the south of France, the Association Manoletta. I am joined by three amazing women who have founded the Association of Manoletta, and would like to tell us a little bit about the fantastic work that they're doing in the south of France to raise awareness for endometriosis. Thank you so much for joining us. First, I'd like to start with you, Manny, the founder of the Association of Manoletta. Can you tell us a little bit about your personal story with endometriosis?
Okay, sorry for my bad English. So my
just
fine. Translate. Quel rapport j'ai avec l'endométriose? Ton histoire avec lui. Voilà. At first, she discovered she had endometriosis. À quel âge à peu près tu as commencé à souffrir? À souffrir 11 ans. She was 11.
Oh, wow, young.
The first time she had periods, and it was always the pain, always the pain. We met specialist doctors, but no one helped her. Neither me, I didn't know what happened. And après, qu'est-ce qui s'est passé?
It became really hard for her because she had so much pain, and when she was more older, 27, she came to urgency.
To emergency room.
Yes,
to the hospital.
And every doctor said there is nothing, it's just period or something like
Maybe
this.
it's a problem in your mind.
Right, yeah.
All the time, it's in the mind.
They never say we don't know, just it's not what you think. So at last, we've been heard that a new surgery arrived in this area.
Before that, I'm just
On a appris qu'un nouveau chirurgien s'installait. C'est ça, chirurgien. And he is the best one, I think, in France. Really.
Hero.
Very big luck. It was her luck, and the luck of all the women who need. And at first, we all together, because it's a story. We worried about her. It's a family story.
The whole family suffers through this awful disease because they see you in so much pain, and your mom and your sister, they want to help you, but it's yes. I know, yeah. I feel your pain and your journey, and you're right. Everyone in the family and your friends, they suffer too with your pain and trying to get you the help, and you have such a wonderful support system, and that makes a huge difference.
It's difficult to keep friends because you are not able anymore to go out at night. You feel very tired, painful, and people are not. It's not everybody who can hear what is happening.
Right.
Above all, if you don't know what you have, you can't explain.
Yes.
And it looks like you don't want to have this friend.
Yes, I know exactly your experience because I've lived it myself, and so many women that I've been speaking with around the world through this through these interviews feel like you do. You become isolated. You want to stay home because you don't feel well, but people don't understand the pain that you're going through. I'm so sorry that you had to suffer from this, but you have such a lovely family supporting you. So after you had your surgery, then you decided to start this wonderful association?
At first, after the surgery,
2 years after,
she decided to create this association, Manoleta, and she talked with the surgeon, the doctor, and
he say
he trusted
yes,
her. He trusted
we need
her
the association
because he's looking for the reason. He's taking comment on peut dire, prendre soin, taking care of women, but he's looking for the reasons of this illness.
Yes, to help find the cause of this illness. Yes.
His father did the same, but not in France. Son papa faisait la même chose. In Belgium.
Oh, okay. So is your surgeon in France or was he in Belgium?
He's in France, but he
comes from Belgium.
I see. He's from Belgium.
He's in Avignon, actually.
Okay.
There is many women in that.
Yes, because it's an area where there are many women with this illness. So he
Here,
wanted to
in the
understand
south.
why, and
Yes.
he thought it could be so useful here. And it's a very nice place too, maybe, I suppose. So he had the wonderful idea to come and stay here. And he's helping us and caring us about all the things we have to know and things we can explain, because we are not doctor. So we must be very careful with with the words and what we say.
He helped us to find the good website for the information of endometriosis.
To know the truth. Never look after a fake and be decepted because of this. We are very careful with this problem in internet. Sometimes it's not the truth. So we are very careful with that.
Well, I think that's excellent that you're working so closely with your surgeon to make sure you're sharing the accurate, correct information with women and families out there. That's excellent. And you mentioned that you have a website.
Yes.
And I think that website for our viewers is located in our chat area. You can see that in the chat room, because we would like to encourage people, not just in your area of France, but all over the world, to seek out your website, because it sounds like there's some great information that can be learned through that website. What other forms of ways are you getting in touch with other women in your area to help them? How else do you provide support?
Comment on les supporte?
Are you using TikTok, Instagram, other
Ça fait combien de temps que tu es sur Internet?
other social media?
5 years.
Okay, so for 5 years you've been working since 2018. You've been trying to raise awareness. And so what platforms or what media do you use to get your information out there? You have a website and you also have
radio.
A radio, okay. Been on the radio, excellent.
Papers.
Papers. Oh wow, okay.
Instagram.
Okay.
Snapchat.
Snapchat.
Facebook. Yes.
Facebook. So you are really out there on all the social media platforms, which is a great way to reach so many people. You can be found then on TikTok, Snapchat, Facebook, Instagram, and all of your sites can be found in the chat room here. I know on TikTok, you're Manoletta84, right? And Snapchat. And then Endometriosis avec Southeast France, I believe, is where you can be located on Instagram and Facebook. What do the people find you? What kinds of things do you do to help women or to provide support to them?
We come with them as soon as possible to the doctors if they need to, if they ask to. We inform. We create special papers. Comment on peut appeler ça? Les supports.
Oui.
A sort of endometriosis kits.
Oh, excellent. Okay.
And we give it to the pharmacy, chemists.
To the pharmacy, to the doctors?
The doctors, and where we buy medicine, everywhere about the health. Because we think the most important it's to be comment on va dire atteignable, accessible for the most people.
It's able to help most people. So do you you actually accompany these women to the doctors if they would like you to?
Something like even by phone,
like a pamphlet or a brochure. Excellent, beautiful. Look at that.
This is for the family for explain
yes,
to explain for
this
the
one
family.
is for family. This one is
all of them is the same, but
it's
No?
for the pen.
Oh, that's wonderful for family. So you're providing information to their families, husbands, boyfriends. That's great. Now, can people that visit your website, is that available on the website to see that?
We send the documents with address postal with
by the
By the post office, you mail it to them.
That's by address.
It's free. It's
free. Oh,
And
free. Excellent, excellent. And so you will go with some women to see their doctors. I think you mentioned to me also when we were talking earlier that you also will meet with husbands or boyfriends or fathers. And what do you do when you meet with them?
We try to talk with the husbands, our sons, our fathers. Anyway, we try to organize meetings all together because they can exchange sometimes better than we can do. But it's important to be with them, to help them to know the truth and the right things, and the right medicine, the right way, what you can hope from the medicine, what you can do by yourself to get better and to live with, to work with, to be mother with, to do anything in life, because there is a life.
Yes, a life to live, right? I think that's excellent. You're the first group I've spoken with that actually have men come together and they can talk and share their experiences, but you're also there to make sure they get the accurate, correct information, and then they can support one another. That's really, really a profound work that you're doing. I love that idea. And so how many women would you say are in your association or follow you?
About 80. About 80.
80
members
in the association and in the social media. We are 100
1,000.
1,500.
Oh, wow. So about 1,500 or more. And probably after this video, you'll get even more followers, because I think so many people will want to check out the great works that you're doing. Now, if a woman wanted to get a hold of you or wanted to get information, are you available to them by phone, or what kinds of support do you provide to women?
Everybody can phone 24 hours a day. She does it by herself. She is alone because this is her she does it better than us.
This is your passion, your calling.
It's a lot of time, but it's important because very often when someone is calling for the first time, it can take 2-3 hours, because we take time to explain, to listen, and to help anyways.
Wow, really amazing work that you're doing there in your region of France, and I really commend you for interacting with men and giving them awareness and knowledge about this disease, the works that you're doing with women to help them to live with this chronic debilitating disease. Really all remarkable. And I want to thank you, lovely ladies, for being here with us today and sharing your great works, and really encourage our viewers to check out your website and Instagram and other social media platforms. So thank you so much. And I hope to meet with you someday and help you spread that message in your area because you're doing beautiful things. So thank you and have a great day.
Thank you very much.
Dr. Amy, it is a pleasure to have you. Please, you have the podium. We would appreciate it if you proceed and explain your involvement and how you decided to help the patient with endometriosis and the issue of your experience and how do you address that. Thank you.
Of course, I think when it comes to having patients in my practice suffering from infertility, they come to me because they want a reason and they want a diagnosis. They want an explanation as to why is what happening to them. And unfortunately, as women, our symptoms are often ignored, and it can take years before someone gets properly diagnosed with endometriosis. And we know far too often in our experiences together how endometriosis can affect implantation. Endometriosis can block fallopian tubes. It can decrease egg quality, causing a less number of mature eggs, for example, and a higher rate of having embryos that are not genetically normal. So when you've already gone through so much to have a baby, and in some cases it can be even multiple IVF cycles, it's imperative for me when I'm planning something for a patient to make sure that I have ruled everything out, and that includes endometriosis. So that's why there are some tests that I do. For example, the Receptiva DX test, if I suspect that someone might have silent endometriosis, or I send them to you to see what you think as far as whether the patient clinically might have some physical exam signs of endometriosis that I can't pick up because I have certain tools in my toolbox and I feel like you obviously can pick up on some things that I can't necessarily pick up on all the time. And I'm always just so grateful for the work that you and your team does to make my patients parents. So we've had great fortune and so many success stories where patients, for example, have had IVF cycles that don't work. Then you do surgery on them and then they come back to me and they get pregnant through either IVF or even naturally. And sometimes, when you tell a patient, Amy, she can get pregnant now. And in the beginning, I was a little bit doubtful. I'm like, there's no way that this patient with this endometriosis can get pregnant. And then after surgery, sure enough, we have so many countless stories of patients who are then able to conceive on their own. Not everybody, but there are definitely some pretty amazing stories out there. And so patients sometimes will do IVF with me, have embryos stored, do surgery with you, get pregnant naturally, and then we've saved their embryos for their future. So that's pretty exciting for me. So if there's anyone out there that feels in their gut that they might have endometriosis or you just don't know what's going on, I think it doesn't hurt to meet with someone to ask them, have you ruled out endometriosis for me? Especially if you have pain or if you're having implantation issues or problems with embryo quality, I think it's worth it to explore endometriosis as a possible factor.
Thank you very much, Dr. Amy. Dr. Amy, why do you think it is that in general, as you said it yourself, there is you cannot deny the success of these couples who get pregnant after many failed IVFs in some of the best centers, and you treat them and they get pregnant. And why do you think, number one, the mechanism, what it is, and number two question is, why do you think this is not more known among many infertility specialists?
Yeah, I'm hoping through more awareness, like the seminars you're doing, and more patients that are speaking out about their success stories, that hopefully more fertility doctors will agree. And I think it's hard because I've personally heard other fertility doctors say, oh, endometriosis won't cause this or that. And we know that it can. So I think that, with more experts like you also, talking about how it can affect fertility, I think people will start to offer patients a workup for endometriosis more and more. And I'm seeing it across the board, either surgery or medical treatments like Orlissa or Depo-Lupron or Letrozole. And the mechanism is, I think a lot of it's just inflammatory. It's inflammation that endometriosis can cause that can decrease implantation rates, increase miscarriage rates. And the hardest part for me is getting healthy eggs when someone has endometriosis. And so I'm not surprised, but I'm pleasantly pleased, I should say, when a patient has endometriosis surgery, especially if it's more severe, then they come back and they make beautiful embryos for me. So I think a lot of it has to do with inflammation, and that's how it can affect egg quality and make things not work the way I would want them to work the first time for them.
Thank you very much. There have been, as you know, the many couples with, everybody thinks endometriosis patients have pain, but there are many patients with endometriosis that they have no pain at all. Many couples, many of your patients, the husband is fine, all the tests are okay on the female side, the HSG, everything is normal, and they are completely asymptomatic. In our experience, more than 90% of these patients, when we see them, they have endometriosis. And it would be very typical for you, I take it, that when you have a couple like that and you see they have had failed IVF, everything is okay, and tell them, hey, you might have endometriosis. How do you talk to those patients?
Yeah, I mean, I feel like the way I talk to them is I talk to them about how common endometriosis is for so many reasons in terms of the things that we're exposed to in the environment. And then also when you've taken so many hormones through so many cycles, I feel like IVF medications can also sometimes stimulate endometriosis. So those are the kinds of things that I bring up. And then I also tell them, just because you have endometriosis does not mean you cannot get pregnant and have a healthy pregnancy. It just means that you should be more thoughtful about the approach you take. And it's kind of a catch-22. And I'm sure everyone who's listening right now understands what I'm talking about. Sometimes people say, oh, you have endometriosis, so go ahead and get pregnant. But when you have endometriosis, it's harder to get pregnant because pregnancy can be a treatment for endometriosis. So I find sometimes it's mean to tell someone who has endometriosis, go get pregnant and that's going to fix it. They just aren't ready yet to get pregnant, or they're ready for sure, but sometimes it's just a little bit harder. So I explain it in those terms, and I feel like people can understand that it's not their fault. It's something that could be environmental and genetic, and it could be stimulated by IVF medications. And that's why it would be important to rule it out before, let's say, you transfer your very last embryo, or you rule it out before you go through all your embryos and then have to do another IVF cycle to have a pregnancy.
Thank you, Dr. Amy, you are so precise. Dr. Amy, one thing that I would really appreciate it if you explain, you have been so outspoken and advocate to raising awareness about infertility couples. Would you please talk about Egg Whisperer and your previous programs that you have done, and many of them are very watched by thousands and thousands everywhere. Could you please, if you don't mind, explain some of that for our viewers?
Absolutely. So I have
would they get involved?
Of course. So I have a podcast, and you have been a very big part of that podcast. You were a guest not that long ago. And then I also have a YouTube show, and then I have a Q&A series that people can send questions into. It's asktheeggwhisperer.com. And my favorite is actually my classes. So I teach IVF classes. I call them master classes, and it's at the Egg Whisperer School. You would think that I could be more creative with the names here, but eggwhisperschool.com. You can go there. You can learn about fertility. I have a Tushy class. Tushy method is one of the methods that I teach people. All the tests that you have to do before you get pregnant. I don't know if you can see it back there. I think it says Tushy method back there, but it just raises awareness about getting your tubes checked, getting an ultrasound to rule out endometriosis. If it's present on ultrasound, getting your sperm checked, your hormones, and then lastly, your genetics. So those are the kinds of things that I do to teach people, build awareness. I make catchy phrases so that people can hopefully sometimes or always laugh and smile as they think about something that sometimes brings a lot of sadness and depression.
Thank you, Dr. I think she has some questions from you, and I would ask Dr. Agrawal to go ahead and ask Dr. Amy.
Hi, Dr. Amy. Good morning. I think I wanted to ask, what do you think about BCL6? I know you are very well aware and you have it performed on your patients all the time. You test for BCL6, but we don't see it from other fertility doctors as much. So how would you educate patients on whether they should ask their doctors to test for this to see if they have endometriosis?
Yeah, I mean, I'm actually seeing an uptick in fertility doctors doing it across the country now. So we're going to see more and more patients getting this test done as people are, waiting longer to have babies. Their embryos are so precious. I think doctors are now willing to, or they agree that maybe doing this test makes sense, especially when they're doing other tests at the same time. They can easily do that. The BCL6 test for me, if someone has obvious endometriosis, I mean, I don't know how helpful it is for someone who has endometriomas. But in someone who is having implantation issues or preparing for a transfer, I think it can be a helpful test to do, even if you haven't, quote unquote, failed one transfer. I don't want people to fail even one transfer. And I know people say, oh, she's never failed a transfer. Why would you do this test? And my personality is, I'm not going to discuss this test with somebody after a transfer doesn't work. I want them to know the menu of tests that they can choose from at the very beginning, and then they can choose for themselves if they feel like that test resonates with them and they want to do it. And at the same time, it is not a perfect test. I mean, Dr. Najat and I have had patients where we think they have endometriosis. The BCL6 test, for example, is negative, and then he does surgery and sure enough, they have endometriosis. So I always tell patients, if the test is negative and you think you have endometriosis, the test could also be wrong. And I know there are other tests coming out that might be better than the BCL6 test, but that's kind of how I use it to guide treatment. It helps me change protocols. It helps me direct patients to Dr. Najat. It makes me look at the fallopian tubes more closely before a transfer. So it teaches me a lot about a patient before a transfer. But again, if a patient doesn't have access to that test because their doctor won't do it, there certainly are other doctors who could do it for you, like your OB/GYN even could do it for you if your fertility doctor doesn't think that it's a tool that they want to apply in your case.
I have one question that a lot of our patients ask when they come see us, and that's about like the time of freezing eggs and doing the surgery. So there are studies that show that the quality of eggs actually get better after we do the surgery. So that's one thing that we tell our patients. But at the same time, there are some of our patients who don't want to lose time, or they're like older and they say, oh, do I have to get my eggs freeze and embryos freeze before the surgery or after? I just wanted to know your opinion about how to counsel these patients.
I mean, I think it also depends on, like you said, their age, their hormone levels, how much ovarian tissue is actually there, and their willingness to do multiple IVF cycles or egg freezing cycles. So I sometimes ask people to consider doing both. So do a cycle of IVF or egg freezing first, and then about 6 weeks later, whenever Dr. Najat thinks is the best time, then do another IVF cycle after surgery. So I've done it both ways for patients, and in some patients, for example, where they have such a large endometrioma that I think it might be very dangerous, for example, for them to go through treatment. Let's say they've had severe pain before, just from the cyst rupturing, or not necessarily rupturing, but maybe leaking or getting rushed to the emergency room. Like, I don't want any of those emergencies to happen during an IVF cycle. Then I'll definitely recommend that they do surgery first. But it's a real fear because of things that patients have heard about other people who've done surgery. Then they have a much lower egg count afterwards. And so they're fearful also of losing their ovary. But just like Dr. Najat said earlier, it is so important that you're going to a fertility-minded endometriosis surgeon. So I've had patients who've gone to somebody and they leave the operating room with no ovary because the doctor didn't do anything to save that ovary. They just removed the entire ovary rather than just removing the endometrioma. So I always reassure my patients that I actually don't think I've had one patient leave Dr. Najat's operating room with an organ removed. In all these years, the surgeries that Dr. Najat and his team does for my patients is always fertility sparing because he knows how important having babies is for them. But not every surgeon has that approach. And I think that, you know, going through all the worst case scenarios in our heads is normal, but I think it's important to verbalize that with your surgeon. And then the other thing is to go through all the worst case scenarios about your fallopian tubes as well. No one wants to wake up not realizing that a fallopian tube could be removed. And that's a very careful, thoughtful discussion that I know you guys have with all my patients as well. And I do also just let them know that, you know, endometriosis can affect your fallopian tubes and it might be helpful to have one removed. You can still get pregnant from the other side. But when it comes to transferring an embryo, having abnormal tubes can really get in the way.
Thank you very much, Dr. Amin. One issue that I like to also ask you, what do you think, why do you think the couples, do you think the rate of infertility is increasing, and why do you think it is?
I mean, I know it's a controversial topic, but stress, I think, and right now we're living in unprecedented times with people undergoing, they're very, very stressed. And I think stress and then the environment and all the garbage that we're exposed to from the minute we're in utero, all the plastics, I feel like that has a lot to do with potentially why we're seeing more endometriosis. And then society, obviously, the trend is for us to wait longer to have babies. And the longer you wait, the higher the chance that you'll have a problem like endometriosis as well, especially if you had it as a younger person, then waiting longer to have babies, you're obviously going to have worsening endometriosis. And so many people say, like, why didn't I know this when I was younger? So I think a lot of that plays a role into why I think I'm seeing more fertility patients now more than ever with some, I think with more endometriosis than I saw maybe, 15 years ago. So I do think that the environment has a lot to do with it. Stress has a lot to do with it. And then also age-related infertility is a big part of it as well.
Thank you very much. And Dr. Amy, do you think there should be a program or perhaps a national program that all the female patients who want to have children be given an option to freeze their eggs in the optimal time of getting pregnant, as you said it yourself, and we see it very often now, couples in their 40s and sometimes very early 50s, they want to have children of their own. How do you feel about that? And how do you think that should be addressed?
Yeah, I mean, I feel like we're going to see a huge trend toward a population decline in the United States. And I think the government, I predict, is going to play an active role in changing that and increasing the birth rate by incentivizing young people to freeze their eggs. I don't think it's going to be happening in the next 5 years or so, but I predict in probably 15 years, just like other countries are doing now, they're incentivizing young people to freeze eggs, and they're actually paying for it. So I would not be surprised if that starts happening here in the US, that people will actually get their egg freezing done for free, just so that as a society, we can continue to grow and support, everything that we need to support. Otherwise, Elon Musk will be taking us on SpaceX, or, Elon and Bezos to Mars soon, just because of what we're doing to this. Anyways, but you know what I mean. But I do feel that it's one of my egg whisperer golden rules that every woman by the age of 25 should have a fertility level check and get, you know, some fertility tests done, and she should consider freezing her eggs if she is considering having children younger, even 21, if she has a history of endometriosis, having an ovary removed, or her mother went into early menopause, because there sometimes are some even 25-year-olds that wish someone had told them about these things sooner. And then I think by the age of 32, if a woman wants at least one baby and hasn't had one yet, whether you're married or not, should consider freezing her eggs. So I do think that egg freezing is a powerful tool. It's a great technology. It works. I do it a lot. I freeze a lot of patients' eggs and they come back to me and we use those eggs and they have healthy babies. It's not perfect. It's not an insurance policy, but it's a future chance at a pregnancy with better chances than you had at the age that you're at. So I always tell people, you want to be your own egg donor. So when you're 40 and 50, I mean, I'm not almost 50, I'm almost 46. And I feel like if I wanted a baby right now, I could have one, but I would have to use eggs that I froze when I was 32 years old. Unfortunately, I didn't freeze, my eggs. Not that I want to have more babies right now, but I froze my sister's eggs when she was 32. So maybe I'll be calling her up if I want another baby.
Well, you are a good pioneer in this area, and you have done a very good job. And thank you for that comment. So, Dr. Amy has a wonderful family. I let her talk about it if she wants, but I don't want to spill all the beans for you. So, and it has been a pleasure to know you and know your family. So, what role, I have another question, and I think perhaps one of my colleagues wants to ask you. It was about anti-Mullerian hormone. Was it Shruti, who was it? Any of you want to ask Dr. Amy the question yourself, or do you want me to proceed?
No problem, sir. I mean, with anti-Mullerian hormone, we want to know, Dr. Amy, what are your thoughts? Because sometimes patients just randomly have an anti-Mullerian hormone test done. They get a low number and they start freaking out about it, thinking that they're never going to get pregnant again. And these are younger patients and patients who are about to undergo an infertility workup. What would you say to patients who just have not had a single infertility workup and just have a low AMH in their hands and now don't know what to do?
Yeah, I mean, it also depends on your age, but I tell patients one snapshot in time doesn't define you. It doesn't define your fertility. And, the AMH can go both ways. You can have a high number and actually it could be a lab variation and wrong, and then you repeat it, and then it could be closer to what your true number is. So I tell patients to never just rely on one AMH level to guide your, fertility treatment. And then never do it in isolation. You want to get an ultrasound and have something called an antral follicle check done. So that's a measurement of the tiny little cysts called follicles in your ovaries. They kind of look like boba pearls in a boba tea, or chocolate chip cookies, chocolate chips in a chocolate chip cookie. We just count those little circles. Or someone said to me the other day, they're like, they look like little caves. I'm like, yeah, little caves with a tiny sparkling microscopic egg inside. So we take all that information, and then I tell patients, I'm not your fertility doctor for just today. I'm your doctor for 2 years from now, 5 years from now. I have a patient who just saw me yesterday. I'm now helping her with another baby, and I met her 12 years ago. So I froze embryos for her back then. So when I take the AMH, I use it to project someone's fertility for them. And I say, okay, well, this is what it means right now, but I can also tell you what it means to me based on everything I know about you 2 years from now. So I always talk to patients about how many kids they want. And then I kind of think through, well, how old are you going to be when you have your last baby? And what will your AMH potentially be then? And, how many IVF cycles should you do to give yourself the best chance of reaching your goals? Because we know that we have a finite supply of eggs, and we have not figured out a way to help women regrow them. So AMH, I mean, one day we hopefully will, but for now we still have to freeze eggs, do lots of IVF cycles for people to make sure that they have enough embryos for themselves. And until then, the AMH, unfortunately, is the closest thing to a sperm count that we have for a woman. And it's certainly not perfect. But that's what I would say. I would say, don't let that AMH define you. You're not your AMH level, and your AMH can be misleading because sometimes you can get a level that's not accurate or true for what's going on with your fertility.
Dr.
Thank
Amy,
you very much, Dr. Amy.
That's very well put.
so there is another question. I think we have touched on some of it, but someone actually asked kind of about failed IVF and an elevated receptiva BCL6 of 3.8, and they're undergoing suppression with agestin and letrozole prior to perhaps another retrieval, and also in the presence of a low AMH. I think my question would be, in counseling with that patient, where would talking about surgery be part of that counseling for you, Dr. Amy, and where would you have that conversation, and how would you kind of counsel your patient for options moving forward?
Yeah, I've learned a lot over the years about how important it is to make sure patients that you describe make more embryos, and make more embryos before you start the suppression process. Because if, let's say, you've gone through 2-3 months of suppression, I guarantee you that you're not going to have as good of an IVF cycle, especially if you're older with a low AMH, than you would have had 3 months prior. So before you even start that, I say make more embryos, because your BCL6 level is telling me that we might have implantation issues, even if we do all the things that we're talking about, like suppression and or surgery. And then I always tell my patients that my goal for you is to be a parent with your own DNA over you carrying the pregnancy. And so I want to do everything I can to make sure you have a baby with your own DNA. And I don't want to roll the embryos like people talk about rolling the dice and just see what happens. So then I want to be very thoughtful about the approach we take and include a conversation about doing surgery as well. So if, for example, you just have one embryo left and that's it, and we're going to talk about, should we do more cycles to get more? If we've already done the number of cycles that we need, then if there's just one embryo, I think it definitely makes sense to talk through surgery and suppression. And then I always say this because these are the conversations that people need to have before they transfer, before a negative pregnancy test. What would you do if this transfer didn't work? Okay, everyone remember that. All the audience out there, remember this. Talk to your fertility doctor and say, hi, doctor. If this transfer doesn't work, what else would you do for me? And if they say, well, we should consider surgery, and you say, but I only have the one embryo, why don't we consider it now? Because people get really angry when they learn that there could have been something else that they could have done to give themselves the best chance of pregnancy for their one embryo. And people make assumptions that the doctor doctors make assumptions that maybe the patient wouldn't do surgery. She doesn't want to hear about all the other things. But my patients, they want to know every possible scenario. They want to know every single thing they can do to give themselves the best chance. So no matter what we do, I will always say to them, if this doesn't work, we made the right decision together, and we can never look back and say that we could have done something different because we were so thoughtful. And patients understand that. They say to me, Amy, no matter what happens, I know we did our very best, and I know we thought through everything up front before we made the decision to do this. So if it doesn't work, at least I know we tried.
Dr. Amy, thank you so much. It has been a true pleasure and privilege to have you. This is why we see all of your patients, they love you. It has been very wonderful to have you in the program. Endometriosis of the bladder is not too uncommon. When endometriosis involves the bladder, it may cause significant amount of pain,
at the center. It can cause pain with urination. It can cause pain and blood in the urine. If this happens, usually it is at the time of ovulation or at the time of menstruation. If you have symptoms of urinary pain, urinary frequency, especially at the time of ovulation or menstruation, you should be very aware of it and that should be investigated. Also, some patients who have had cesarean section, endometriosis, sometimes could get involved their bladder. Endometriosis of the bladder and the ureter and the kidney can go unnoticed and undiagnosed for a long time. Often I have said that I do call endometriosis a great masquerader because it behaves and creates all kinds of symptoms. There are very vague symptoms and it might be difficult to diagnose the endometriosis of the bladder, ureter, and the kidney. Endometriosis of the ureters, for example, they could cause the kidneys to die silently without significant amount of symptoms. So we have to be careful and cautious when patient has symptoms and the tests are negative. We should not give up because it could be at times endometriosis involving the bladder and the ureters. The simple urinalysis and simple tests, they might not be diagnostic, so the physician should be more diligent, evaluate the symptoms of the pain, urinary symptoms like urinary frequency, urgency, blood in the urine, pain in the back, in the flanks, and that there are vague pains. They could be endometriosis involving the ureters. Although endometriosis of the ureter is rare, it is not that common, but if it is not diagnosed properly in the proper time, it may cause the kidneys to die. When it is diagnosed, and usually a gynecologist or urologist can diagnose this by looking inside of the bladder and also looking inside of the abdomen. Looking inside of the bladder, it is called cystoscopy, video cystoscopy. By a video camera, we look inside of the bladder and we evaluate endometriosis of the bladder and we take a biopsy of that. And by video laparoscopy, we use the camera, we look inside of the abdomen with a high definition video camera called video laparoscopy. We look inside of the abdomen and we evaluate the bladder surface and also the ureters for the diagnosis of endometriosis. Sometimes some tests, they could diagnose endometriosis like MRI or CT, and your doctor can guide you in that direction. The first line of therapy for the endometriosis of the bladder, ureter, and the kidneys is medical therapy. We should avoid surgery as long as we can, as much as we can. We leave the surgery as the last resort. We make the diagnosis and we try to manage it by medical therapy as long as it is possible. Treatment of the endometriosis of the bladder and the ureter is with video laparoscopy, with and without robotic assistance by a very experienced surgeon, and there is no need for a major surgery. I hope this information is very helpful to you. Hello, I'm Dr. Cameron Nejat, the founder of the Worldwide EndoMarch. I would like to greet all the viewers all around the world at any time zone that you are. It is an honor and privilege to be with you, and I would like to thank every one of you, all the patients with endometriosis, their families, their friends, their doctors, all the EndoMarch president, chapters around the world, the ambassadors, the captains, and the volunteers that have, for the past 10 years, have done so much effort to raise awareness about endometriosis. And I have said it many times, if endometriosis was a man's disease, we had more diagnosis and better treatments and hopefully methods of prevention for it. Endometriosis is very, very common. Our research has definitely demonstrated that it is significantly more common than it is assumed so, especially among couples who want to get pregnant. 1 out of 7 couples who try to have children, they have problem getting pregnant. And very often, these couples go through a lot of heartaches, many significant amount of expenses, failed IVFs, so on and so forth, without any success. Many of them have no symptoms at all. All of their tests are completely normal. Their partner's test and semen analysis is completely normal, and they do not get pregnant, and we call it no reason infertility. Our research has demonstrated that more than 90% of these couples have endometriosis, and helping them significantly could increase their wish to have a child. Endometriosis is a social issue. As couples try to have children later and later, then endometriosis is a progressive disease. It progresses and gets worse and worse, and then people have more problem getting pregnant. But indeed, there is help. We can help, and knowledge and science can help a lot of these couples very, very well. We have been trying to address this issue in the Worldwide EndoMarch webinars, and we are very privileged to have our guest today, the physician guest who is a visionary, and she is a gifted reproductive endocrinology and infertility specialist in Los Angeles, who is internationally known, and patients from all over the world travel to see her to gain their wish to get pregnant. Brilliant Dr. Kelly Beck, who has had significant training in endometriosis infertility. She has been trained at Hopkins, the best institutions in this country, Sinai and Cornell. And she presently practices in Los Angeles. Also, 2 couples of her patients, Roya and her husband Scott, and their daughter Anaya, and also Carly and her husband Zach and their son Jacques. They are also joining our webinar today. We thank you for listening. Past webinars, you can watch them in endomarch.org, and there are many, many sessions that you can watch. You can ask your questions. We have our fellows, Dr. Shruti Agrawal and Dr. Deborah Lee, and also Dr. Makam Tavallai. They're all also joining us to answer your questions. And we will start, as I said, the endometriosis is a social issue. In developed countries, the birth rate is in some cases less than 0. And in our country, in US, we are going towards that direction. So endometriosis is one of the major issues, and hopefully with your interest that you are raising awareness, we will have better and better results. Saying so, I would like to introduce first you, Dr. Kelly Beck, that I mentioned to you. She is going to express to you her interest and how she sees patients with endometriosis. As I mentioned to you again, she is completely gifted. Practically, we work together on a weekly basis, and we have had numerous patients. I cannot believe how she diagnoses endometriosis, but she is incredible. Dr. Beck, please go ahead.
Dr. Najat, thank you so much for having me on your on this forum, and I really I'm so grateful to Roya, Scott, Zach, Carly, and your children for joining us. This is like so kind of you. But I do think that endometriosis is something that does affect a lot of women, and unfortunately is either undiagnosed or misdiagnosed for years. And so I know that we're probably going to go into when and how do we diagnose it, because it's not always that you need a biopsy, and there are times where you can detect it on physical exam. And because the true way to assess endo, if you have a suspicion for it, is laparoscopy, and it is surgery, and it's invasive. It's one of those things that we really have to kind of come to an understanding and educate women about, like, when should you seek it? So when you have irregular menstrual cycles, or you have pain, or you have things with GI symptoms that you're being diagnosed as having GI issues, sometimes it could be endo on your colon, and that's what most women are diagnosed as having IBS or irritable bowel, or having something called SIBO, which is a small intestinal bacterial overgrowth. And so I do think that just being able to identify it for women and asking for answers, because a lot of times when women have irregular menstrual cycles, or they have burst ovarian cysts when they're younger, one of the first knee-jerk reactions that they get when they try to seek help is that they're placed on birth control pills. And I think before getting placed on birth control pills, it is good to first try to get some type of answers. And I think I'm really glad for opportunities like this to help educate people. So thank you.
Well, thank you very much, Dr. Beck. So, Roya, how did you end up having the diagnosis of endometriosis, if you don't mind? If you explain your story, and then we can ask Carly to talk about hers later, after you.
Yes, definitely. So yeah, my husband and I started to try to get pregnant right after we got married in 2017. For a year, we tried on our own, and I had about maybe 2 biochemical pregnancies. And as you explained, when Dr. Beck also explained, after a year, my gynecologist said, you know what, I think you need to go to a fertility specialist. And we checked everything, like my hormone levels. I had totally normal periods. I had 0 pain. Everything that, they would checked out for us, and same with Scott. And, this just became a constant, we don't know why you're not getting pregnant. Maybe it's your age. I was 39 at the time. They kept saying, maybe it's your age, maybe it's, something else. They couldn't really figure out what it was. And I was taking a lot of the blame and responsibility myself, that maybe, we should have done something sooner. I should have frozen my eggs. And, all I kept hearing is, we don't know why this isn't happening. Everything looks normal. Everything looks fine. So I did about 6 rounds of IVF at one clinic, and we got nowhere. I never got one genetically normal embryo ever. And then is when I got recommended to go to Dr. Beck, and I did about, I think, another 3 or 4 rounds with her. And in between, we were always trying on our own, and we never had any success. And I did feel that a number of times that, you know, we would get around the implantation phase that, you know, I would have implantation bleeding, or, you know, I felt like something was trying to happen and it wouldn't. And we, even with Dr. Beck, we never got a normal embryo, never, even though we would get, you know, and I had a lot of, you know, eggs, I guess, for my age, and we would get to blastocyst, but we never got a genetically normal embryo. And then in that process, when I was with her, is when I told her, you know, a lot of times when we try naturally to get pregnant, I feel like something's trying to take, but it doesn't seem to work out. And, you know, I read online myself, I did some reading about checking my uterus and abnormal cells. And when I discussed it with Dr. Beck, and I told her, you know, no one's ever checked my uterus before. Is there something further that we should be checking? She said, sure, I could T on you, which is an endometrial function test, and it'll biopsy, and we can send it out, and that'll give us a lot of answers. So once she did that, the answers came back, and the results were endometriosis. And she said at that point, this is 4 years, I guess, into the making now that we had been doing IVF, 3 to 4 years. And she said, you know, at this point, there's moving forward with IVF. There's nothing else. You need to have surgery and have this removed. And my biggest recommendation is that you go to Dr. Najat. He's the best. He's, you know, world known, and everybody goes to him, and he's wonderful. And I recommend that you go to him. And, you know, until you do this procedure, until you do this, you don't have a chance of getting pregnant, because not only does endometriosis implantation, but it can also cause you not to get genetically normal embryos, which that was also something that I didn't know and I wasn't aware of. But she also educated us on that, saying that, you know, this is also, it makes sense that we're not getting any genetically normal embryos, because if the endometriosis is pretty bad, we wouldn't be able to get embryos either. And when we came to you, you were very confident and pretty, confident that if I did the surgery, that, you know, afterwards, most likely our percentage of being able to get pregnant would be something around like 70%, I think you had said. Once you go in is when you'll really be able to notice, you know, how bad the endometriosis was. And I think after the surgery is when you came in and you told me, you know, you had no chance of being able to get pregnant on your own or through IVF, because I had endometriosis everywhere. Apparently I had it on my uterus, my ovaries, my rectum, my bladder. It was everywhere and not one symptom. So, and then after seeing Dr. Najat, after not the first month, but the second month, we got pregnant with her, and naturally, and it was like a miracle. I didn't believe it. When Dr. Najat told me, like, you know, after this, you can get pregnant on your own, I said, oh my God, after everything we've gone through, it can't be that easy. But, and Dr. Beck said to me, you know what, I don't recommend you doing IVF. You just had this surgery, you know, you're still healing from it. And, you know, the IVF and the hormones can bring back the endometriosis, you know, at some point. You've never tried, you know, naturally on a normal playing field. Now that we know we've resolved the issue, I think you should try on your own. And I was very skeptical of doing that because I have diabetes and I was a high risk patient. I'm now in my 40s. It's been a few years since we started. So there were a lot of, you know, things to take into consideration that I was very fearful of, but I figured, you know what, this is the only way to do it at this point. I came more IVF and I had done 10 rounds up until that point. And so we gave it a shot, and 2 months later, we were pregnant with Anaya. So, I mean, it was a long road, but thank God for Dr. Beck and thank God for Dr. Najat. I had heard about endometriosis. I had friends who had had it before, but I didn't really know what it was until it actually happened to me. And I think that educating people and letting them know that they cannot have symptoms or, you know, that there is even what endometriosis is and how it can affect your reproductive system. I don't think many people know about it. So I think doing this is very, very beneficial to people. And I can't thank Dr. Beck, Dr. Najat for their existence and for their knowledge and for being so amazing. I mean, if it wasn't for you guys, we would have never been here. So thank you for being such amazing doctors, because those are hard to find too these days. We owe it all to you.
Well, thank you very much, Roy. You are very kind to say that. But Dr. Beck, how do you feel about, in general, the patient with endometriosis? Is there anything, comments that you would like to give, the difference or the age difference of as the patient getting older? Do you have any specific recommendations for younger patients, female and also male, about freezing their eggs and sperm? How do you feel about that? Roya brought that up.
This is something where oftentimes when I suspect endo in younger women, because I have a lot of women who come in their 20s and 30s for egg freezing, when I have a younger woman and they have a lower number of eggs for their age, you typically see about 10 to 20 follicles on each side, or they have a very low AMH. So their AMH should be like 5 to 8 and it's less than 1. And they have really no other significant red flags. They don't have a history of smoking or vaping or have an autoimmune issue or had pelvic surgery or infections. One of the first things I try to rule out is endometriosis. And I look for any potential physical findings, whether their uterus is deviated to the right or the left, if there's thickening of their uterosacral ligaments. But when you have a young woman who comes in just for a fertility assessment and they have a lower number, I think that, and there's no other red flags, I always rule out endometriosis. So that's like one category of patients. And usually, they're asymptomatic. They came in for something elective. They're usually angry when I bring it up because they just want me to freeze their eggs, but they don't understand that, like, if you have endo and I freeze your eggs, it's not going to work. The eggs are not going to thaw well. You're going to go through the motions. It's not my recommendation. And can you find a doctor who'll freeze your eggs? Of course, you can go anywhere and they'll freeze your eggs. But you have to make sure, is it medically appropriate for you, and really make sure that you have the information so you can really make the appropriate choices for your fertility. That's one. The second is if you have a known uterine defect, like a congenital septum, or there's something abnormal about the uterus, 50% of those women have endometriosis. So I know right away it's something that I'm going to be looking for. If they have a hysterosalpingogram, which is one of the basic fertility evaluations where the radiologist assesses the uterus and the fallopian tubes, and it's really deviated to the right or the left, there's something going on. If they haven't had pelvic surgery to explain that type of deviation to the right or the left, you have to rule out endometriosis. But I have to say, in a case when you have a woman who is closer to 40 or over 40, who has done multiple IVF cycles, they haven't gotten normal embryos, then is it the first thing you're thinking about? No, you're trying to get them a normal embryo because you think, well, 10% of eggs are going to be genetically normal and you don't want them to lose that window. So would I tell them to do endosurgery first? Probably not, because I'd want to not have them lose that window for opportunity. And every time you do IVF, it can make endo worse. So you don't want to address the endo until you're done harvesting embryos. So I just want you to know, like, how I kind of look at different types of patients. But when I have a patient and we have normal embryos, one of the first things I would recommend is, if they've never had children before, making sure we've checked the uterus, that there isn't something on a microscopic level, even if they're completely asymptomatic, because I want to make sure that I've given that embryo every opportunity to be successful. And so in someone who's never had children, once I get normal embryos, I do the endometrial function test. I know there's other tests out there that are commercially available that are backed by Wall Street, but they're not really appropriate for someone who's never had children.
Thank you very much. This is very insightful and very informative, as and all research has shown that patients of yours, or a combination, some other REIs that we work with, and the majority of the couples, more than 90% of them that are trying to have children, all of their tests are normal. The husband test is normal, and they do not get pregnant. we have pathologically proven endometriosis. And all the data has been shown that endometriosis is poisonous to the egg, to the embryo, to the sperm, and also prevents implantation. And the success rate of results of these groups has been so high that I asked one of our fellows, Dr. Shruti Agrawal, to go and double check it, all the data of your patients and Dr. Sunny June and Dr. Tazuka and Dr. Amy Avazadeh, because these are the core groups of patients that we see a lot of their patients. And this has been proven and over. And is Dr. I think Dr. Shruti Agrawal, who is one of our second-year fellow, had a question in that regard, and she had those data. If Shruti is available and you want to ask Dr. Beck that question, Shruti, please go ahead.
Good morning, Dr. Beck. How are you?
Hi, good morning.
It's finally nice to meet you. We see so many of your patients. They speak so highly of you.
Oh, thanks. It's nice to meet you.
Nice to meet you. I think one of our patients is asking this question as well. Can you explain further? Like we have seen with research that endo does affect euploid embryos, and there, people who are harvesting these embryos, they can be abnormal if you have endometriosis. Can you delve on why that is? Why does endo cause that to happen?
Sure. So what endometriosis can do is it can age your ovaries more quickly. And by aging your ovaries more quickly, how does it affect the eggs? Well, it's a machinery of the egg that has to divide normally to get a normal or genetically normal embryo. So if that membrane of the egg is a little bit more fragile because you have an underlying inflammatory environment, which is caused by the endometriosis, that would affect it. Oftentimes, if I know someone has endometriosis, I always trigger ovulation smaller because I know that their eggs will mature potentially at a smaller age. Who matures smaller? Women who, as they start to get older, they'll mature smaller, or if they have endometriosis or any type of autoimmune issue, their eggs tends to be a little bit more fragile, they mature at a smaller size. And so when you do IVF, if you know someone has endometriosis, I always try to trigger at a smaller size so that the machinery of the egg will divide normally, and that's why. And so even if someone has endometriosis and they don't have a lot of follicles, first of all, usually I don't recommend they do egg freezing because I really worry that they're not going to freeze and thaw well, and I don't want to simply go through the motions of it. But if we're doing embryos, even in the scenario of an embryo and you do genetic testing, if someone has endo, people always want to do IVF first. But if we're doing harvesting for the future, I do recommend having the surgery first so that their eggs have a better chance of being normal, responding better to the medication, and so that we have a better chance of getting normal embryos.
Right. And that is the question with a lot of our patients who come to us with infertility, that they are always asking us, should I go ahead and harvest embryos or eggs, then go through surgery in case my ovaries get damaged? And I had looked at some research, and I actually ended up publishing it at ASRM. We looked at about 40 patients who all had endo on their pathology, and before surgery, they were all trying to conceive for about 29 months. And after surgery, they were all able to conceive within 4 months, and all 40 of them were able to get pregnant by embryo transfers, but they shortened that time after surgery. So absolutely.
But
I
the
totally
one
agree
caveat
with
of that is you have to make sure it's someone who doesn't have adenomyosis, which is endometriosis in the muscle. That you have to separate that category. And so that's one of the things that Dr. Najat will identify. There are times that when he does surgery, even in someone who's completely asymptomatic, if they have adenomyosis that's in the muscle, I do bring up surrogacy. It's not a fun topic. It's not patients are a little shocked, but if you have it, it's better than if they really want to have a genetic child. Those embryos are so precious. So I do want you to know that it's not always the case where if we have a normal embryo, we have surgery. There are times that we learn things intraoperatively that tell us you shouldn't carry a pregnancy. There was a very young woman in her early 30s, Dr. Najat may recall her, and she was asymptomatic. Her and her husband did not believe that they had any issues. When Dr. Najat went in, her entire pelvis was a concrete. And he actually called me to tell me, this is not correctable. I don't know if you recall, but you called me intraoperatively and said, this is not correctable. And we moved on to surrogacy, and they subsequently have 2 genetic children with surrogacy. But obviously this is an asymptomatic woman who is not expecting this, who went like not willingly for surgery, but then when we went in for surgery, she was so grateful that, you know, even Dr. Najat couldn't correct this. And so, you know, I do want you to know it's not always that we just tell people, oh, you're going to be able to carry pregnancies. But what we do learn intraoperatively with Dr. Najat is whether or not you can, and we're not going to waste an embryo. And then the other thing that I want to identify is that it's not simply having endosurgery. Who does your endosurgery, that they're doing an excision therapy, that they're trained in this, really makes a difference. My biggest concern is there's a lot of people who claim to be endosurgeons who unfortunately burn. And when they burn the eggs and they burn the endo, they're not excising and removing the endometriosis. They're not changing the environment. And usually when you burn the eggs, you're burning microscopic eggs. So you're usually putting women to menopause earlier. So I'm very careful. And so whenever patients are upset that I really only refer them to a couple of surgeons, there's a reason why. So I just want you to know, like, I want to make sure it's not just like telling everyone go get endosurgery, because I don't think that's the answer. It's who you do it with and making sure that it really fits along with where your fertility goals are.
Thank you very much.
Okay, thank you.
Dr. Beck and Dr. Agarwal. What we often forget is also the couple, the husbands, Scott and Zach here, they go through the process. But I'd like to ask a question about here. Hopefully Roya and Scott stay there. Carly, would you please tell your story and how you were able to achieve your goal and your journey with Dr. Beck and then coming to us in Northern California?
Yeah, I mean, ours started, we didn't know we had any problems with infertility. We just started talking. I was like in my, in my late 30s, and we were talking about having kids. We were getting married, and we were like, instead of just trying naturally, if we want to have 2 kids, maybe we should freeze eggs now before we get pregnant with our first, because we thought we'd have no problem. Like, we both are healthy, and we just, none of this crossed our mind at all. And it just never was a possibility in our minds. So we saw Dr. Beck just to freeze eggs and kind of just see what's going on in there, and just kind of casually going in. And then the adventure began, because we did freeze some, so we froze some embryos, and we got 2. And then we decided maybe we should do one more round, because in case, we need to use those and we wanted to have 2 kids, maybe we need to have more. So we did it, and we got 1 more. So we had 3 embryos, and we felt like we were, on a good path and kind of, ready to implant. And luckily, Dr. Beck is one of the most thorough doctors that I've ever met. It was frustrating along the way, because there is a lot of stuff that she wanted to check before we even tried naturally. Dr. Beck, I don't remember the name of the test that you had me go to that doctor where they go in to make sure your tubes are clear.
Right, the hysterosalpingogram.
Yes. So she wanted me to go do that. So I'm like, okay. So then I go do that test, and I'm thinking I'm going to pass everything, and comes back with that one that I have a polyp in my uterus. And so I have to get surgery for that, because if you have a polyp in your uterus, it's going to be really hard for the embryo, maybe impossible for the embryo to implant. And so we went to do that surgery, and there were 5 polyps in there when we actually went and got it done. And then after that, we're going like months, because it kind of felt like to me, it always felt like it was going to be this easy thing. And I thought I'd have a bunch of eggs and a bunch of embryos really easily. And everything was just way harder than I thought along the way. And I felt like I kept failing the tests that we would take, and so once we got the polyps out, then she wanted to do the EFT before we did any implantation. And so I was okay with that. And we did that test, and it came back that she suspected that I had endometriosis. And now, because we had done 2, freezings, it's been like a year. We've been trying naturally. She'd been along the way, helping us along with trying naturally with like releasing the egg at the time that we needed released. And every month we were negative. Every month we never got pregnant. And so we were starting to get worried that this process that we thought we'd have no problem with, all of a sudden we were like infertile, and our tests in every other way were coming back okay. But then when I had the polyps, and when she finally said I had possibly had endometriosis from the EFT test, I was one of those people that was frustrated. I was like, can't we just implant? I don't have any symptoms for endometriosis. Like, nobody's ever said I have endometriosis. Now, one thing, just an aside, that I have struggled with my whole life is food issues, or most of my adult life is food issues. And I had no idea that these two things could be connected. I was sensitive to a lot of foods, and it was getting worse through my IVF treatments. I was getting really bloated, and I was seeing this doctor that was doing all these tests and testing me with foods that I was sensitive to at the same time. And all of a sudden I was sensitive to like everything. And I was getting so frustrated because I didn't know, I just felt like my body was falling apart at this point, like I was failing all of these other tests, had polyps, had these surgeries, and then couldn't eat anything because everything I was reacting to. So when she said endometriosis and I started to look into it, and saw that that could possibly be something that is causing all of this, then I got a little bit more excited to meet Dr. Najat, because she said, you need to see Dr. Najat. And I saw that he was in Palo Alto, and I was like, I live in Los Angeles. There's not a doctor here that I can go see. Like, I have to fly up there. And she's like, this is who I would see. And when she said that, we really take that to heart. And I trust her. And so we flew up there to meet you. I don't think I've ever been so nervous. I don't know why, to meet a doctor, just because all of it was just unexpected. And I remember my like palms were sweaty. And then the second you walked in, Dr. Najat, I was immediately calm. And you just had a way of talking to me about endometriosis that I almost felt excited to get it done, as opposed to scared. When I was flying up there, I was really scared. And so I was so excited to because I talked to you about my food issues as well as the infertility, and the idea that this could possibly fix all of that was exciting to me, because it was something that I was struggling with, the infertility now for 1.5 years and the food stuff for years. So I booked the surgery as quickly as possible. I went to get the pre-op, which is about 2 weeks before your surgery. And even then, because I don't have any symptoms for endometriosis, my doctor told me, I think you're making a mistake. I don't think you have endometriosis. You don't have any of the symptoms. This is what I think you have. And he's, leaky gut or whatever else it could be. And he really was begging me not to get this surgery. And I said, I really trust the experts. Like, I was talking to experts in this subject, so I'm going to go do it. So I went up to get the surgery, and it turned out that I had it really bad. It was everywhere. It was in my colon, it was in my ovaries, it was in my bladder, where you also found a lesion. And so it was in my like back, it was everywhere. And so afterwards I felt immediately better. I mean, there's like a little bit of post-surgery pain, but it is, it's a fairly simple surgery as far as the way that you feel when you wake up. I was in like 3 days, I flew home and was feeling my bloating was gone. Like, my food issues were gone afterwards, which already immediately I felt so grateful, because that was something that I was dealing with for so long. And then we were supposed to go to Dr. Beck. This is March 2020. We had the surgery in January, and in March or early April, we were going to go in and do another EFT just to make sure that the endo was gone and that, it didn't start growing back by then. And then we were going to do implant one of the embryos. And obviously then the pandemic hit and everything shut down. And so we couldn't go in to get that done. And that month that we were scheduled to do the EFT that got canceled, we conceived Jack naturally. And we were like completely shocked, because we just didn't, with everything that we had been through up until then, I kind of at that point felt like my body just wasn't playing games. It was just like not playing with me. It was failing, it felt like. So for it to do it on its own felt like a miracle. I remember calling you, Dr. Beck, and being like, no. What? And then I came in and we did the pregnancy test there, and she's like, it's positive. It was just the craziest thing. And then afterwards, my food stuff was completely changed. Like, now I don't have all the food sensitivities. I don't have the bloating. So for me, this was life-changing, not only in conceiving my son, who's amazing, and not going through the infertility stuff anymore, but all the uncomfortability that I had with food stuff was gone. So it's completely life-changing. And I wanted to talk about this for a long time because of how life-changing it was for me. And because I didn't have, painful periods or a ton of bleeding, like I really didn't have anything. And any doctor that I talked to about it along the way really discouraged me from getting the surgery because of that. And so I'm just so grateful that I had such a thorough doctor and Dr. Beck having me do all those tests along the way, getting the polyps out. Like I just felt like this like newborn baby afterwards or something, like my body was working again how it was supposed to. And Dr. Najat, like going in there and making me feel so confident and sure that this was the right decision. And then doing such an amazing job of making, I really felt great almost immediately after the surgery. So I am forever grateful for you guys. And, now we have our son and we want to try for another later this year. And so it's just, I have nothing but amazing things to say about this whole process.
Carly, I'd like to thank you very, very much for your kindness to me and also I'm sure Dr. Beck. But what I want to make sure all of you around the world, the viewers, know that all the doctors are meaning well, they have good intention, and they like and they love their patient and they want to help their patient. But sometimes what the mind doesn't know, the eyes don't see. And what Carly is very smart about it, she found Dr. Beck, who is brilliant in her work, and she is the expert. And Carly listened to the expert in her area. And although other physicians may mean very well, they have good intentions, it might not be their finest moment of practice because that is not their area. So that is what I wanted to show. And also one area that it is important is the endometriosis that as Dr. Agrawal mentioned, many, and I think Roya was mentioning earlier that about 70% of the patient, it seems recently our data has shown that a lot of these patients, their chance of pregnancy is significantly even higher, but they have a lot of them go through IVF. I mean, especially if you are older, if your age group is higher, after about a period that we usually after surgery, perhaps 6 weeks, or every patient is different, they could go through the process of IVF, and the chance of success with IVF and implantation is significantly higher. And now Carly and Roya got pregnant spontaneously, and Dr. Beck recommended to them to wait. And during that period of wait, when you listen to your physician, but some cases they have to go ahead and proceed with IVF and the embryo transfer. That is important. And I wanted to see how Dr. Beck decides which patient do you recommend to them to try on their own, and which of them, Dr. Beck, you proceed and you transfer the embryos.
So if there is endometriosis or they have a uterine factor. So if there's a uterine factor, 100%, I'm going to have them try it on their own as long as the tubes are healthy and the sperm is normal. Because if there's a uterine factor, there was no way they could have gotten pregnant. So if you have polyps, or if you have a uterine septum or a fibroid in the uterus, this entire time they were trying, there was no way they would have conceived because there was no place to implant. But in anyone who, when I advise they consider trying to conceive on their own after surgery, I don't like rush people in, is I need to make sure that their tubes are healthy, they don't have endometriosis affecting their uterus, and the sperm is normal. Because 30 to 40% of fertility is male factor. So I'm not going to have someone try in vain if the sperm's not going to meet the egg.
Yeah, thank you very much. Again, this is very, very important that, when there is a combination factor of endometriosis and also male factor. That is why the rate of infertility increases. Sometimes the female partner has no endometriosis and the sperm count is a little bit low, she would get pregnant. Or sometimes both of them, they have a little bit of endometriosis and a little bit of sperm problem, then the infertility is exaggerated. So these are all factors that we evaluate, and the recommendations, it is Dr. Beck's recommendation. Our recommendation is individual. It is not a cookie cutter. Every patient is very differently. And one of our other fellows, Dr. Deborah Lee, she had a question and she wants to ask. And Deborah, go ahead and please ask Dr. Beck.
Yes, good morning. Dr. Beck, it's so nice to meet you. We've really been looking forward to this. So, and Carly and Roya, thank you so much for sharing your stories. Your children are beautiful.
Thank you.
So, Dr. Beck, we actually have a question from one of the participants in the chat, or one of the people here with us today. You mentioned about the EFT, and one of the things that we often hear from patients is, why didn't my OBGYN recommend this? Is this something that they can do? Or is this only something that Dr. Najat or Dr. Beck can do? Can you tell us a little bit more about how that process works?
Sure. So with the endometrial function test, as with any of the uterine biopsy tests, it's not something that most OBGYNs will be doing. And the reason for that is if you're doing the ERA, which is a different test called the endometrial receptivity assay, it's very time specific, where when you start the progesterone, you have to do the biopsy 120 hours later. And so with most OBGYNs, with the volume of patients that they have and the timing, it's not going to be accurate because they usually aren't able to do it at the right time. For the endometrial function test, I'm going to be honest, this is something that I've seen even other fertility specialists have reached out to me asking how to do it, because they still are confused of how to do it. And so it takes a little time, and you actually have to read and work with the doctors at Yale to figure it out. Because normally when we start progesterone suppositories, you normally start at 200 milligrams. And with the Yale protocol, it starts off at 25 milligrams, which is 1/8 the amount. And so you have to find a compounding pharmacy that can do this. And you also have to understand that we don't do blood work. The whole purpose of the endometrial function test is to know what's happening at the level of the uterine lining. It's microscopic. And so, because most doctors are so used to, if you read the textbook, you're going to do estrogen, progesterone levels, and they think that, oh, the levels are too low, I'm going to up it. And they don't follow the pattern that's recommended by the lab that created this test at Yale. The second thing that I'm really careful about just telling people to do with their gynecologist is that when I do the biopsy, I use a Pipel biopsy that's a straight plastic catheter that has no teeth on it. It can't cause damage. It can't cause scarring. And it's really how you do it. I go in with a full bladder. I do it under ultrasound guidance to make sure I'm getting the right tissue, because all tissue is pink. Because most doctors, when they do an endometrial biopsy, and you're usually doing it for cancer or irregular bleeding in a gynecologist's office, they will use a metal biopsy that can bend. You can get into the uterus easily, but it has teeth on it. And what's the downside of that? Well, if you have endometriosis, you have an inflammatory environment, and you have a biopsy with that, you may have had no uterine problem. And now, after this biopsy, you now have scarring inside the uterus called Asherman's, and you are now going to have a difficult time getting pregnant. So it's not something I encourage everyone to do, because if you do it just to go through doing the test, but it's not done appropriately, or you have, even in the best hands, it's how your body responds, because they used an instrument that can actually cause scarring. That's why I'm really hesitant to advise people to do this with a generalist or a fertility specialist who isn't familiar with it, because it can cause harm.
Thank you very much, Dr. Beck. There are a couple of some other questions from the audience that Dr. Agrawal and Dr. Lee are going to ask Dr. Beck. But one component of this infertility couple that often are ignored, or that they get less attention, is the journey of the husband or the partner. Scott and Zach, we'll start with Scott. Scott, how this process affected you, and how did you cope with it?
It was pretty, to watch your wife go through something that is so emotionally, physically, and mentally taxing on her. And for somebody who, being a mom was so important to her and was something that she was not going to get married until she wanted to be mother with. Watching her go through that and struggle with it was really, really difficult because you want to help and spend 3 years of unanswered questions. And, my wife went through over 18 months, 7 to 9 rounds of IVF, the hormone injections, the mental and emotional anguish that goes with that, the changes, hormones in her body was a struggle for all of us. And, and to watch her mentally break down towards the end. And I think that's what, the greatest gift was the pandemic happened. And we had to do, we had an abort one of the IVF cycles with Dr. Beck, and we almost got pregnant. She had all the signs, all the signs of implantation and everything that it says. And we were on day 27, day 28, and then, her period came. And we're like, okay. And that's when, Roya really sort of said something, and no one's listened to her. The previous place we were at, they didn't listen. They didn't, it was a factory, and Dr. Beck sort of really paid attention. And it was the first time that someone listened to her, got the diagnosis, even oh my God, we just go have it. It took us a few months to make the decision to come to, Stanford in the middle of the pandemic, to go up there and drive there. There's no planes. But it affected me, because as a husband, you want to be their support, and it's difficult to watch my wife to go through that. And it was very emotionally taxing.
He was a wonderful partner too, though, because for me, I mean, I don't know. I think for a lot of people who go through IVF, and I'm sure Carly can probably, vouch that, you emotionally, physically, mentally, spiritually, you kind of just break down, and we went through so many rounds of IVF because every single time we thought that this cycle was going to be the magic cycle. Everything is aligned, everything looks good. And we kept thinking, one more time, this is the magic cycle. Okay, one more time. And then we got to a certain point where I thought, I can't take this anymore. And that's when Dr. Beck said, you have to have surgery. And I thought to myself, after everything I've been through, now I have to go get invasive surgery, and there's and Scott was actually the one, I actually told Scott before we came down to see Dr. Najat, I said, I have a feeling that once we go down there, I'm not going to be able to go through with this. I don't think that I can do this anymore. And he said, okay, why don't we go? We'll go to Palo Alto. Let's go see Dr. Najat. If after him, you still think you don't want to do the surgery, you don't have to do it. So he was like, he was so supportive the entire time. I don't think I could have done it without him. And it definitely affected both of us, but I was lucky that I had such a wonderful partner. It was a very hard journey for us. But she's here and we're happy now.
Well, thank you very much, Scott, as well, and Roya and Anaya, for sharing your story. And I was wondering if Carly, if Zach is with you and he has any opinion, but that's very important.
Yeah. I knew absolutely nothing about this, as you can imagine. And I think my journey with it was one, it all started out with, what is this? What are we even talking about? Never heard of it before. And so I think that there was my first reaction was maybe one of I don't know if it was relief, maybe relief that like, oh, there's a thing that's preventing this from happening. So, okay, like identification, that's the first step. That was a really positive moment of like, okay, there's this thing. Now what do we do about it? So, I mean, beyond grateful for that day that Dr. Beck came to us and said, I'm seeing this thing and it's definitely worth getting checked out. I was nervous about, you know, Carly's my wife. I'm nervous about any surgery, anything going on with her body, I'm going to be nervous about. But going up to you, Dr. Najat, it literally took all of about 5 seconds.
That's what I was saying. We were nervous.
to have those nerves calm. You project an ease and a confidence about you, but not in a cocky way, not in a way that makes you go, oh wow, like this guy just thinks he's got some sort of God complex and is like, it didn't have any of those vibes whatsoever. And you even just sitting in your office and having you explain to us other alternatives, like, you know, the surgery is not it if you don't want to go that route. Just sitting in your office and having you explain the gamut of what our possibilities were was amazing. But again, it probably took all about 5 seconds after we walked out that door to go, oh, of course we're doing this. we're gonna end up doing this.
We booked it, I think, there when we were there. Yeah.
I think Zach and Carly, you guys are my PR agents. I mean, I have to tell you, you are very kind to say that. Thank you very much. But and you are very kind to say so. But it is interesting to see what you as a husband and wife, you guys, your story as and also Scott and Roya as a complex, as a unit, how this affects the scenario and the decision making of supporting your wives. That is so important, and that's what I thank you for sharing your story.
Yeah, of course. Thank you. I cannot. There isn't a day that goes by. I'm being completely honest. There isn't a day that goes by that I don't see Jack and think to myself, Dr. Bett and Dr. Najat. Like, thank God for them. It's true.
Well, that is the highest honor that a physician can receive. Yeah. So I was wondering if Dr. Beck has any comment essentially about the issues of their husbands, partners, and their support and how they affect the unit. I mean, what is your experience about supporting partners? Are there issues? And also, unfortunately, what Roya and also Carly specifically brought it up, because this is an area that you are ahead of the game of many other infertility specialists. And two issues you address, one of them is the denial of other specialists and conflicting data that the patient receive. And also, that's one area to see how you think it should be addressed, because what the mind doesn't know, the eyes don't see. And if you address that one, we would appreciate it, these two issues.
Right. I think that, bringing up the partner is a really big issue, especially during COVID when we're not allowing partners to come in. So this is like even worse right now because we don't allow partners to come in. It's our COVID protocol. And so I think people feel a little bit more separated. There's a lot more questions. And I think, when you're actually allowed to come into the office and you understand what's going on and you hear the information real time, it's a lot easier. So a lot of my patients are now FaceTiming their partners whenever we're in the office and doing ultrasounds. And I understand it's really hard. And one of the beauties of both Zach and Scott and, most partners who are in it, they really are protectors and they feel like, what can I do? They feel kind of helpless. And so I think that's that role that they have to really try to vet it. I think the biggest hindrance of this is what Carly mentioned, and I see it every day whenever I have to talk about endo and sending patients for surgery, is that other practitioners who aren't familiar with it really try to discourage my patients. And I just tell them, look, I am just trying to get you pregnant and optimize your cycle. I have no other reason to recommend the surgery. I'm an IVF doctor, and I would love to just do IVF and embryo transfers and not take a break and send you off for surgery. But when I'm recommending it, it's because I really think it's going to make a difference. So I do think that opportunities like this and educating is so important. One of the reasons I do Instagram is not because I need patients. It's because I feel like there's a lot of bad internet sites out there, a lot of misinformation on social media, and I'm really just trying to combat that. There's a lot of women, unfortunately, who can't afford fertility treatments or in small towns who don't have access to good care. And so, I really appreciate opportunities like this. But Dr. Najat, I think this is why educating and getting the information out there, even to general OBGYNs, internists, gastroenterologists, is really important. And that's really what I've been working on. But it goes slowly. Not everyone's ready to accept it.
Adding to Dr. Beck's point, when I told my gynecologist, that I've been going to forever, that I have endometriosis and that, this is why I can't get pregnant, he said, no, but you can get pregnant with endometriosis.
It doesn't cause infertility.
It doesn't cause infertility. And, for me, and the other fertility clinic also said the same thing, is that, but you can get pregnant with endo. It doesn't cause infertility. It doesn't, you can get normal embryos. And I think it's a, has to be reiterated over and over, because yes, you can. There's tons of people who are going through that are not, and it can also be a cause of infertility and why you're not getting pregnant. So, I heard that a number of times, but you could get with endo, and I'm like, yes, but if I could, I would have been pregnant. It is a factor here, which I think a lot of people are blind to that. I don't think that they know about it. Like I said, my own gynecologist said, no, that can't be, because you can get pregnant with endo. So it's kind of a battleground that we got here. Thanks to Dr. Najat and Dr. Beck. You guys really are amazing.
Thank you.
Well, I'd like to thank you very much. We have so many more interests and questions, but we are running out of time. I'd like to thank Dr. Kelly Beck, Scott, and Roya, and Anaya, Carly, Zach, and Jack for being so kind and spending the here in the West Coast the Saturday morning, and for all of you viewers around the world for supporting the efforts of Worldwide EndoMarch and raising awareness about endometriosis and helping patients, couples with endometriosis, their families, and as a result, the society. You have been wonderful in every aspect. These seminars, if you go to endomarch.org and touch the webinar session, you can follow the previous sessions, and also you can send your questions to us if you have anything you would like us to address, because practically we have addressed all the issues. We also have, as Dr. Beck said, Instagram and TikTok session that we are raising awareness exactly for what Dr. Beck said. There are a lot of misinformation, unfortunately, so we try to express and show real facts for the follow-up. And we thank also the organizers of EndoMarch, the Zoe Pennington, Barbara Page, and all the other staff, Melanie Salem, and also Genesis, for putting all these webinars. A lot of people are behind this, and we thank all of you, and we wish you, and of course, Dr. Beck and Dr. Agrawal, Dr. Tavalai, and Dr. Lee. And if I'm forgetting everybody, I apologize, and I wish you the most wonderful weekend.
Great. Thank you. Great. Thank you, everyone.